Good morning. I'm hoping that people can hear. We're so glad that you're joining us today, and we are going to get started in just a minute. All right. I've just been informed that I should begin my intro. So again, welcome everybody. We're really grateful that you're here today. I'm Jordan Karp. I'm the professor and chair for the Department of Psychiatry at the College of Medicine at the University of Arizona in Tucson. I'm also the clinical service chief for behavioral medicine for Banner University Medical Center and Group. We are really pleased that you've decided to spend 6 hours of a precious Saturday with us, and I promise you that this will be time well spent. Our planning committee selected topics and speakers that will keep your interest, improve your clinical skills, hopefully entertain you a bit, but most importantly, improve patient care. So let me share with you how this meeting came about. I'm a geriatric psychiatrist, and I've always enjoyed working at the intersection of psychiatry, medicine, and neurology, and serving as a consultant to primary care colleagues and educating them about the care of common psychiatric illnesses has really been at the center of my 21-year career. I moved to Tucson from Pittsburgh in September 2020, and one of the things that was most striking was the relative scarcity of psychiatrists, psychologists, and psychiatric nurse practitioners practicing in Tucson and Southern Arizona. However, I have to say that even though the Department of Psychiatry I came from at the University of Pittsburgh had 200 faculty and 25 geriatric psychiatrists on faculty, there was still a 4-month wait to get in to see any of the geriatric psychiatrists. And the operators at our large psychiatric hospital were encouraged to refer callers to the community because access to psychiatric care, again, even at our large hospital and tertiary care center, was so challenging. I'll say that this problem is really an international one that has been worsened by the last 2 years of the pandemic, which, according to the CDC, is still not over. So how do we respond to the clinical needs of so many patients and improve access? Well, we can, of course, train more psychiatric residents, psychology interns, psychiatric nurse practitioners, social workers, licensed professional counselors, and psychiatric pharmacists. And that is a laudable goal that we are certainly pursuing. But this takes time. So I'd like you to consider this. To train a psychiatric physician, they need to complete 4 years of medical school and then 4 years of residency, perhaps followed by another year of subspecialty training. We don't have time to wait for another 8 years. The other troubling fact to consider is that 60% of active psychiatrists are age 55 or older, and 46% are age 65 or older, and they are considering or are nearing retirement. Workforce projections show an estimated shortage of at least 21,000 psychiatrists nationwide by 2030, which is not that far off. Another solution is to train primary care providers in the assessment and care of common psychiatric conditions in the primary care setting. As you may know, many patients, especially depressed and anxious patients, receive psychiatric treatment from primary care physicians rather than from mental health specialists. And in general, PCPs are more likely to provide psychiatric care than refer their patients to mental health specialists. These trends demonstrate that the role of the primary care physician has expanded such that PCPs are also the primary psychiatric care physician for a considerable number of their patients. My brother, Michael, a family practice physician who is attending today's conference from Western Pennsylvania, once told me that 50% of his patients receive treatment for depression or anxiety, and that he considers prevention of these common conditions, in addition to preventing disrupted sleep, addiction, and unsafe behaviors related to psychiatric conditions, in the majority of his patients. That's why we thought a conference like this would be valuable to primary care providers to help increase confidence in providing high quality care. I want to acknowledge and thank the conference planning committee, all of whom are primary care physicians, except for Dr. Saira Kalia and myself, for their wisdom in guiding today's programming. I also want to offer or express tremendous gratitude to Banner University Health Plans and our good colleague and Chief Medical Officer for BUHP, Dr. Sandy Stein, for their generous support of today's CME eligible activity. BUHP operates as just one component of an integrated healthcare system that includes Banner University Medical Center Tucson campus and our South campus, as well as a comprehensive network of Banner Health primary care and specialty care providers. Their plans include a Medicaid program, long-term care system, and a dual eligible special needs plan for members with both Medicare and Medicaid. Again, thank you, BUHP, for your dedication to ensuring the people in our communities who are among the most vulnerable are insured and for your support of today's program. I have just a few housekeeping notes to share before we get started. First, please use the chat function when asking questions. I will be moderating the questions and asking our presenters just a couple of the questions that are posed. And this is because we're on a tight schedule with just 5 minutes for the question and answer sessions. So I encourage you to please stick around until the Ask an Expert session at 1:45 p.m. And any questions we don't get to during the course of the day, we'll try to tackle those then. We also ask that the chat feature be only used for questions to our speakers, or potentially for answering your colleagues' questions. As healers, we know how important it is to be kind and respectful. But to cover our bases, we do want to share that anyone who posts disruptive or disrespectful language in the chat will be removed from the webinar. With your registration, you received reminders from Eventbrite that included the conference learning objectives, the conflict of interest disclosures, and the link to fill out the evaluation survey. Jamie will also post the link to the evaluation survey toward the end of the day. Once you fill out the evaluation survey, you'll then receive the link to submit the request for your continuing education credits, and we will get those certificates to you towards the end of March, along with a link to the recording of the conference. Throughout the day, if you have any logistical questions, please reach out to Jamie Manser via email, and her email is jlmanser, it's JLMANSER @arizona.edu. So I want to thank you, everyone, once again for joining us. We will get started in just a few minutes, so grab another cup of caffeine or water, run to the restroom, silence your phones. We will see you back here in just a few minutes. Okay, well, I'm really pleased that we're getting started, and it's my honor to introduce our first speaker of the day, Dr. Olivia Okereke. Dr. Okereke is Director of the Geriatric Psychiatry Clinical and Research Program at the Department of Psychiatry at Massachusetts General Hospital. She's also Associate Professor of Psychiatry at Harvard Medical School and Associate Professor of Epidemiology at the Harvard T.H. Chan School of Public Health. Dr. Okereke is committed to research in late life mental health and well-being. Her programmatic research goals are to, 1, employ epidemiologic research methods to identify modifiable risk factors like diet and lifestyle that are involved in healthy mental aging, and 2, to translate these findings into novel, effective strategies for the prevention of anxiety, depression, and cognitive decline. Her program of research has been funded by numerous awards from the National Institutes of Health, Harvard Medical School, and research foundations. We're really lucky to have Dr. Okereke launch our day today, and I'd like to turn it over to her to begin her talk.
Thank you so much, Jordan, and thank you everyone for being here today. So these are my disclosures. And these are the topics we'll cover today. We'll talk about nosology of depression, risk factors, and epidemiology, some key aspects of how depression may present in older adults, and of course, treatment. We'll spend the bulk of the time on that. So it's important to debunk common myths about depression and aging. Specifically, often people think getting depressed is somehow a normal part of aging, and it is not. There are losses that accumulate as people get older, but there's nothing normal about being depressed. Also, depression can't be treated. That's similarly not true. There may be other comorbidities, even including dementia, but in all of these cases, depression can be treated effectively. And finally, sometimes there's a myth that older adults don't want treatments, but also this isn't true because many older adults simply need treatments explained the same way we'd explain treatment for diabetes or hypertension. And once it's explained and provided in a way that's understandable, people tend to accept these treatments. So the major clinical syndrome we see is major depressive disorder, which meets 5 or more of 9 criteria, one of which has to be depressed mood or loss of interest nearly all the day, every day for 2 weeks or longer. There's also dysthymia, in which depressive symptoms are present more often than not for a period of 2 weeks or longer. And there's other forms of depression along with bipolar disorder. But the predominant type of depression that you'll encounter in terms of clinical depression in primary care is major depressive disorder. But it's also important to recognize minor depression. So in this case, individuals may have the core features of depression, but not the full complement over 2 weeks or longer. And these subclinical or subsyndromal presentations of depression are important in older adults because it turns out that unlike with younger people, older adults who have subclinical and clinical depression may have equal likelihoods of having poor outcomes, functional outcomes, health impairments, increased hospital and doctors' visits, healthcare utilization, and costs. And so it's very important to realize that there can be quite a bit of morbidity associated with even subclinical depression in older adults. Key features to keep in mind with older adults also are the cognitive deficits. Memory issues, concentration, and decision-making problems will be more prominent. They'll often improve as people make efforts, so they're what we call effort dependent, but they can be quite prominent in older adults. There's also a relationship between depression and increased risk of dementia. Subsequently, in older adults, it's possible some depression in many cases can be a prodrome of what later declares itself as a dementia. In terms of specific features, in addition to sadness or anhedonia, loss of interest, older adults may be more likely to present in depression, having symptoms of anger, irritability, anxiety, or withdrawal. So there can be less subjective sadness in late life depression. Joe Gallo and colleagues call this depression without sadness. And it is true that for most depressions in older adults, the predominant mood actually is anhedonia rather than sadness or tearfulness. And anhedonia is that loss of interest or lack of enjoyment in things. There can also be a preoccupation with somatic symptoms to the point of a symptom replacement. So for example, rather than simply saying a person has lost their appetite, you might hear someone say that they can't eat or they can't keep food down. Psychotic symptoms increase in the proportion of depressions with age. These are symptoms of paranoia or delusions. And then also important presentations include a kind of failure to thrive. So if older adults get severely depressed, they may have declines in self-care, they may be more likely to fail to eat, lose weight, or develop severe functional impairments. And this can prompt a hospitalization by itself. And then vascular depression is important to know about. This may result from a history of strokes, either small lacunar or strategic strokes or larger strokes, or it could be an accumulation of vascular pathology, let's say from longstanding hypertension. There's also a bidirectionality to keep in mind here, as depression itself is an independent risk factor for stroke. And I cited a meta-analysis here from JAMA about 10 years ago that my colleagues and I did, really summarizing from dozens of publications illustrating this strong association. It may have to do with the fact that depression can worsen some of the vascular risk parameters. It also may have to do with some shared etiology, such as inflammation. Another useful thing to know about in the primary care setting is that depression can sometimes mimic or overlap with the symptoms of other disorders. So with apathy, which may present in certain types of neurologic or in a severe post-stroke syndrome, you can have blunted emotion and diminished interest in psychomotor retardation that looks a lot like depression, but may not be a depression. So those features that are sort of outside that Venn diagram overlap are useful. Dysphoria, sadness, reporting guilt or self-criticism, pessimism, hopelessness, those are tip-offs that there's more depression going on than an apathy syndrome following a brain injury. The overlap that can sometimes happen between depression and neurocognitive disorders is even trickier sometimes, as depression can sometimes be concurrent with or look like the prodrome to an incipient dementia. But there are some important things that can help distinguish, and I've highlighted a few. A short duration of substantial decline in cognitive function is unlikely to be explained by Alzheimer's disease, which tends to be more of a longer course and gradual. Individuals with depression may complain more of their memory frequently, whereas individuals with Alzheimer's may actually have variable complaints for even a lack of insight around them. Individuals with depression may not make an effort on tasks, but if you encourage them, their performance will improve, where this would not be the case for people with Alzheimer's disease. Similarly, people with depression may benefit from prompting, and their recognition memory tends to be intact, whereas no amount of prompting is going to help someone with a primary amnestic deficit, and also recognition will be impaired. So it's also important to keep in mind that for every level of comorbidity, depression is an amplifier on disabilities and costs. So for example, if you look across a range of levels of comorbidity, all other things being equal, the presence of depression in an older adult can add between 5 to 15,000 rather, extra costs, $5 to $15,000 extra costs over the course of a year. It also tends to reduce the effectiveness of the rehabilitation for many common comorbidities of aging. So for example, rehabilitation from stroke, cardiovascular disease, lung disease, exacerbations, or Parkinson's disease are impeded by comorbid depression. I've also mentioned here that depression is an important risk factor for suicide. Men age 75 plus have the highest rates of suicide of any demographic in the population. But I'll hold off on that because I know you will have a whole separate session on this from Dr. Van Orden. In terms of the prevalence of depression, it is common. Major depression current prevalence, or point prevalence, as we say, sort of cross-section of the population at any given time, maybe about 2 to 3% in older adults. But minor depression is much higher, on average around 10%. So if you look at any slice of the population, combine major and minor together, about 13% of the population is dealing with depression among older adults. The gender ratio is about 2 to 1 in favor of females, women. And that is true not only of older adults, but actually all age groups. The differences across racial ethnic minority groups is less clear. Earlier studies seem to suggest there may be no difference or perhaps even lower prevalence, lifetime prevalence among older persons of African descent. However, some more recent data by Barry, also work in my group that's been published in some recent years, show that actually, if you look at depression symptoms, the severity of symptoms, and the burden at the item level of depressive symptoms, actually racial ethnic minorities, particularly Black, Latino, and Asian adults, may show higher levels than non-Latino whites. And some of this may actually vary by United States region. We published some data showing that, for example, Latino older adults may have higher depressive symptom burden that's more exaggerated in the Midwest region of the country than in Northeast, for example. A lot of this data, of course, should be replicated, but it's interesting to be considering these potential additional variations. But critically important for the primary care providers yourself is that Black and Latino older adults have substantial disparities in diagnosis and treatment. They're significantly less likely to be diagnosed or treated for the depression. So if anything can come out of this session is that you will be very attuned to the importance of the underdetection and undertreatment of depression among minorities, and do everything in your power not to contribute to that. Risk factors are important to keep in mind for older adults. Dominantly, those risk factors related to physical functional issues, disability, mobility problems, medical comorbidities, sleep, and pain. These account for about 40 to 50% of incident caseness of depression in later life. Other risk factors include adverse health behaviors like heavy drinking and smoking, social isolation, and caregiver stress. By contrast, social networks, social support, all tend to reduce risk of depression, and physical activity and regular exercise tend to reduce risk. And dietary factors such as caffeine intake, Flavonoid-rich foods like berries, healthy diets may also tend to reduce risk. And we have to keep in mind that temporal factors are always in the mix. For example, the COVID-19 pandemic is a perfect example of a temporal factor that was associated with some, at least a transient increase in risk for older adults. Although in the long run, it turned out that younger people were more vulnerable to the risk of depression related to the pandemic. So I'd like to just take a moment to think about a case example. So I mentioned the physical comorbidities in their relation to depression, and this has some practical utility. For example, I was treating a patient in her late 80s who had late life depression, who responded very well to a SNRI, duloxetine, and had a remission of the depression. But in this context, it was very clear that the ongoing pain and degree of mobility limitation from a shoulder injury would set her up to have a much higher risk of relapse or recurrence of her depression. And so this resulted in my conferring with her primary care physician about re-referring her to have more persistent PT to address these issues. And in fact, it did make a difference in terms of her pain and range of motion. And in the subsequent years that I treated her until she passed away from natural causes, she never had a recurrence of her depression. So I hope attention to these issues helped. Now, psychotherapies are an important treatment to be aware of, although you may not primarily be referring patients for these. Cognitive behavioral therapy, interpersonal therapy, and problem-solving therapy are all evidence-based treatments for late life depression that can be highly effective. Combined treatment with these evidence-based therapies and medications can increase efficacy and also reduce the risk of relapse and recurrence. There are some important adaptations in geriatric psychotherapies that are often needed, such as for sensory or physical impairments or cognitive impairments in particular. And there's emerging work being done in these areas to address these types of adaptations for older adults. Somatic therapies are important to know about. Electroconvulsive therapy, or ECT, is still the single most effective antidepressant treatment, about 80% efficacy with this treatment. And it actually has a very good safety profile, which is important to know in terms of dispelling fear and stigma about the treatment. And it is often indicated by older age, as well as a history of a prior positive response to ECT, the presence of psychotic delusions, these sort of failure to thrive signs, malnutrition, dehydration, severe self-neglect. And in terms of the memory loss, which is something people are often concerned with, it's important to keep in mind that this is mostly a recent retrograde amnesia, so forgetfulness of about 2 to 3 months window before the start of treatment, rather than a remote memory loss and long-term issue. That tends to be quite unusual. And cognition for older adults may actually improve in many cases because of the fact that there's such a severe cognitive deficit associated with severe depression. So treating with ECT can actually improve the cognition in those cases. Repetitive transcranial magnetic stimulation, or RTMS, is an FDA-approved treatment. This is indicated for treatment-resistant depression. There's also emerging evidence suggesting its benefit for vascular depression. So this is a treatment, for example, I have used in the context of older adults who've had 3 or more antidepressant treatment failures. So I'd like to overview some broad issues in terms of geriatric psychopharmacology that are just kind of important to know in practice. Getting information about a current medication list, reconciling it is very important. You want to set expectations for people and provide education about how you're approaching things. It's important to look at any deprescribing that can be done, especially because it's really hard sometimes to know what to expect, as there's no drug-free baseline. So minimizing drugs, if that's possible, can always be an important thing to consider. With older adults, there could be some higher sensitivity to the side effects, more potential for interactions given polypharmacy, and you may observe a slightly longer time to treatment full response. Other considerations include barriers for adherence, particularly if there's cognitive issues. But then you also have to consider important pharmacokinetic and pharmacodynamic changes associated with aging that impact directly in antidepressant treatment. So I'm going to touch upon that now. With pharmacokinetics, we're concerned with how the body affects the antidepressant medications. So with aging, there is an overall slowed rate of absorption, but the extent tends to be unaffected. Distribution changes can have some direct effects. Increased fat stores in aging will result in drugs accumulating in fat stores and longer half-life. A decline in lean body mass is present. So for example, if a person gets intramuscular injections, it might be more painful due to decreased muscle mass. There's an increased volume of distribution for lipophilic drugs, and that means there's less drug in the systemic circulation immediately available. And there's declines in albumin levels, and that means more unbound drug that may reach the brain due to decreased albumin in some cases. With metabolism, the cytochrome P450, 1A2, and 304 are the most affected by aging. Phase 2 is less typically affected by aging itself. And then finally, with regard to elimination, it's important to keep in mind that this can affect the time to reach steady state and the time to drug elimination, and that will affect how quickly to titrate the drug. So altogether, these pharmacokinetic changes in aging are what underlie the mantra of starting low and going slow. With regard to pharmacodynamic changes, this is with regard to antidepressant medications' effects on the body in aging. So there are greater drug effects compared to younger people given the same doses, sensitivity to the drug, higher concentrations of brain receptors, and differences in initial levels that are observed. And in aging, there may be a decline in the ability to up or down regulate postsynaptic receptors. Anticholinergic effects are really important to keep in mind. Even though there tends to be lower levels of acetylcholinesterase activity, enzyme activity with aging, there's also an overall increased sensitivity to anticholinergic properties of drugs. Tricyclic antidepressants are anticholinergic. Even the SSRI paroxetine is weakly anticholinergic. So caution is particularly needed with those, given the risk of confusion from anticholinergic drugs. So overall, older adults are at higher risk of having pharmacodynamic drug-drug interactions due to polypharmacy. The consequences of this are general tips of starting low, going slow. Making one change at a time is very important because it is critical in terms of observing the effect of each drug. Reevaluating the need for whether the drug needs to remain, if it can be removed, addressing barriers to adherence, screening for potential interactions, and simplifying the regimen whenever possible. Once daily dosing is ideal. Imagine what it would look like for the patient to take this medicine. It may be something where just reducing it to daily would increase the compliance. Choosing dose strengths that are manageable. So think about the size of the pill or how easy it is to cut if people have to take half doses. And using liquid or sprinkle or capsule formulations that can be emptied can be great if needed. Capsules often they can't be cut, but they can be emptied into food. So I'm going to talk briefly about these treatments now. I do not expect you to memorize all the details on here. That's why you have the slides. But I'm going to highlight some important issues here. As I mentioned before, the tricyclic antidepressants you're unlikely to be prescribing as primary, given a range of potential side effects, the anticholinergic aspect, as well as the need for monitoring blood levels and toxicity in overdose, either intentional or inadvertent. But nortriptyline and diazepam have a profile of being somewhat less anticholinergic compared to other TCAs, and the dose ranges you can see there. The SSRIs, by and large, tend to be your go-to initial trials, but it's important to keep in mind some differences. Fluoxetine has an active norfluoxetine metabolite that can linger in the body for up to 6 weeks. So that has some implications in terms of changing drugs. Paroxetine, I mentioned, is weakly anticholinergic, so probably would not be the first one to go to for an older adult. With citalopram and escitalopram, these dose limits were adjusted because of the increased risk of QTC prolongation, especially with the higher doses of citalopram. So these ranges represent the most considered appropriate ranges of these drugs for older adults. There's some other classes to keep in mind. So the SNRIs, venlafaxine, duloxetine, these are increasingly used. With venlafaxine, so caution is needed about risk of increased blood pressure. And duloxetine has an advantage in terms of individuals who may have comorbid pain or pain conditions. It's important to keep in mind with SNRIs, however, that many people can experience a kind of withdrawal effect if they stop these, particularly if they don't have a long taper and removal from these drugs. So it's important to be cautious about that. With mirtazapine, sometimes some of the side effects of this drug can be used to advantage. Individuals with anorexia, loss of appetite, may benefit from the slight weight gain side effect. And also it tends to be most sedating at low doses. So starting a cautious initial dose of 7.5 may not only help with the depression, but improve sleep at night if sleep disturbance is part of the symptoms. Trazodone is less likely to be used as a monotherapy antidepressant, but it can, especially lower doses, be helpful as an adjunct for sleep or tension issues. Bupropion has a very different mechanism, has no serotonin component. It is an NDRI, or norepinephrine and dopamine reuptake inhibitor drug. But important considerations are that it is activating, and so it should be taken in the morning and avoided after 4 p.m. Some other agents to keep in mind, you would not be prescribing these primarily, but you may see some of your patients on them, and they're important to be aware of. The monoamine oxidase inhibitors are increasingly seldom used due to serious drug interactions, particularly with certain types of drugs or foods like wine and cheese. The psychostimulants can have some benefits in some populations, particularly depression that may be in the context of disorders that also involve components of apathy, certain types of dementia. For example, people may need a little bit of this push of a psychostimulant. So you may see some of your patients on these drugs. And those are just important to just keep in mind that that can add to the mix of the pharmaceuticals people are on. Augmentation strategies are important as well. So these may involve combining antidepressants, such as bupropion with an SSRI. There's also augmentation using buspirone, which helps with anxiety, but is a non-benzodiazepine, lithium and thyroxine. I had in one case, for example, a patient with late life depression, a nonagenarian patient with late life depression, extensive medical comorbidities from heart disease, lung disease, and cancer-related fatigue. And this patient really did benefit quite a bit from a very, very low dose of methylphenidate to address the residual symptoms of poor energy and sense of fatigue that did not resolve from his escitalopram treatment. Antipsychotics you will not be prescribing, I would not imagine, primarily. But again, you may see many of your patients on these. They are indicated as augmentation treatments in the case of major depression. Increasingly, these drugs do have some FDA, several of these do have an FDA indication for that purpose in the context of treating depressions. But important factors to keep in mind for your patients are that these drugs are associated with increased risks of dyslipidemias or metabolic disorders. So people getting monitoring for lipid and A1C is important. Also, there's a black box warning for individuals who have dementias. And QTC prolongation is also another potential risk. But generally, this is something that is managed in the context of a coordinated care or that may be observed when a patient has a specialty referral. To give you a sense, though, this is a range of the most commonly prescribed atypical antipsychotics you'll see, and it's just really important to observe here how low these dose ranges are for appropriate treatment of older adults. They won't look anything like what you would see for general adults. You really have to factor in with older adults how much more sensitive they may be to the extrapyramidal side effects and a whole range of side effects with these drugs, sedation, etc. And so starting at a very low dose and titrating up to an optimal dose that may be 50% of the dose that typically younger adults may use is quite often seen. So in terms of managing side effects, there's some general rules, keeping in mind, even though once a day dosing is simpler, it can be associated with higher peak levels. And the peaks are typically what's associated with side effects from some medications. So if there's no barriers to this, such as cognitive impairment, splitting the dose might be useful for reducing this type of side effect. Gastrointestinal side effects, dizziness, sedation, these are really common, especially with SSRIs. So sometimes individuals may prefer to take their medication dose at bedtime. Activating medicines like bupropion, as I mentioned, should be given in the morning. Tremor is another type of side effect that may be mitigated by use of dose splitting. And then sexual dysfunction is a very common side effect, especially with the SSRIs. Switching or augmenting with bupropion, actually, I have certainly found can be a way to mitigate some of this. In terms of teaching with medications, it's so important to be educating older adults throughout the process, allowing them to ask open-ended questions. There are no bad questions, and then using it as an opportunity to dispel myths or mitigate any misinformation people may have about psychiatric medications. Using target symptoms is critical. Identify what is the most impairing symptom to that patient, and then focus on that and tracking that over time. Educating family is important, and using them as an assist to keep track of medications and adherence is quite helpful. And then it's important, finally, for me to mention the Beers criteria. Many of you may know about these, but it's important to keep in mind the medications that should be avoided, ideally in older adults. So I talked about the anticholinergic medications. Some of the biggest offenders are the ones like antihistamines, diphenhydramine, that are given over the counter. So going through that list of medications and identifying if someone has a drug that's such and such PM, often that's a dead giveaway that there's some hidden diphenhydramine in there. The benzodiazepine and Z drugs can be associated with increased risk of confusion and falls. Many muscle relaxants are anticholinergic as well. And then it's important to be cautious about NSAIDs. Short-term use may be appropriate for a variety of reasons, but there is an increased risk profile of GI bleeding, especially when concurrently using SSRIs. Overall, it's best among older adults to avoid there being 3 or more CNS active drugs that are being used concurrently. This is in terms of reducing risk of confusion as well as falls. So individuals may be on antidepressants, but there may also be antipsychotics or benzodiazepines or opioids being used for pain. So as you survey that list of drugs, really keep in mind when people sort of reach that threshold of 3 or more CNS active drugs, and if it's time to start doing some deprescribing or strategic deprescribing. So I think I'm going to stop there because I want to make sure we leave plenty of time for questions, but thank you very much.
Thank you, Olivia. That was excellent. You covered a lot of ground in 25 minutes, so we're just terrific. I do have a question that came in. If geriatric or late life depression may present differently, how well do common scales like the PHQ-9, or the PHQ-2, which is so commonly used in primary care settings, perform with people who may have a different cognitive profile, especially in primary care? Would you suggest that people use the PHQ-9, or is there another way to serially measure depression?
What a great question. I love questions about measurement. The good news is that the PHQ-9 is fine for assessing depression. In fact, I use it both in clinical and in research contexts. Turns out the PHQ-9 has been extensively validated. Another really great aspect about the PHQ-9 is, unlike some other measurements, it actually has cross-cultural validity. So it's actually been validated for older adults across diverse backgrounds, which is very important measurement issue that sometimes you can have what's called a measurement invariance, where you have or a measurement bias, where a measure may not perform as well in certain groups as it does in others. The PHQ-9 seems to be all right. That said, there are some specialty scales. There's a Cornell scale. There's some other scales that are focused on depressive symptoms as they may present in older adults, maybe with a comorbid dementia. Or neurocognitive disorder. But by and large, a PHQ-9 is sufficient for assessment of older adults in primary care.
Thank you. And I imagine that you getting collateral history from families and also surveying how depression or psychiatric problems has affected function would be important to measure as you're determining the effects of treatments.
Yes, very important. And another thing that's really useful in the context of the PHQ-9, and my colleagues and I have some recent publications on this in the last year or two, is that you can actually look at the items that are reflected. So for some people, their depression may be more predominant with the sleep disturbance, concentration problems, the anhedonia or loss of interest. And it turns out, and this is an area that we intend to study more, there's some pretty substantial racial ethnic variation among senior citizens in terms of which of those symptoms will be endorsed as the lead symptom. Or so if you have comparable levels of severity, we see that the concentration disturbance was much more disturbing, twofold more so for older Asian adults compared to non-Hispanic whites. That symptoms of anhedonia and energy issues really impairing for Black and Latino older adults. So very interesting. So I think there's a lot of rich information that can be mined from the PHQ-9. So it's fortuitous that it's a validated scale.
Thank you. That's excellent. One of the other questions that came through, and this related to your excellent overview of pharmacokinetic changes in aging. This question was more older and younger patients are getting bariatric surgery, which can affect absorption of antidepressants. How does that affect your treatment planning? Do you not use XR or sustained release formulations, or do you have recommendations for the participants today about folks who have had bariatric surgery?
Oh, that's a really, really great question. I think in the context of where I've encountered this, it's been more in the context of just sort of recognizing that the profile of how a person may respond to the drug may change sort of pre and post. So just sort of recognizing that the landscape of how the person's going to respond to their medication is going to look a little different after their surgery versus before. In some cases, for a variety of reasons, the surgeons may actually be the ones dictating how which medications get stopped or reduced before the surgery. So you might be working in concert with that. But once people are post-surgical, I think it's really important on this sort of a case-by-case basis just to sort of monitor how the person is responding as the dose is being titrated, since it may look, you're very right, it may look different after they've had that type of a major operation, which has changed, the amount of fat stores they have. Or if they've changed a lot about other body composition issues, like maybe their lean body mass has changed as well, if they change their exercise habits after surgery. So there are a lot of things to keep in mind. So I agree, it's important to be mindful of that.
That's great. Thank you. I'm being mindful of the time, and we're going to move on. There's some excellent questions that are coming through. We are not ignoring them. We will do our best to answer them throughout the course of the day to the shared chat, and we'll also address them during the Ask the Expert this afternoon. So Dr. Okereke, again, thank you for joining us and presenting.
Thank you.
So let's see. So it's now my pleasure to introduce Dr. Kim Van Orden. Dr. Van Orden is Associate Professor in the Department of Psychiatry at the University of Rochester Medical Center, where she co-directs the Center for the Study and Prevention of Suicide at the University of Rochester. She is the principal investigator of the Helping Older People Engage Lab, which conducts clinical trials of suicide prevention interventions to promote social engagement and healthy aging. She also serves as co-director of the Center for Social Ties and Aging, which studies behavioral interventions to promote social well-being in dementia family caregivers. Her research has been funded by the National Institute of Mental Health, the National Institute on Aging, and the Center for Disease Control and Prevention. Dr. Van Orden maintains an active clinical practice providing evidence-based psychotherapy. She's a popular mentor to students and fellows, and she provides training and consultation in suicide risk assessment and intervention. Dr. Van Orden, we are honored to have you today, and I look forward to your talk.
Great. Thank you so much, Dr. Karp, and thank you to all of you for being here today. I'm going to talk to you today about suicide risk assessment and prevention in adults. And so what I hope that we can get to today is to cover three broad areas. The first, I'll touch a bit on the epidemiology of suicide, insofar as it can inform how you might understand and treat your patients, including kind of the most common risk factors. We'll also talk about best practices for suicide risk assessment, including essential components, and then we'll turn to risk management strategies, so how to keep your patients safe. And so starting with what we know about suicidal behavior. So there's a lot on this slide. I'll walk you through it. And what we're talking about here is how common suicide deaths are by age. And so what we see here are 10 leading causes of death. This is 2018 data, but the patterns remain with more recent years. And what you're seeing going from left to right are age groups. So very young people all the way up to older adults. And then what you're seeing as well is where suicide ranks in terms of leading causes of death. And so suicide is in the green box. And so you'll see that for starting at age 10 to 14, suicide is the second leading cause of death in young people. And so what this illustrates is that suicide is a very important issue for young people. The other thing, though, that I kind of want to take away from this slide is that suicide doesn't discriminate. It's a problem across the life course. And so what you see for adults in the middle years of life, they actually account for the greatest number of deaths. So 50% of suicide deaths occur in adults in the middle years of life. And so it's a problem for adults as well. And then in the next slide, we'll talk about the indicators of how this is a problem for older people. And so when we think about that, the other indicator we look at with suicide deaths are rates. And so that's adjusting for the size of the population. And we know when we focus on suicide deaths that men are more likely to die by suicide, but women are more likely to attempt but survive. And then what you see in the figure here on the right is what that's illustrating is this difference in sex, men and women. And so on the left, what you're seeing, those bars that are blue, light blue, are smaller, so lower rates. And then you can see how the rates are much higher for men on the right. Another key thing to keep in mind, though, is age. And so what you're seeing here, again, younger on the left, moving all the way up to older, 85 plus on the right, you're seeing increases in suicide rates by age. And in fact, the highest rate for suicide deaths, at least in the US, is older men who are white. So older white men have the highest rate of suicide deaths in our country. The other thing to keep in mind, though, when we look at a figure like this is cohort effects. So we've seen that with the baby boomer cohort and later, they're ushering in even higher rates of suicide deaths. So what we're going to see as these younger cohorts enter into higher risk periods, we may see more and more deaths by suicide. I wasn't able, because of time, to include all the complexities, including race and ethnicity. But one thing I do want to mention is that Native Americans have markedly elevated rates, especially in youth. And so I'll turn now to methods. And so in the US, suicide deaths are largely a problem of firearms. So most suicide deaths in our country are due to firearms. And this is true especially for men. You see 56% of men who died by suicide did so via firearm. And so firearm safety is a key risk management strategy that can be addressed in primary care. So there's a lot more data I could go through, and I'm only going to touch on this briefly. But what I want to highlight here is that suicide attempts, which is when someone attempts to take their life but fortunately lives, is much more common than suicide deaths. And you'll see that that's even much more common in younger people. So that's kind of what pops out on this graph. The age 18 to 25, you can see that suicide attempts are much more common in younger life. And then what we also see are suicidal thoughts. So suicidal thoughts are much more common than attempts. And you can see here kind of the range of distribution and how common this is, especially in young people. You can also see that there are differences in race and ethnicity, and a bit of a difference by gender. So one thing I do want to spend a bit more time on is just how important primary care is for suicide prevention. And so these are data from the Mental Health Research Network, which is a broad number of health systems that are able to look at suicide prevention in a nuanced way with enough patients to really give us useful information. And what we're looking at here is among patients who are in contact with the health system who died by suicide, how many were seen in a behavioral health setting, in the ED, and in primary care. So I want to start with the figure on the top right with the blue and the orange. And what you can see there, in the past year, the majority of individuals who died by suicide did not have a mental health visit. So 71% did not see a mental health provider. Emergency department visits below that, you can see again, the majority were not seen in the ED. But then flip to the left, we see primary care visits. And what you're seeing there is that the majority of individuals connected to health systems who die by suicide had a primary care visit in the year before their death. And so this is where the bulk of individuals who die by suicide are receiving care, which means we have a great opportunity to save lives and improve well-being by addressing suicide risk in primary care. So way too much on this slide for you to fully pull in. Instead, what I was kind of using this slide was for a heuristic value, which is that depression is not the only risk factor. So what you see here are results from a study by Matt Knock, and they're looking at the range of psychopathology and mental disorders that are linked to suicide deaths. And when you look at them individually, most mental disorders increase risk for suicide deaths. And so you see anxiety, mood, impulse control, substance use. But of course, when we look at that, a lot of that is driven by comorbidity. So when we adjust for other disorders, we do see that some, like generalized anxiety disorder, is not linked with suicide attempts. And that the one with the sort of biggest predictive value is depression. Another thing I want to highlight here, but not go into a lot of detail with, is the fact that there's a difference between that different predictors will predict whether someone has thoughts of suicide versus whether they will act on them. So an example would be the impulse control disorders down in the middle there. Those disorders, when they're present in someone who has thought of suicide, can be shown to predict an attempt. So there are different risk factors for having someone develop suicidal thinking versus among those with suicidal thoughts who might attempt. Now, not to say that you need to keep all of that in mind with all of your patients, but I do want to highlight there is a lot of complexity there. And as we come to it later in the talk, your goal when you're seeing your patients is not to predict if they're going to die, in part because it's not possible. Look at the complexity here, the low base rates of suicide deaths. The good news is that what we do is we treat these problems, and that's a key thing in preventing suicide deaths. But it is important to keep in mind that it's not just depression that is associated with suicide deaths. And so, kind of in a bit more of a useful framework and in thinking about it and how we can talk to our patients about it, why do people die by suicide? So it's not just psychopathology, though we do know that people who are suicidal do have increased rates of drug and alcohol problems, depression. We know that in younger people, impulsivity and aggression can predict suicide attempts, a family history. But it's also things like having a prior attempt, and then the psychosocial context, such as recent losses, setbacks, such as job loss, feeling hopeless, and social disconnection. And when someone feels hopeless about all of those things that are going on in their life, that's a key time when their risk may be elevated. I want to talk just briefly about suicide risk in older people, as working with older people is my passion. So we're going to talk about the full range of adults today. When we think about dimensions of risk in later life, it's when these different dimensions start to pile up that someone's at at greatest risk. And so for older people, it's this constellation of depression, of disability, of social disconnection, access to deadly means, and then also multiple comorbid diseases. And when those start to come together, we see an older person at greater risk. Those factors may look slightly different in younger people. We might emphasize, say, impulsivity in younger people, but the concept of how it's converging and it's the multiple accumulation of risk factors that leads to greater risk applies across the lifespan. So let's talk about assessment. So why do we use screening tools? So I already alluded to this. The goal is not to predict whether a patient sitting with you is going to die by suicide. Thankfully, suicide deaths are pretty rare. The base rate of that is low. And so the likelihood of being able to predict for a given patient who's sitting with us, if they're going to die, it's just not something we can do. Even our machine learning models can't do that. So instead, a suicide risk assessment, the goal is to figure out which actions to take. What are the most appropriate actions to take with that patient to keep them safe, while also honoring their autonomy. So we don't want to send all of our patients to the emergency department. That doesn't mean we don't want to take actions for all of our patients. So the thing to take away is that we want to take actions for all endorsement of suicidal thinking, but not the same actions for every type of endorsement. And so key components in a suicide risk assessment are these, in my view. One is we can't forget about the attitude that we take. So if we are stressed or worried about someone having suicidal thoughts, which is, of course, totally understandable, but if we're in that state, that gets communicated to the patient and they may feel less likely to be willing to talk with you about that. So our attitude and our comfort is really key. The other part, of course, is gathering information. And that's what we often think of when we think of suicide risk assessments. We think about questions. But what I want you to take away is that the questions we ask is one piece of this bigger picture of things to do. And so not only the questions we ask, but how we ask them. And then there's making sense of the information. So getting that information, and then what does it mean? Taking actions while we're meeting with the patient, but then really importantly, taking actions after the meeting with the patient, extending it, making that intervention continue. And the reason for that is that suicide risk is very dynamic. So someone may have thoughts that they wish they were dead today, but in a couple of days, that may increase to active thoughts of killing themselves. So it's a very dynamic state. And so to the extent that we can extend our interventions, maybe including the family, a follow-up call, is really useful in addressing suicide risk. So briefly, the evidence base for these actions. There's good news and bad news. The good news is that we can prevent suicide. Someone's death by suicide is in many, many, many cases not inevitable. There are things that we know that work. So let's start with the bottom bullet, things that we know work. Some medications, psychotherapies, collaborative care models for depression have been shown to reduce the severity or frequency of suicidal thoughts, and in some cases prevent non-lethal suicide attempts. That said, when we're talking about suicide deaths, there are no evidence-based assessment methods for suicide risk that have been shown to prevent suicidal behavior. Now, why am I telling you this? I'm telling you this because there is no perfect way to do it. I can't say, this is the way you should ask questions and this is going to work. I wish I could. So I want you to keep in mind that there is no clear, perfect way to do this. And that's why you may hear slightly different things from different people. The good news is that we're studying this. And so stay tuned and hopefully we'll be learning more and more. The other thing, though, is that asking about suicide is safe. You are not going to cause someone to attempt suicide by asking them. You won't put it in their mind. It typically makes people feel better. The other downer news that on this slide is that there have only been 3 randomized trials of interventions shown to prevent suicide deaths in the world ever. And so the thing there to keep in mind is that in part, it's not because we've done lots and lots of studies and they haven't worked. It's very challenging to show an effect on suicide deaths, given how thankfully uncommon it is. It's also very hard to study. So in part, the science is just really challenging to do. But we do know, interestingly, is that one of those trials is an intervention looking at carrying letters. And it's a very light touch intervention that following up with people saying we care about you does seem to be something that it has a pretty solid effect on preventing suicide deaths. So now that we've gotten that kind of dismal mood out of the way, let's talk about the stuff that does work. So definitions, what we want to keep in mind is that suicidal thinking isn't just one thing. It can be thought of as on a continuum. And so what we have here is the range from passive thoughts, meaning that someone's thinking that they wish they would die, but not necessarily thinking about taking action themselves. Whereas that's what active ideation is, thinking about how someone might, thinking that they want to kill themselves. But then those thoughts can get more and more specific. Someone may be starting to think about how, which is methods. They might start having some intent, meaning that they're kind of having an urge. They feel like they might act on the thoughts, all the way up to what we would classify as imminent risk, which is where someone is going to act on the thought. They have a method picked out, a specific plan, and a time and a place. And that's where we're talking hospitalization, where someone is not able to keep themselves safe. So those are the main kind of definitions to keep in mind. There are also different types of suicidal behavior. So there's an attempt where someone had intent to die and acted on it, but there are also other types, like an interrupted attempt, which is where someone gets close to doing something, but someone stops them. An aborted attempt is where someone gets very close, but then stops themselves. There's also preparatory behaviors, maybe collecting pills, writing a goodbye note. And then there's also non-suicidal self-injury, which is when someone harms themselves, but without the intent to die. That might be for emotion regulation purposes, for example. So these are all important indicators in that they indicate something that needs to be treated. That doesn't mean that all of these types of presentations mean that someone is going to die by suicide. So nitty gritty, what might you do in a primary care setting? So we've already talked about in our first talk about the PHQ-9. So we're going to pick up from that. So say you've done your PHQ-9 with the patient and they have endorsed thoughts that they'd be better off dead or hurting themselves in some way, at least one or more days in the last couple of weeks. So that's when you'd want to follow up, or you need to follow up. And so there's several ways to do that. Like I said, there isn't one perfect way to do this. So instead, I'll give you one that I think is very useful and routinized. So what you see there is the P4 screener for assessing suicide risk. And what's nice about that is that it links directly to the PHQ-9. And what you do there is if someone has endorsed that item 9, you have some follow-up questions. And it gives you as well some potential ways to think about that. So remember the questions and then what to do with it. So it gives you a sense of, okay, if you have a couple answers yes on this, the risk might be higher versus lower. And so when you've got someone who is saying that question 3, there's a big difference between having a thought and acting on it, that's getting at this idea of intent. And when someone has intent to act, and there's something that isn't going to keep them safe, that's where you'd be quite concerned about their safety and need to consider some emergency services. There are, of course, other ways to assess suicide risk. And if you were in a behavioral health setting, for example, you might use the Columbia Suicide Severity Rating Scale. What's useful about it, in my view at least, is that it gives very clear definitions of these different types of behaviors. It also gives you really good follow-up questions. So even if you don't want to administer this interview, it can be useful to look at if you want to learn a bit more about follow-up questions you might ask, because the group did a really good job of distilling the literature and coming up with really useful follow-up questions. There are also self-report versions of the scale that can be used. diagnosed. Another useful thing about this is it asks about worst points. So it asks about the lifetime of behavior. And that's useful because we know actually that someone's severity of suicidal thinking and acting at its worst point in their lifetime is actually more predictive of whether they'll die than what they might tell you in that moment. And that's because, as I said, suicidal risk is dynamic. It waxes and wanes. And so the moment in time in which you get someone is almost in some sense a bit arbitrary in terms of the whole picture of their life. And so the worst point tends to be very useful information to have. So tips for asking about this. This is not easy stuff to do. Thinking about someone thinking about wanting to kill themselves is scary, and it should be. If we're not scared, then we're probably not fully engaged. So makes sense to be scared, but it also makes sense for us to be courageous and to manage that fear. And so some ways to do that are to have some tips about ways to ask about it that work. And so these are from Sean Shea's book, which is a really lovely compilation of sort of clinical interviewing strategies. So gentle persistence. So if someone says to you, well, no, not really, that's a clue that there's probably something there. They don't just feel comfortable talking about it yet. Normalizing it, letting the person know that you feel comfortable hearing the answer, and then gentle assumptions. Those will not cause someone to come up with a new idea. It will, however, it gives them the message, I'm comfortable hearing more. So what other ways have you thought about killing yourself? And the reason you really need to do that is remember the importance of firearms. So if someone tells you they're thinking about taking pills, don't assume that that's the only method they've thought about. You would need to ask what other ways, and you might directly ask, do you have access to a firearm? Have you thought about that as a method of suicide? So suicide risk management. So asking questions is one part, but it's all in the service of taking actions to help your patient be safe and get to a path where their life feels more meaningful and they don't want to die by suicide. What I have here is my colleague, Tony Pisani, and his colleagues came up with a really elegant suicide risk assessment and management strategy. It's a bit more than we have time to go into today, but it is something that I wanted you to know about because it's a very useful framework, and it's something, if you want to learn more about suicide risk assessment, they have an elegant article, and I would highly recommend reading it. But what I want you to take away from here is the bigger picture of how asking questions, getting the clinical data, that's on the left of the slide, is in the service of the formulation, which is making sense of all of that data and then taking actions. The other key thing I want to point out here that this model does really well, I think, in managing suicide risk is addressing that fact that risk is dynamic. Remember that someone may have passive thoughts one day and then active thoughts the next. And so this model has clinicians address foreseeable changes. So assessing what might make things worse for a person. So if you know that someone is dealing with the stress of a divorce and there's something coming up and they might get news that their child is going to be taken away, and you know that that's coming up, that's a foreseeable change that you'd want to make contingencies for. And it might mean involving the family. It might mean having a care manager do a follow-up call. But the idea of addressing foreseeable changes is so important because risk isn't static. What you see in your office could change tomorrow. So, but in a more manageable framework that for what you might be able to do in a primary care visit. So risk management actions, a really key distinction, is it someone at imminent risk, or is this something that can be managed outpatient and helping them get to feeling better? Imminent risk means they have intent and a clear plan and a method. At that point, we can't leave the patient alone. You want to think about hospitalization, engage the family in planning. If someone has active suicidal thoughts, but they're not at imminent risk, meaning we can help them stay safe on an outpatient basis, there are some things to do. Safety planning, which we're going to turn to in just a minute, involving the support network, limiting access to means such as firearms, but any other means or methods they may be thinking about. If you can, increasing contact, making commitment through the crisis. So a depression care manager is a really important part. part here, someone who can follow up, be part of that patient's care throughout, and is able to contact them in between visits. Obviously, arranging for a mental health evaluation if possible, and assuring follow through. So safety planning, again, a lot on here, but what I want to just show you is that a safety plan isn't just one thing. There's lots of ways to do this. And what is safety planning? It's a brief clinical intervention that results in a priority written list of warning signs, of coping strategies, and resources. So safety planning is designed to empower patients, to help them and their family and friends be able to keep them safe while they get treatment that makes them want to keep living. So we know that often people have suicidal thoughts for a long time, but when they act on it, when it gets really bad, can happen very quickly. And so the idea of a safety plan is to have something in place to help someone stay safe, even if they may have suicidal thoughts for quite some time. And so the idea here, what's really important is that it's a process. This is not a worksheet that you hand someone, tell them to fill it out, and you'll be back. And that does happen. A safety plan will not be effective in that case. The idea is to have a conversation with someone. And when you do that, when you help them identify the red flags, personal coping strategies they can do, things they can do to take their mind off of it, social support resources, and then emergency folks to call. When you do that in a conversational way, that helps the patient feel motivated to use this strategy and want to do it. And we know that safety planning plus follow-ups is associated with reduced suicidal behavior over 6 months. It also helps people engage in mental health care. That said, you don't have to do it on this one worksheet. What I show on the bottom, you could put it on a card. I've done these with patients and put it on the back of a photograph so that they want to look at that photograph, and then they flip it over and the information's there. The other key thing to mention on this slide is that no suicide contracts do not work. Having someone say, "I will not kill myself," and sign it does not work. In fact, it may be iatrogenic. So we don't want to do suicide contracts. That's telling someone what not to do. We want to do a safety plan, which is helping them figure out what they can do to help themselves stay safe if they have a suicidal crisis. I have this up here because I think it's a great resource. Even if you're not working with older people, there's a free handout available online that my colleague Elizabeth Conti led that walks through how to do a collaborative safety planning, including with older people for whom some of this may be a bit more complicated. Say they've got some cognitive impairment going on, things like that. So they have some strategies for navigating that with older people. They also walk you through how this is not just a worksheet for the patient to fill out. It is a process. You introduce the purpose, you get some collaboration. Now, that doesn't mean this has to take forever. It doesn't. You could do this in 30, 45 minutes, but it is a process. So I highly recommend that as a resource. Safety plans can also do more than just have people list out things they can do, like call a friend. So what I have here, unfortunately doesn't have a citation, but thankfully it's my work, so I don't feel so bad about that. This is from a paper we wrote on how to do safety planning with older people in a way that it's not just a crisis strategy, but it's a way to treat suicide risk. So if you know the risk factors that a patient has that increases their suicide risk, say depression or feeling isolated, you can use that safety plan to help them take actions to reduce their suicide risk. So not just keep them safe, but actually start to reduce their risk over time. So someone for whom disconnectedness is a big feature might put on their safety plan reaching out. It could be even journaling, things that remind them of connections they have, things like that. So you can personalize a safety plan to a patient's personal risk factors for suicide in a way that can make it even more potent, more relevant, and potentially part of treatment. Okay, so we are getting to the end of our time, and thankfully I'm getting to the end of my slides. But another key part, obviously, for suicide risk is treating depression. Depression isn't the only risk factor, but addressing it and treating it is essential for someone who is suicidal and has depression. So we've just covered depression. I'm not going to go into that a lot. I will mention, though, that collaborative care for depression treatment has been shown to be useful in reducing suicidal ideation, especially when we have psychotherapy as part of it. We've mentioned safety planning. Caring contacts is following up, letting someone know that providers care. Addressing social determinants of health is a key part of reducing suicide risk because it helps people have reasons to live. Means safety, like addressing firearms, and then the National Suicide Prevention Lifeline is key. This is mentioning, again, the key part of firearm safety and how essential it is if someone has a firearm in the home to help them remove that, at least during a crisis. And then finally, I do have a set of resources for you that I think are especially useful to come back to. And then because I study social isolation and social connection, I do want folks to stay in touch. So I will stop there and see if we can take some questions.
Thank you, Kim. I think that really exemplifies what we're trying to do with today's meeting, is to help primary care providers feel more confident in managing and talking about some difficult things with their patients. So I think that was excellent. We're starting to get some questions in, and I have a question for you, because many primary care physicians are active advocates for firearm regulation. And I wonder, in countries that have passed laws to restrict access to firearms, like Australia, the UK, has there been a decrease in suicidal behaviors and completed suicide? That informs whether, PCPs want to continue to do that kind of advocacy here.
Absolutely. So the data looking at restricting means is fascinating, and it applies across different means as well. So not only firearms, but there's some really interesting studies looking at bridges. So for a long time, the Golden Gate Bridge did not have barriers because it doesn't look pretty. And people think, oh, well, they'll just go to the next bridge and jump. That doesn't happen. So when you put barriers up on bridges, that saves lives. People don't tend to, at least in the short term, replace methods. So it's not like if you take someone's gun away, they're going to necessarily use a different method. So we know that method restriction works. There's solid data for that. So absolutely, getting firearms out of the home is useful because we know that suicide crises tend to be time limited. We also know that people may have, it's very hard to die by suicide. People may have gained capability to act on a certain method that may not transfer to another. So we should absolutely keep advocating for that.
Thank you.
Yeah.
Looks like the first question we got is, how do you address suicidal ideation when the patient is experiencing overwhelming life challenges, like the ones we've seen during the pandemic with childcare, job losses, and other losses that cannot be ameliorated in the foreseeable future, and there's really limited services or support systems available? What do we do in these cases?
Yeah, it's such a tough situation when we know that hopelessness increases risk for suicide, yet things can be really challenging to change in the moment, and we ourselves can start to feel hopeless. Absolutely. And so, one thing I keep in mind is that even though some people may believe that suicide is rational, and I'm not here to argue either way, I am on the side of life because I have seen things change for people. We know that even in some of the most dismal circumstances, there are things we can do to take the edge off, and things we can do when we hang in there in the longer run that can help people have a life worth living. So even when we may not be able to fix the big stuff right away, during the pandemic, when I lived alone and, hadn't touched another human being in a year, there are things you can still do, right? That may feel hopeless, but I can go outside and stand, not right now, it's snowing, but if it was summer, I can stand in the grass and I can feel my feet in the grass. And there's something powerful about that. So even when we can't be with people, there are ways we can feel safe and secure. So there are almost always things we can do, even if they're small, to get people on a path to have a life worth living. That said, I do not think that psychotherapy and medications alone is going to address this. That's the idea of social determinants of health is huge. And so finding people helping people find a reason to want to live, not just keeping them from killing themselves, is essential. So I guess try to hang in there and hold the hope for a patient until they can find it themselves.
And I think this speaks to your recommendations to conversationally develop a safety plan, because it can break down some of these insurmountable seeming problems into more actionable bits. We have time for one more question. Often the only way we screen for suicide in primary care is with the PHQ-9, which is often only prompted if positive PHQ-2. Since depression isn't the only risk factor for suicide, do you recommend routine suicide screening in another way?
Oh, such an important question. And I will tell you that there is wide disagreement in the field about this. So I will give you my viewpoint in, I know, just a minute, and let you know that mine is not the only one. So we know that the U.S. Preventive Services Task Force does not recommend universal screening for suicide risk in all patients. Instead, only recommends it in the context of depression. So the reason for that is that it has not been shown to reduce suicide deaths when we do universal screening, in part because it's very hard to study. So my kind of takeaway is that we shouldn't assume that asking about suicide is necessarily going to be useful unless it's done in a way that is very compassionate. So if you have the time and the space and someone is talking about being distressed, absolutely ask. But if it's a question that gets thrown in at the beginning of a visit by a tech who says, are you thinking of killing yourself? Do you feel safe at home? Is that going to be useful? I doubt it. So instead, what I would recommend if we have limited resources is to make people's lives better. Address social determinants of health, ask about depression. All of those things will reduce suicide. And of course, if someone brings it up, absolutely dive in and address it. But that's a super good question. Follow people on Twitter and you'll hear that conversation all the time.
Okay. Thank you, Dr. Van Orden. That was just wonderful. We are at 9:56. We're going to take a 3-minute break so people can run to the bathroom, fill up their coffee cup, and please come back at 9:59. I'm going to introduce our keynote speaker then. All right, well, welcome back. So our keynote presentation today is being delivered by Dr. Susie Bertich, who is the clinical director of the Behavioral Sleep Medicine Program at Brigham and Women's Hospital. And she's also an assistant professor of medicine at Harvard Medical School. Dr. Bertich studies how to adapt sleep interventions for a variety of community and clinical populations and the impact of sleep disorders on pain and cardiometabolic health, for which she has won several awards. Dr. Bertich trained in internal medicine at Beth Israel Deaconess Medical Center. She completed a research fellowship and her master's in public health at Harvard, and she trained in sleep medicine at Brigham and Women's Hospital and Beth Israel Deaconess Medical Center in Boston. Dr. Bertich couldn't be here today because she is at the World Sleep Conference in Rome, Italy, but we have recorded her presentation and we're sharing it with you momentarily. Dr. Bertich graciously offers her email at the end of the presentation, so take note of any questions you have, and she encourages you to please email her with those. Other questions that arise, we can also try to address those during the Ask the Expert session this afternoon. So I'm going to turn it over to Barry, our biocom expert, to get Dr. Bertich's talk rolling.
Thank you, Dr. Karp, for inviting me to speak on the topic of pharmacological treatments of insomnia in primary care. I do have some conflicts of interest related to this talk. I serve as a consultant by Idorsia, and I will present any data when talking about this specific medication. So the learning objectives of the talk today is to have the viewers learn how to perform a diagnostic assessment of patients presenting with insomnia to make sure it's comprehensive, to summarize the current guidelines supporting both behavioral and pharmacological treatments of insomnia. And I want you to be able, after this talk, to really feel that in your clinic, to bring this information into your clinical setting and to use with your patients and maybe even your own sleep on how to develop and implement evidence-based treatment plans for chronic insomnia disorder. Before we dive into insomnia, I'm just first going to review what actually controls sleep. So like all species on the planet, humans have a biological need to sleep. And in our brain, we have these elaborate networks that actually control when we sleep, when we're either sleeping or awake. So two of the main processes that are thought to determine whether or not our brain is in a sleep mode or wake mode are going to be talked about early, because these are actually the key to treating insomnia, to understanding these basic physiologic principles. So the first main controller of sleep is something we call the homeostatic process, or the homeostatic sleep drive. And really simply, it is just how long you've been awake. So this is a basic pictorial. On the x-axis is plotting the hours over the day. So starting at 7 in the morning, 11 at night, and again, 7 in the morning. And the sleep drive is on the y-axis. And the higher we are up on the sleep axis, the more likely it is that we're going to be able to sleep. We'll fall asleep quicker, have a deeper sleep, and stay asleep for longer. So assuming we have a sufficient duration of sleep at night and good quality of sleep at 7 in the morning, our sleep homeostat is low. And throughout the day, it gets higher, higher, and higher. And then we hit the sleep period, the main sleep period, it resets and goes down over the course of the night and starts again the other day. The dashed line here just depicts, when you stay up later and later, the sleep drive goes up and up and up because you've been awake for longer, which often means it's much more easy to fall asleep the longer you're staying awake at night. The way I explain it to my patients, I describe it like a volume button. Early in the morning, after a good night's sleep, our volume dial is low, and throughout the course of the day, the volume goes all the way up. And we want them to try to get into bed and try to go for sleep when their homeostatic drive is high rather than low. This is the same reason why we generally recommend for patients who have difficulty sleeping at night, we recommend avoiding napping during the day, because when you nap during the day, the volume button turns back down. And by the time you get to your normal sleep period, you're down here, and we really want you to be up here for night. So working in concept with this homeostatic process is our underlying circadian process, or intrinsic 24-hour body clock that signals our brain when it's the nighttime period and when it's the wake time period. And ideally, we want these two processes aligned so that our biological night starts at the same time that our homeosleep process is aligned. And this right here is the basis of a lot of the very effective behavioral treatments of insomnia that we use as well. And these two factors, the homeostatic sleep process and the circadian system, are actually what inform part of the sleep-wake regulation. So as I said before, we have these neurocircuitry systems in our brain, with various types of neurotransmitters that are actually telling our brain when to be awake. And you see here the wake system, which is called the reticular activating system. And you can see there's several different nuclei and neurotransmitter involved, and they project from, all the way up into the cortex to signal wake. And on the flip side, we have the sleep systems that you see here with some key neurotransmitter. You can see there's the GABA receptor over here, the histamine receptor. And these two systems are thought to work. The theory is a flip-flop switch. So generally, our brain is either asleep and when our brain is awake. And this is actually controlled by some of those intrinsic biological processes we have in terms of how much sleep we're getting, how long we've been awake, but also our circadian system as well. These and many of the neurotransmitters you see on this slide are actually the targets of drug treatments as well. So some of them directly try to target the sleep system and enhance sleep, and some block the wake systems too. So it gives us a lot of targets for treatment that we work on as well. So getting back to the main part of the talk, now that we have a little bit of the neurobiology behind us, is insomnia disorder. And just to make sure I'm very clear about what this talk is on, I'm talking about insomnia disorder, which is actually also called chronic insomnia disorder, which has a distinct clinical diagnostic criteria that's either difficulty falling asleep, difficulty maintaining sleep, or early morning awakenings that occur at least 3 nights a week for at least 3 months and causes significant distress or impairment of functioning. An important clause at the bottom of these DSM-5 criteria is that a sleep problem cannot be, but these symptoms are not accounted for by another sleep disorder, a medical problem, or substance abuse or psychiatric condition. And this wording can sometimes be problematic. It doesn't mean that these other disorders can't exist. So certainly you can have depression and anxiety and still have insomnia disorder. You can have be in the menopausal transition, have a lot of hot flashes and still have insomnia disorder. And you can still have other sleep disorders, such as you can have sleep apnea and insomnia disorder. But part of what we try to do as diagnosticians is to really try to understand, are these coexisting or is one primary driving the other? And sometimes it's really hard to tell which is the chicken of the egg, particularly I think for the psychiatric conditions, but we often can treat both at the same time. There is an older school thinking that, you had to only treat the primary disorder to resolve the sleep symptoms, but that there's actually a lot of science to suggest that we should still target the insomnia in the setting of these other disorders. And for some disorders, specifically depression, if there's some evidence that if we treat the insomnia, we can improve depression symptoms. So I really say, in the cases of some of these, it's really less common that you only treat the primary symptom, and we can often treat the insomnia beyond that. So just to reiterate again, what insomnia is not. It's not sleep apnea. They're not circadian phase disorders, not restless leg syndrome, night terrors, other sleep problems. But all of these may present with insomnia symptoms. So again, a patient comes in and has insomnia symptoms, and part of the differential diagnosis to figure out, do they have another sleep disorder? Do they have another medical disorder, psychiatric disorder affecting this? Or do they have, chronic insomnia disorder? Similarly, things that insomnia is also not, things you ingest. So a lot of caffeine, other active medical disorders, asthma, GERD, heart failure, and psychiatric disorders. Again, often we can treat the insomnia even in the setting of these active mood disorders and medical disorders, but it's also important to have a broad differential diagnosis to make sure you're not missing something else. So a case, so this is a 27-year-old female presenting with difficulty falling asleep, has a history of hypertension, has a normal BMI, social history, they're self-employed at a desk job, 2 to 3 beers per night. The sleep history, they deny snoring or witness apneas, deny daytime sleepiness. Sorry, they are reporting daytime sleepiness with the recent car accident. There's no restless leg symptoms. For their bed timings, they report they get into bed at 11 o'clock or midnight, but it takes them 2 to 3 hours to fall asleep. Minimal middle of the night awakenings, they're only awake for 10 minutes at night, but they get out of bed at 6:30 a.m. with an alarm on work days, but on non-work days, they get up at 11 a.m. or later, or sometimes even the afternoon. They also report that they nap 50% of days for about 30 to 60 minutes. So what is the best next step for this patient? Take zolpidem later in the evening, evaluate for a possible circadian rhythm disorder, do a sleep study to evaluate for possible sleep apnea, or counsel on high-risk alcohol use. And again, this is the best next step. So before we get into answer, what else do you want to know about this person's insomnia? So the way we evaluate patients with insomnia is really about 95% of it is a thorough history, but includes a thorough sleep history, medical and psychiatric history, substance abuse. The physical exam is really focused on really if you're considering that there may be other medical problems going on, such as like hyperthyroidism, maybe heart failure, asthma, something like that. Ideally, you could get a sleep diary, which is sometimes challenging. In the primary care setting, in the office setting, sometimes wearable data, which we'll talk a little bit more about later, may be useful just to indicate the actual sleep timings that the person's reporting. A sleep study is rarely indicated, and actigraphy, which is another wearable, you see the tracing here, which is usually an accelerometer that tells us when the person's sleeping versus awake. Activity is really limited at this point for research purposes predominantly. Although certainly, as we all know, patients are using a lot of different types of wearable, and often they include information on sleep. But most of what we see in clinic this day, most of which could have started differential diagnosis, is really just with a thorough and detailed sleep history. So in getting back to this patient, essentially marked by prolonged sleep latency, the best next step is you're going to evaluate for a possible circadian rhythm disorder. So again, they're reporting it's taking a long time to fall asleep. So there's someone who, once they get into bed, can actually stay asleep for long periods of time and wake up. So by definition, this is not insomnia disorder. It's a circadian rhythm disorder. In this case, it's delayed sleep phase, which is marked by bed timings that are later than you would think. In the same time zone, it's sort of a form of chronic jet lag. There's also the opposite of advanced sleep phase, when we see people getting really sleepy earlier in the evening, around 5, 6 o'clock at night, and then they wake up 2, 3 in the morning, can't go to sleep, more commonly in older adults. So in another case, we have a 50-year-old woman who presents with middle of the night awakenings, often due to hot flashes. She feels worn out during the day. She has a history of hypothyroidism. She has an unhealthy BMI. She also denies snoring or apneas or restless legs symptoms. And then her sleep pattern, which is different to the previous patient, reports a bedtime of 10 p.m. at night. She's able to fall asleep quickly, but like many women in the menopausal transition, she has multiple awakenings of variable duration in the middle of the night. So she says she wakes up 3 to 5 times a night, from anywhere to 0 to 60 minutes. She gets out of bed to 6 or 7 a.m. And she reports that despite sort of this poor pattern of sleep, she's actually not sleepy during the daytime. And she not only doesn't have an opportunity to nap, she physically feels like she can't nap despite her poor sleep. So what is the best next step to treat her symptoms? Initiate zolpidem at 5 milligrams, initiate gabapentin 300 milligrams every night, referral for cognitive behavioral therapy for insomnia, initiate hormone replacement therapy, refer for sleep study testing. So again, this is the best next step. There's actually multiple choices that could be argued to be correct on this slide, but the point here is, if we're actually specifically treating her insomnia symptoms, I would argue the best next step for this patient is to refer for cognitive behavioral therapy for insomnia. Again, if we were treating other menopausal symptoms, we might use hormone replacement therapy or gabapentin, but cognitive behavioral therapy would be considered first line for her insomnia, given the data, which I won't go through in detail. But I just wanted to bring to point that there were, in 2016, the American College of Physicians updated their recommendation on the management of chronic insomnia disorder in adults, and came out, which was really a practice-altering recommendation for our field, recommending that all adults receive CBTI, or cognitive behavioral therapy for insomnia, as the initial treatment for chronic insomnia disorder. And this was a strong recommendation based on moderate quality evidence, when they reviewed all the randomized clinical trials to show that cognitive behavioral therapy for insomnia was an efficacious treatment of insomnia disorder, and is thought to have fewer side effects. So what is CBTI, for those of you who don't know? So generally, it's delivered as a multi-component strategy of 5 parts. So the first is healthy sleep practices education, or sleep hygiene, as some of you may have heard of. Sleep restriction therapy, stimulus control, cognitive therapy, relaxation therapy. And this is just the broad term that combines all these techniques. And essentially what these therapies are doing is to use behaviors to influence those involuntary physiologic processes we talked about before. And I don't expect, primary care doctors to be able to deliver CBTI, but since primary care doctors are actually really the first line providers of insomnia, they need to be able to counsel patients and educate them on what CBTI is, so that they can make successful referrals if that's what's going to be pursued. The data on single component strategy actually varies by use, but another important point is that the healthy sleep practices are actually ineffective as single therapies. So what do I mean by that? So when we think of these sleep hygiene behaviors, if we think of things that are helpful for sleep, daily routines, treating underlying medical problems, keeping a comfortable sleep environment, keeping the bedroom dark, cool, comfortable, and things that hurt sleep, like using personal electronic devices. It's not a mistake it's on there twice, because it's such a problem these days, and it keeps people awake at night. Plus the light also stimulates people at night. Drinking alcohol close to bedtime, drinking caffeine late in the day, nicotine are all things that hurt sleep. So all patients with insomnia need to know about these things, but sleep hygiene is necessary, but insufficient to treat insomnia disorder. So a lot of these behaviors will actually, like, they need to be reversed in order to stop perpetuating poor sleep. But in and of itself, the expectation that having perfect sleep hygiene will actually treat insomnia disorder is really low. Certainly there'll be some patients that help for it, and it could be more effective in patients in primary care who maybe have less problematic sleep problems. But in the recent clinical guidelines from the American Academy of Sleep Medicine, we recommended that clinicians not use sleep hygiene as a single component therapy just because the data does not support its use. The last few notes on behavioral strategies. CBTI is often misunderstood, and many providers assume that patients want a quick fix. They know everything there is to know about healthy sleep, and a lot of patients say, I don't need therapy, it's too hard, I've tried everything. But some of the qualitative research and different discrete choice experiments that have been done on insomnia is that often patients with insomnia have had insomnia for years. And so they're not usually in a rush to get treated. Again, there's a large variation in patients, and some patients definitely come in, they want that medication that night. But they often are interested in investing time and resources into getting better because it's affected them for so long. Plus, CBTI has very few side effects, and they don't really care why something works. They just want to know that it works. So it's something to keep in mind in terms of some of, I think, the assumptions sometimes we make providers about what patients may or may not want for the treatment. The major limitations of CBTI is that there's just not enough people, healthcare professionals who are trained to deliver it. So our field is really working on trying to make these therapies more available. So one therapy actually pictured here. So the FDA recently authorized a digital platform called Somrist when it was developed in research studies called Shut-Eye. It has many clinical trials supporting its use as an effective treatment for insomnia. And this is the picture here. It's a digital therapy. It's available by prescription as of last year, and they're starting to work with more insurance companies on getting more coverage for patients on it. So I think in several more years, it'll be more accessible again for patients who like or have access to digital therapies. There are other apps out there that work on sleep. They just don't have the data that Somrist or Shut-Eye has to support them because they haven't been through clinical trials. With that said, one that has been used in some pilot studies is much less expensive, developed by the Cleveland Clinic. That's called Go to Sleep, which actually was delivered for more of like a primary care setting by those patients. Again, it has much less data than Somrist does. So getting back to pharmacological therapies, so there's sort of this false dichotomy that there either needs to be behavioral treatments or pharmacological treatments. But in reality, patients can often have both. And there's actually data to support that medications don't impact the effects of cognitive behavioral therapy for insomnia. And patients actually seem to do equally well over the long term. And sometimes giving two different types of medication in sequence may actually help patients in the long term as well. For the purpose of this talk, I'm not going to go into the data on sequencing and timing. You'll just have to take my word that they're both equally efficacious choices. So in the same guideline I mentioned before, recommendation 2 as a second step was that they recommended clinicians use a shared decision-making approach, including the discussion of benefits, harms, and costs of short-term use of medications to decide whether to add pharmacological therapy in adults with chronic insomnia disorder who either is unsuccessful or obviously don't have access to it. And I think they probably needed to add also who may not be interested, which we'll talk about more. So pharmacological treatments got sort of demoted to the second line therapy, but I think any of us working in clinical practice know that these pharmacological strategies are still much more commonly used, and that's not even counting all the over-the-counter medications patients are taking on their own before they even talk to a doctor about it. So switching to really pharmacological strategies, because I think this is a challenge, because I get asked a lot by a lot of providers, well, what do you recommend to treat insomnia? And unfortunately, we don't have anything that's the equivalent of like the JNC 8 guidelines, where if you have a patient with hypertension, you sort of have this nice algorithm based on different factors. What are your first line, second line agents? What combination therapies to use? We just don't have that data. We have very few comparative effectiveness studies done. what we have is sort of a series of, data on medications from several different classes. And, the starting basis of knowledge to make it to this decision, I think, is to make sure you understand, what are the different classes of medication available? What is the evidence about these classes? And how might I use, when would I consider different classes for different patients? So hopefully by the end of this talk, you'll feel more comfortable making evidence-informed decisions about prescribing pharmacological medications for insomnia. So broadly, and we'll get into each of these categories. There's the benzodiazepine receptor agonist, and this is I'm just putting together the traditional non-selective benzodiazepines with the newer selective non-benzodiazepine receptors. It's a mouthful, but these are your Z meds, like your Zolpidem or Ambien is the brand name for it. Melatonin agonists, orexin antagonists, sedating antidepressants, antipsychotics, which I won't really spend time going into because there's so little evidence on this, but this is where Seroquel would fall in. Anticonvulsants such as gabapentin. Again, I won't talk about these either just because there's very limited data for it. But again, this might be reasonable in a patient with chronic pain or certainly with restless leg syndrome or hot flashes, as we talked about already. And then over-the-counter agents, just sort of generally non-selective antihistamine. So again, these are the 7 main categories of medications that are either FDA approved or just commonly used off-label for treating insomnia. So in 2017, the American Academy of Sleep Medicine updated their clinical practice guideline for pharmacological treatment of chronic insomnia disorder. So all of these medications actually came out with weak evidence for. There were no strong recommendations based on the grade system that they used for these medications. So again, it includes a lot of the benzodiazepine receptor agonists. So temazepam, triazepam, zolpidem, Xalapon, and azoplacone are all in that first class I talked about of benzodiazepine receptor agonists. They differ slightly by pharmacologic principles, with temazepam and triazepam being the non-selective ones that actually differ dramatically on half-life, which is a key thing to think about when prescribing, which I'll talk about later. And then we have suvorexant, which is the first in class of the dual orexin receptor antagonists. Doxepin, which is the only FDA-approved non-sedating antidepressant, and Ramelteon, which is the only FDA-approved melatonin agonist specific. So it works on the melatonin receptor. So these are, they did a systematic review of the randomized trials, and these were weak evidence for. I think and there's really no surprises there. Where I think there are surprises are what they came out against. So the first being trazodone, which we know is the first or really the second most commonly prescribed medication for insomnia, despite it being off-label. And that was because of limited randomized controlled trial data for chronic insomnia disorder, where they also did see potentially a harm signal. There's a subsequent systematic review where they looked at all studies that used trazodone. That was also fairly negative in terms of extremely modest effects for trazodone. Similar here, you said diphenhydramine, which is really the ingredient of most of the over-counter medications. It's as an antihistamine for insomnia. Again, very limited clinical trial data supporting its use for insomnia. Melatonin, there actually is some more data for melatonin. It's actually just not really effective for insomnia disorder because insomnia is not really a circadian rhythm disorder. Some patients who present with insomnia have a circadian rhythm disorder, and sometimes it's very hard to tell. But again, as I mentioned before, that's why we really limit its use to circadian rhythm disorders rather than in patients with chronic insomnia disorder, and then some other dietary supplements. Valerian's actually been used in several studies, and also again has modest effects that fell below what they determined a priori to be clinically meaningful thresholds. So again, I think more of the surprises are what the evidence did not support rather than what it supported, because most of these medications were FDA approved, so they obviously needed at least 2 pivotal trials. So this is where I think it's really hard. It's really, I have nothing beyond to say that, treating insomnia can have a lot of dissatisfaction because if you look at the list, there are no perfect options. We know any medication that's given to a patient that helps them to sleep is going to have some side effects, just because at the bare minimum, there's going to be a risk for somnolence. Benzodiazepine, I think the side effects are well known. We know, and this is again the class in general, not just the non-selective ones, but the selective ones as well. They increase risk of motor vehicle accidents, hip fractures. They may cause some anterior great amnesia. In the more recent Z-meds, there's no evidence of tolerance, but we know people often rely on them to sleep for long periods of times. And obviously there's like a physiologic tolerance of the non-selective benzodiazepines. And the Z-meds also received a recent black box warning for increased risks of falls and sleep-related behaviors, such as sleep driving, in things like that resulted in death. So there's a black box warning on these medications for insomnia. They're very effective, and they're actually very effective, by helping people get to sleep faster, get to sleep longer. But again, there's this clear demonstrated risk of the medication. And I think this is coming out, making providers aware. There was a recent study that came out in JAMA at the end of last year that looked at a large database of health records and found that from 2011 to 2018, that zolpidem, which is the number one prescribed medication for insomnia, the rates have been decreasing over the last 7 years, up to a decade now, down from about 4.5% to 2% of all 2% of prescriptions, or percent of people, in the data set. Whereas trazodone, increased, although not to the same extent, but increased slightly. So again, these are the most commonly used medications, and I think the word is getting out there, which then a lot of questions I get around, I don't want to prescribe zolpidem or other medications, because of the known risks, what do I prescribe? So one option, although I don't think this is a great option, is Ramelteon. This is the data from a systematic review of Ramelteon, that it's only approved for the treatment of sleep onset insomnia. It has no effect for sleep maintenance. And if you actually look in this meta-analysis, this is actually the result of the meta-analysis. So it helped people fall asleep faster for about 9 minutes, which is not a lot of. It's not a long. Which is not a substantial benefit. So again, it's used modestly and sparingly. Sometimes I prescribe it just in order to check it off the box as a requirement to get them something that might require a prior authorization, but it can be something to try in patients with a history of substance abuse or can't take benzos, and also older patients as well, because it does have a more sort of gentle effect, and it may actually help some patients, but again, overall has a modest effect. The sedating antidepressants are also very commonly used for insomnia. As I mentioned already, that doxepin is the only one approved, and it's specifically approved in 3 to 6 milligram capsules. This was sort of developed as a designer med called Silenor, but it is available in 10 milligram capsules, or you can get it available as a liquid, so you can actually get an equivalent dose amount in this range. It's particularly good for middle of the night insomnia. Doxepin is FDA approved for sleep maintenance insomnia. So it's reasonable to try. It's thought to only have antihistaminergic effects at these low dose, but the anticholinergic effects coming up at higher levels. So, especially in older adults, we're always worried about those anticholinergic side effects, especially long-term. That's one of the limitations of the over-the-counter antihistamine, and also concerns about long-term cognitive effects. Mirtazapine, or Remeron is otherwise called, is also used for insomnia. And again, I've already talked about trazodone, which is a mixed receptor that falls within this broad category. So as you're going through the list in your head, when you think about sedating antidepressants, these are the ones you could consider using. And some may work better than others for other patients, but no, there's really only one that has data to support it. Again, one nice thing about the generic doxepin is that it is theoretically supposed to be better for early morning awakenings. It also generally requires no prior approval form, and it's non-scheduled, so it has little abuse potential. So it actually makes it a fairly good, potentially first-line option. The newest class of medications used for insomnia, as I mentioned before, these are orexin antagonists. So suvorexant was the first that was approved, followed by lemborexant that was approved at the end of last year, and divarexant, which was actually just approved within the last month. These work specifically on the orexin neurons. So what they do is orexin is a neurotransmitter that sort of stabilizes the wake setting. So it actually works on that flip-flop switch and helps to promote wakefulness. So these essentially block different orexin receptors to make patients more sleepy. So that's the underlying neurobiological basis of this class of medications, and how they're thought to work. So suvorexant again was the first in class. There's there's a great article in the New Yorker about its development. And then the pivotal studies were from 2 large randomized controlled trials. They initially tested it in 15 and 20 milligram dose, the lower dose in older patients, and 30 and 40. Ultimately, the FDA only approved the 10 and 20 milligram dose that's available. They didn't approve the larger dose. But this is general data for those trials. This is latent to persistent sleep. It's similar to how long it takes patients to fall asleep. And you can see here across the range of doses, again, similar to Ramelteon, it's effective, but modestly so is actually pretty negative in some of the studies. But where the orexin antagonists work much better are wake after sleep onset. So this is actually wakefulness in the middle of the night. Here the effect was 15 to 30 minutes overnight, which is actually similar to the benzodiazepine receptor antagonist in terms of sleep maintenance. Where they differ from the benzodiazepines is that these agents, at least for suvorexant, lemborexant, the data looked a little different, as the patient's perception of wakefulness was still higher. So when you give patients the benzodiazepines to help with sleep, they sleep. They have less wakefulness in the middle of the night. They also report less wakefulness in the middle of the night. With these agents, they actually sleep. They actually wake up less in the middle of the night. But on diaries, they're still reporting waking up in the middle of the night more. So they may wake up or go back to sleep faster, or there's something about the benzodiazepine and amnesia and recall. We're not actually sure why the differences are occurring. Again, less of a difference with the newer lemborexant, but it's just something to keep in mind. With that said, suvorexant, even though this data was underwhelming, it was still approved for the sleep onset as well as sleep maintenance insomnia, and recently had a label update where it's actually approved in patients with mild to moderate Alzheimer's disease. So again, thought to be useful even in older patients, but again, still have risks of some somnolence, although less so than the benzodiazepines in some really other side effects related thought to the mechanism of action in orexin, and start actually acting out like behaviors we see in narcolepsy, like cataplexy, or other things such as complex behaviors during sleep, although those actually during the trials were really not that common. So really somnolence is the main side effect. And again, with the newer agents, may have less somnolence than the original suvorexant. So that's sort of, these are the newest agents on DORA, maybe the ones that you're least familiar with. So I want to spend a little bit of time on those because I think those will be more emerging over the years. And again, not thought to be drugs of abuse or potential. It's another option for patients who can't take benzodiazepines. With that said, all of these classes of medication, again, I didn't get into the atypical antipsychotics, of which, Seroquel is usually the most common ones. And again, this includes diphenhydramine, but this was a study that came out last year looking at hospitalized patients and risk of falls, and looked at time to fall in the hospital. So it's actually falling in the hospital. And actually you could see across all classes of medications, especially the benzodiazepines, no matter which ones in the antipolar antipsychotics, they had higher risk of falls, but even in trazodone and diphenhydramine, there was still an increased risk of falls. But again, as I sort of mentioned before, every sleep medication does have some side effects by the nature of it. And our job, I think, is to really, to treat the patients and minimize these side effects as well. So the rest of the talk, that's all, I think, all the data I'm presenting in the talk. So the rest is actually, how do we think about, treating patients with insomnia, given all these options and obviously the known limitations of these options. So the approach I really try to use with my patients is I try to use a shared decision-making approach. And what shared decision-making is, it's an interactive process between patients and clinicians and engages patients in their decision-making. The role of the providers to give them accurate information about different treatment options and outcomes, and to tailor the treatments to the patient's goals and concerns. So ideally, that the clinician and patients are bringing things. So the clinicians are bringing expertise in communicating and tailoring evidence to patients. The medical evidence, again, provided, clearly describes, what treatments are available, how effective are they, what are the risks and benefits of these treatment options. And then the patients are bringing their own values, goals, and preferences and concerns about the treatments. And that's how we actually make the treatment decision. So again, we mentioned this a little bit when we talked about, we assume patients don't want behavioral therapy. We know some patients won't want to do behavioral therapy. So it's important to decide, which one am I going to use first line. So the first step is really to provide information on the risks and benefits, then to elicit preferences, and then to assist the patient with implementation. So these are, sort of the 5 steps outlined in this shared approach that's out there. So, but it's engaging the patients, seeking their participation, helping them explore their treatment options. So again, talking about behavioral pharmacologic therapies, or maybe even considering, eliciting concerns they may have specifically about some medications they have, assessing their values and preferences, reaching a decision, and helping them evaluate how they feel about the decision. Again, all of this needs to be in the framework that the treatment needs to be acceptable to them, because they need to either do the therapy for the adoption, particularly, the medical treatments. I don't need therapy, my meds are working, I've tried everything. And then some people say medications don't work for me and actually want the exact opposite. I see plenty of patients who don't want to take any medications for sleep. And patients, you also need to counsel patients on what's feasible for them. So, the timing of treatments, the cost, what are their comorbidities in terms of what options are available, what are their attitudes, are there cultural language barriers? Again, that usually is for behavioral strategies as well, but it's important to keep in mind. So in thinking more specifically about pharmacological therapies, I often tell my patients by the time they come to sleep clinic, I don't have anything up my sleeves. I don't have any special sleep medications available to me that primary care doctors don't have. And I just try to be really realistic with them about what we have and what we know and how we work, and what the concerns are that we have with some of the medication. So in thinking about, if you think through those classes of medication, like how do we decide which medications of therapy do we use? And I always feel like these talks are a little bit, must be dissatisfying to the listeners, because I don't have any, one secret answer. I said, treat all patients first line with insomnia with this, because every treatment is different in terms of their goals, their symptoms, what bothers them, what are their actually risks? Are they older? Do they have a substance abuse history? Do they have other comorbidities we need to think about treating, like pain? What are the costs? Some of the newer medications may be great, but you can't get them, or the patient can't afford copay. And what are the perceptions? And this includes sometimes stigmas about either behavioral therapies or even a stigma regarding taking medications for their sleep. And also in terms of history, it's also a history of what they've tried before, what medications that they've been tried, including, over-the-counter medications. Are they using alcohol to try? And even history of other types of behavioral processes. And thinking about the different characteristic medications, a key thing to think about is termed as the pharmacokinetics. How long does it take for the medication to get into the blood and start working in terms of getting patients sleepy and helping them sleep? how long is what is the half-life? How long is that medication going to last? And if the patient has only difficulty falling asleep, if they have only difficulty staying asleep or early morning awakenings or both, the medication you select may really be based on how much of that nighttime period do you need to treat. But then also what I always try to do is limit any daytime active med in the bloodstream. So I usually recommend using the lowest dose of an effective medication that's going to treat the symptoms they're experiencing overnight, and it's going to have the least active medication in the bloodstream to prevent the hangover, to prevent the somnolence, to prevent the risk of falls that occur, and then any potentially side effects that may occur. And this is really important too in terms of educating your patients specifically about when they're supposed to use the medications, because often patients are taking their sleep medication at the wrong time, that they're supposed to take it several hours before bed, or they use a long-acting medication in the middle of the night after they wake up. And so they're basically staying drugged into the early morning hours when they're actually awake. This is actually here more for a reference. If anybody wants a copy of this, the slide deck at the end. I really like this medications from a New England Journal of Medicine review by John Winkelman a few years ago. And I think what's really nice is it actually has a list of the several different categories. Again, there's some newer agents not on here, but it really hits the common players, gives recommendations for starting dose based on age stratified, and then also the half-life of medication. So again, this is really helpful when you're thinking about, when are you treating over the overnight period? How quick is that medication going to be out of the patient's system? And then as well as common side effects to monitor patients on and also to educate them about as well. So this is a super useful chart. I know when I was learning about sleep, I would reference charts like this frequently, just until I feel that I had all the details clear in my mind and sort of, felt comfortable manipulating sort of the properties of the medication to get the most effective treatment in patients and minimizing these side effects. And again, sort of why I also want to talk about behavioral therapies and a talk on pharmacological therapy is taking a pill is actually a behavioral therapy when you think about it. And we know from data that patients often share other patients' medications. So it's really important to specify that this medication is for you, to go over what the medication is, the name of it, the dosing. And then it's critical to talk about, as I mentioned already, the timing of the medication, because patients, do have different ideas about when they should take their sleep medication. And I have had many patients taking, longer acting medication, not till the middle of the night, because nobody told them that exactly when they're supposed to take it. So this is really basic, but it's really critical to get them to use the medications properly, not only to maximize benefit, but again, minimize the side effects. What are their treatment goals of medication? Some patients with really bad insomnia, you're not going to make them perfect sleepers. It's really to minimize the symptoms at night as much as possible to get them functioning during the day. And again, I'm going to go over details on, how to use it. Do they take it on an empty stomach or with food? And then how long are they going to use the medication for? And, the goal is not to use these medications forever, but to use them for a short period of time, although they could be on longer term use as needed. But I really try to be clear up front, because I don't want to start a medication assuming that they're not going to stop it, for the rest of their lives, which could be 30, 40 years from now. So it's really important to be very specific about these instructions with patients, and again, also ask them, tell them that they shouldn't take it with in terms of other medications. Many patients are on multiple sedating medications and also avoiding alcohol in these patients. This should all be very explicit when you give the patient that prescription. And then patients also really need to be educated on realistic expectations. And what I mean by this is we often get patients coming to the office who say, I want something that knocks me out. And they're actually looking for anesthesia. These medications are not anesthesia. I sort of tell patients, I may not be able to make them sort of make the Olympic sleep team. They're not going to sleep a perfect 8 hours a day. What these medications are used for is to actually work with your own brain, and they sort of give it a little push. So when it's your nighttime sleep and when you're awake for a period of time, this is going to give your brain the little push it needs to help you sleep better. You're not going to take them. They're not going to knock you out. They're not going to give you hours of sleep. At best, they give, patients 20 to 30 minutes of sleep, but the benzodiazepines give a little bit longer and subjective sleep up to 40 minutes a night. But again, they're not going to knock people out for hours at a time. And that's often what patients think that they do. And they're often not satisfied when the medications aren't doing that. And all the patients, getting sleep medications really need to be educated on some minimum behavioral strategies in terms of regularizing routines, setting wake times, not getting to bed until they're ready, because that's all going to help them sleep. And obviously some patients, because of work scheduled or childcare, they're not going to be, some of these aspects are going to be out of their control, but we often can make inroads with some of the behavioral, basic strategies along with the medications as well. And then it's really important to follow up assessment. Often patients get written prescription for a sleep medication and they never talk with their provider about the insomnia. Again, they're on automatic refills and they could be on it for years. So we advocate, as they do in the recent guideline, that there needs to be ongoing assessments of effectiveness and side effects, using the lowest dose for the shortest periods of time, discussing challenges, answering questions, challenge patients to withdraw, reassess comorbid conditions, and educate regarding long-term use. And again, this all sounds well and good, but this all sounds good, but we also know that often, the road for insomnia is often bumpy. Things work, things don't work. Some, medical conditions happen, major life changes happen. They're too busy talking to them about their hypertension and their diabetes. You don't get to talk about sleep. So we know that, the real world is often very different. But it's important to keep in mind, what are you going to do for patients? Even if it's working, you're going to talk about some of the goals on the previous slide, but it's also important to talk about what if the patients don't respond. I recommend that as best as you can, review any information you have about their sleep patterns to see if maybe something else is going on, to understand what is actually going on with their sleep, because they might say, I'm still sleeping poorly, but are they having trouble falling asleep? Are they having trouble staying asleep? Is something else just disrupting their sleep? Because you want to actually decide, is it really their insomnia, it's the problem, or something else that's interfering? You want to review their medication adherence. Are they taking the medication? Are they taking it at the right time? If they were doing behavioral therapies, were they able to adhere to therapy? And if they are doing everything right and they're just not responding, you may want to consider changing the medication to maybe even another medication within the same class. Maybe change the medication from one class to another class. So if you start somebody on zolpidem, maybe you want to try something like doxepin is another line. Or even sometimes adding two medications together, so something for sleep onset and then something that's more for sleep maintenance. There's lots of different permutations you can try as long as you feel comfortable and I think this is the key to really understanding how the different drugs work in that chart of the time zone. And then as always, what is the differential diagnosis? If patients really aren't responding to insomnia treatment, they can have another sleep disorder going on. So those are the patients that may be worth referring or ordering a sleep study and to make sure that you're not missing something in your diagnosis, because we rely very heavily on clinical history, but sometimes we do miss things, and that the sleep study can give us more indication, and that's something to continue to reevaluate. So the last few slides I wanted to mention is on deep prescribing. And I think people are skeptical that this happens, but it is effective. And I'll just say the Canadian Family Physician has an excellent guideline. This is specifically about benzodiazepines, but it actually provides a really clear framework for how to have this conversation with patients on how to deprescribe benzodiazepines for sleep. And they did a review of the evidence in creating this guideline and found that the best practices were unclear, but they strongly advocated for discussing the evidence at risk of ongoing benzodiazepine receptor agonist use, the potential benefits of discontinuation, so that sort of reversing reducing the risk of falls, reducing concerns about potential long-term effects in the long run, but also set patients up for that they will likely experience mild short-term withdrawal effects, including rebound insomnia. But this is actually from the insomnia perspective, short-term. And then often, if you actually look over a period of time, patients, after they withdraw off their medication, their sleep actually doesn't look that different. So their sleep improves with the short-term withdrawal. It gets a little worse, but then it often recovers. And over time, they look actually pretty good long-term, even off the medication. So the assumption that they're not going to be able to sleep without their medication can't be assumed. Certainly, there's some patients who fail the tapering, but many patients, if not probably more patients, actually are successful at tapering if done in the right context. The tapering plan should be negotiated, and sometimes using other medications may make it harder. There's also no clear evidence on the best way to taper for approaches with insomnia. Obviously, the traditional benzodiazepines, you need to follow the guidelines for how to reduce withdrawal, but for the benzodiazepines, I usually do a slow taper that's even sub-physiologic, just to make sure the patients really have the cognitive buy-in that this is something they can do. And I often buffer it with behavioral therapy. So if they're going to reduce their medication, their sleep gets worse, I often reduce their time in bed a little bit. And then when they're sleeping better, they might titrate back down again. So it's nice to do it in consort. And then when to refer to sleep clinics. So a lot of these tools are available in the primary care clinic, but there's definitely times to consider, referring patients. So if they have persistent symptoms despite multiple therapies, you've tried a few different medications, they failed behavioral therapies, they're just not working, that would be a reason to send them to sleep clinic. Or if, they have a, other severe chronic medical condition or active psychiatric condition, that may be useful to seek referrals for those aspects of their care. So to summary from the talk, again, differential diagnosis and causes and contributors of insomnia is the key, because that's actually going to determine your treatment option. Sleep hygiene is not effective as a standalone therapy for chronic insomnia disorder. Behavioral treatments are recommended as first-line therapy and are increasingly accessible. And there's numerous and some new medications available for insomnia, but it's important to evaluate the cost benefit for each medication option for each patient. And this could be challenging. I have a old photo here of a physicist walking the nodal line on the Verrazano-Narrows Bridge. And that's sometimes how it feels like, finding the right medication for insomnia. There's all these other factors going on, and you don't want to be harmful, but you just want to sort of get that right line. And sometimes it does take a few different options. I'll be the first one. I definitely have patients I need to try, 3 or 4 meds and before I figure out what is actually working for them. And so it can be challenging to do. I wish I had a simple answer. I wish this talk could be a 5-minute talk, but unfortunately it's not that easy and not that straightforward. And just know you are not alone. I'm happy to, I'm sorry I can't be there in person, but I'm happy to take any questions you have by email and share the slides and any materials to help you actually feel more comfortable in implementing this in your own clinical practice. Thank you once again for having me speak, and be well, everybody.
All right, well, welcome back, everybody. Just to orient you to the day again, we have 2 more 30-minute talks, then we'll take a 20-minute lunch, and then 2 more afternoon talks and a Ask the Expert session. So it's really a pleasure to introduce my friend and colleague. I think we've been friends for the past 20 years, Dr. Eric Lenz. He is the Wallace and Lucille Renard Professor of Psychiatry at Washington University School of Medicine in St. Louis. He founded and leads the Healthy Mind Lab, one of the top clinical translational research labs at his university. And he's received approximately $60 million in funding from the National Institutes of Health and the Patient-Centered Outcome Research Institute since his lab's inception. He's known for innovations in clinical trials, and his research has advanced evidence-based medicine for depression, anxiety, and cognitive disorders in older adults, including studies published in JAMA and The Lancet and other top-tier psychiatry journals. Throughout his career, he's been a practicing clinician, teacher, and mentor at Washington University School of Medicine. He founded and leads both the Geriatric Psychiatry Outpatient Program, the Geriatric Psychiatry Curriculum for residents and medical students as well. He also has a leading role in the psychiatric residency research education program and works in faculty development. So we're really lucky to have him spend some time with us today, and I'm going to turn it over to Dr. Lenz to share his talk.
Great, thanks so much, Jordan, and I appreciate the audience. I don't know if the weather there is probably better than it is here in Missouri. It's kind of a chilly day here, so happy to be indoors and sharing my thoughts with you. I'm going to start by turning on my talk and sharing my screen here. Pardon me, just a second to do that. Okay, my hope is that you are seeing my talk, first slide. And I'm going to be talking today about deprescribing, which is something that Dr. Burdish just touched upon, as well as did Dr. Okereke earlier on today, which is just a rising issue in geriatric psychiatry. And I'm a clinician as well as a researcher. I'm going to start with an actual case. This was someone who came to my practice a few years ago. She was a 69-year-old woman referred to me for a variety of issues. Someone wanted me to take care of cognitive impairment, depression, anxiety, and polypharmacy. What was noticeable on the interview, she was cognitively impaired, and she was also ataxic. The family gave a story of progressive cognitive decline, which had occurred fairly rapidly. With disorientation, she was frequently getting lost while driving. She had a car accident due to confusion. She was missing appointments, not knowing the date, confusing names of family members. On top of that, a worsening gait, having frequent falls, resulting in lacerations and head trauma. And things were so bad, the family was planning to put her in a nursing home against her will because of her dramatic cognitive and physiologic decline. Well, we looked at the meds, and this is what we found. It took some searching. They weren't all on the electronic health record, but we got this list together. Doxepin, the very heavy antihistamine tricyclic at a high dose. Alprazolam, taking as needed with an unclear frequency. Oxybutynin, the bladder medication, an anticholinergic. Tylenol PM at night, an antihistaminic and anticholinergic. And then Zantac, which also has some antihistamine properties, as well as sertraline, and of course 12 other medications, but those were non-CNS active. This is what we did. We had her stop all of those medications at the first appointment, brought her back a week later. In 1 week, she was not cognitively impaired, not ataxic, not falling, interestingly, not depressed and not anxious. So, problem solved. And it's not surprising that you've already heard two other speakers talk about deprescribing today. And that's because even when we cover different topics within geriatrics, insomnia, anxiety, depression, it's all related. It's all related practically in what's been called the geriatric 5 M's. The geriatric 5 M's is a new way of describing core competencies in geriatric medicine created by some geriatricians, including Mary Tinetti in Yale, which is focusing on mobility. How do we maintain gait and balance, prevent falls and fall-related injuries? Mind, how do we reduce or prevent cognitive impairment and delirium? Medications, how do we reduce polypharmacy and be aware of adverse medication effects? Multi-complexity, how do we deal with the fact that older adults have multiple medical problems at the same time? And then finally, matters most. What are the goals of care that matter most for the patient and their family? What are their wishes? And is that being reflected in their medical care? But as a geriatric psychiatrist, as a brain doctor, I'm going to also say it's all related in the brain. The other reason why you heard similar issues, deprescribing, sleep, depression, come up in multiple different talks today, is that many of the same pathways underlie each of the outcomes that do matter in older adults. By which I mean, if you look at the left on this slide, there are numerous pathways into dysfunction in the brain. Neurodegeneration, like Alzheimer's disease or vascular disease, long-standing deficits, which may be due to long-standing depression, trauma, or even neurodevelopmental issues, but then acute changes, which may be metabolic or other changes, and importantly for this talk, medication adverse events. These combine, or I would rather say conspire together to produce various changes in the brain that tend to hit these same key networks in the brain that underlie so many outcomes that matter, including cognitive dysfunction, behavioral dysfunction, which can include depression and anxiety, sleep dysfunction, which can include insomnia or hypersomnia, delirium risk, low quality of life, caregiver distress, and loss of independence. But unfortunately, those 5 M's, the ideal of geriatrics, tend to hit what I call the 4 A's of real-world geriatric mental health care. And that's not good. Those 4 A's include inaccurate assessment, low adequacy of treatment for conditions like depression, little use of psychosocial approaches, for example, for depression, anxiety, and insomnia, that then leads to more alarming rates of inappropriate medications. And the rest of this talk will focus on that latter point. And it gets at an issue of the issue of deprescribing. I think those of us who are speaking today, and many of you in the audience, may remember a time when this word didn't exist. Okay, I don't believe the term even existed when I was a geriatric psychiatry fellow. This is what the definition of it is: the process of withdrawal of an inappropriate medication supervised by a healthcare professional with the goal of managing polypharmacy and improving outcomes, those outcomes that matter. So it's not withholding of care. And deprescribing is increasingly a science-informed practice. So it's a clinical practice. I wouldn't call it a science, but I would call it a science-informed practice. Starting on the left, because of epidemiology teaching us what we're seeing with our own eyes, rising levels of polypharmacy of CNS active medications. And then principles of geriatric psychopharmacology, a science that, as Dr. Okereke reminded us earlier today, tells us that aging changes both how the body metabolizes medications and how medications affect the brain to increase medication risks. But then also behavioral science. We know more and more about how to talk to our patients in a way to change minds about medication use, which I'll go over later today. And finally, an increasing science of patient-centered medicine, focusing on outcomes that matter. And all of those lead to a practice, a science-informed practice of deprescribing in order to reduce benzodiazepines, reduce anticholinergic medications, and thereby reduce interactions of medications as well. And why is it so important to mental and cognitive health? Bluntly, patients we see are on a lot of medications, and we could talk about why that is, why an older adult is on so many more medications than they used to be. But the fact is that from a geriatric psychiatry standpoint, many of these medications affect the brain. First of all, when I'm seeing a patient, I'm thinking of psychiatric drugs that we in psychiatry are prescribing. But then added to that in the same patient are psychotropic drugs that other doctors are prescribing. But then there's also non-psychotropic drugs like bladder medications that enter the brain. And then, of course, over-the-counter medications, which may be nowhere to be seen on any medication list that enter the brain. And the epidemiology tells us this is on the rise. This is a paper by Donovan Most and colleagues showing us that, for example, in older adults who have a depression diagnosis, more than 10% are taking 3 or more concurrent psychotropic medications, what Dr. Most has referred to as CNS medication polypharmacy. So not just multiple medications, but multiple CNS active medication, which is what I'm focusing on here today. That's the epidemiology, but I want to put a rather human face on it. This is Bob Saget. In fact, this is a tweet that Bob Saget sent a few weeks ago. He had just given a comedy show in Jacksonville and sent out a tweet with a selfie saying what a great time he had had doing it. And as he said, I'm happily addicted again to this shit. Check my website for my dates in 2022. Later that night, Bob Saget died. He died in his hotel room. No illicit drugs or alcohol were found in his system. He appeared to have had a catastrophic fall, resulting in a severe head injury, leading to his death. In his system were the medications clonazepam and trazodone. So while you almost certainly heard about it on the news, you may have missed, or the news may have missed this point. Brain toxic medications in older adults, even very healthy older adults in this case, can cause falls, and they can also cause cognitive impairment and delirium. And this can be catastrophic. Well, these medications seem like they're easy to start, but they also seem like they're hard to stop. And I'll give you this example from a recent study. This was a study, a randomized trial of a multifactorial strategy to prevent serious falls injury called the STRIDE study. This was a big study in geriatrics, a multi-site effort of many of the best geriatricians in our country, in the world, getting together to test a multifactorial strategy to prevent serious falls injury. But unfortunately, this was their primary outcome. They found no difference between the intervention, the multi-component strategy to prevent falls, and the control condition in terms of falls prevention. And in their discussion, they said this. They said, our intervention, it was patient-centered. They said it used motivational interviewing that encouraged participants to choose recommendations they were willing to address, but some potentially valuable recommendations were not implemented, meaning were not chosen by the patients. For example, and I put this in bold, only 29%, so less than a third of the participants taking a medication identified as a risk factor, meaning a fall risk medication, agreed to address this. So when the best geriatricians in the world work together to develop an intervention to try to reduce fall risk and run into this barrier, you know it's an issue. I'm going to spend the rest of the time now talking about how I do it. These are tips learned from 25 years now, I hate to say, of geriatric psychiatry practice and doing this in research studies and in my own practice and in my teaching. Step one, most important step, make a list. Make a list of all brain toxic medications. Put them all on one list. Benzos and other CNS depressants go on the list, as well as strong centrally acting anticholinergics and antihistamines. And that includes, importantly, over-the-counter medications. I develop a line of question with patients in order to make sure I don't miss those. I say, do you take any over-the-counter medications? No. Well, like for sleep, for example, or allergies? No. For example, Tylenol PM? Oh, yeah, that. Yeah, I do take that. Okay. So it does often take a multi-pronged question to jog that out of a patient's memory that, oh, yes, in fact, they do sometimes, or maybe most of the time, take that inexpensive over-the-counter medication. And I'd encourage you, if you ever have the spare time, walk through the aisle, the over-the-counter aisles of your pharmacy. You'll see loads and loads of what I call brain toxic medications. Walk down the sleep medication aisles, and you'll see Tylenol PM, which has diphenhydramine, Benadryl, a strong antihistaminic and strong anticholinergic. Ergo causes cognitive impairment, falls, and delirium. Walk down the colds and flu aisle. You'll find NyQuil, which contains, you guessed it, a strong anticholinergic, strong antihistaminic. Walk over to the pain medicine aisle. You'll find nighttime pain relief medication, which contains, once again, a strong antihistaminic or anticholinergic. You can even overlook to find some motion sickness medications, which tend to be antihistamines as well. It's all through those over-the-counter aisles. So that tip one was to make a list. If you don't know what they're on, you can't do anything about it. And then make a plan. Here's how I do it. I categorize all these brain toxic medications into two types of categories. Category one is the easiest one. That first category is strong, centrally acting anticholinergics and antihistamines, those medicines like Tylenol PM or oxybutynin. In my experience, these are the easy ones. You can stop them now. There's no need to taper. Now, in some cases, patients will feel that they're helpful because they are helpful, maybe. In the case of maybe a tricyclic being taken for migraine prophylaxis, for example. Just as often, or maybe more often, whether they're helpful or not, they're perceived by the patient as helpful, like an overactive bladder medication like oxybutynin. In those cases, I'll switch to a less harmful medication. So you can switch from a highly anticholinergic tricyclic to a less anticholinergic tricyclic. For example, from amitriptyline to nortriptyline. Or in the case of a bladder medication, you can switch to a CNS active medication. That is a medicine that crosses the blood-brain barrier, gets into the brain, to a non-CNS active medication, one that does not cross the blood-brain barrier, does the same thing to the bladder, does nothing to the brain. And that's why in the St. Louis area where I'm from, I'm known, perhaps with some concerns, but I'm known as the psychiatrist who will put patients on trospium, the bladder medication that does the same thing to the bladder as oxybutynin, but doesn't get in the brain. And the message matters, okay? This talks about the messaging to patients. And I'm gonna just reduce my message down to distill it down to the basics. Mr. Smith, you told me you're really concerned about your memory. Yep. The good news is we can definitely help you with your memory today. That'll get their attention. Okay. You take Tylenol PM. It causes memory impairment and confusion. Wow. All you have to do is stop it, and I guarantee your memory will get better. Great. You can see here the language is simple, straightforward enough that any patient can understand it. I'm not talking about relative risk ratios or anything like that. It's talking about something that's important and relevant to the patient, something the patient told me was important, and I'm describing it in the most positive way possible. Okay, here's the benzo addition. Benzos are harder. They're harder to taper off. Why is that? There's three reasons. Number one reason, you need to taper them in order to avoid a withdrawal or rebound. I do outpatient care, so the good thing is that we have the luxury of time in outpatient care. We can taper slowly. I'll usually taper by a fraction of the total amount every 2 weeks in order to avoid that withdrawal or rebound. Now, patients may nonetheless feel worse as you taper down a benzodiazepine. You might unmask underlying anxiety or depression. I say, okay, well then treat it. We have good non-benzo ways to treat anxiety, depression, and as the previous speaker indicated, insomnia. But the last thing I'm going to talk about with respect to language to a patient is that they're habit forming. Now, very few of our patients who take, our older patients who take benzodiazepines have a substance use disorder, but many of them take them in a habitual way, and that's because the medications are innately habit forming. And what does that mean? On a neurobiologic level, it means that patients like them. Patients' brains like taking benzodiazepines. So I like to imagine in my mind that when I'm telling the patient about the bad things of a benzodiazepine, the benzodiazepine is whispering sweet nothings in that patient's ear, saying, you like me, you want to stay on me. So for that reason, the message really matters. And this is, again, distilled down to the basics, my messaging with a patient. You are taking clonazepam. Patients probably heard this before. The problem with this medication is that it causes older adults to fall and have hip fractures, emphasis on hip fracture. Yikes. It also causes memory impairment, like Alzheimer's disease, emphasis on Alzheimer's disease. Eek. Fortunately, if we reduce and stop it, you won't have these risks anymore. Whew. So what you're seeing here is, again, the positive, talking about things that are important for the patient, but more emphasis on the potentially catastrophic outcomes that can occur, spoken in a way that the patient very much understands. We know our older adults know about hip fractures and don't want to get hip fractures. We know our older adults know about Alzheimer's disease and don't want to have their brain be like someone with Alzheimer's disease. So these are the words I use. And with this, I've noticed a very high rate of success reducing and even stopping benzodiazepines. I'm going to stop here, and hopefully there's plenty of time for questions and comments. But I would argue here that geriatrics on some level geriatric psychiatry is not that complicated. Simple principles make the difference. One, as stated previously, measurement-based care. Another is as Dr. O'Carricky and others said, use algorithms, use dose optimization to get treatments right, use psychosocial approaches, know where to refer people for that. But hopefully I've convinced you, deprescribe, or better yet, avoid in the first place bad medicines, those brain toxic medications that causes catastrophic outcome. All right, that's all I got.
Eric, that was outstanding. Thank you. Really practical, useful for our primary care colleagues who are participating today. And I'd like to just bring up a patient that you and I shared in a research project who we did not know was taking Xanax, and we also did not know how much alcohol he was drinking. And he had a catastrophic fall down a set of stairs and suffered multiple traumatic injuries, including a head injury, and died. So in some cases, you do need to have a shared decision-making approach with older adults, and you do want to keep maybe a benzodiazepine because it's inhumane to stop it. But in those instances, we really need to be vigilant to minimize other CNS toxic drugs and alcohol or drug use.
Yeah, I think that's a great point, Jordan. And I think the point here is that that you make is that some of these medications could be particularly problematic in combination. Even a low dose of a benzodiazepine plus concurrent alcohol use could be really, really problematic, really at any age, frankly, but particularly in older adults where they're going to be more likely to lead to, in this case, falls. More and more, I'm asking very carefully about for someone who even drinks a little bit and uses a little bit of benzodiazepine, I'm asking about that and asking him, can you cut one or the other?
Thank you. We're getting some great questions in, and I also just received a question. How do you work with clinical pharmacists, both community and hospital-based? Because this is hard work, and patients are often resistant, especially to minimizing benzos or Z drugs. And so, what's your recommendation for working with clinical pharmacists to help achieve this task?
I think this is really important, especially for primary care doctors or other non-psychiatrists. I'm continuing to learn from clinical pharmacists and further improve my knowledge on the CNS actions of these medications. But I have to say, I tend to be, like 100% in agreement with them on the concerns about these medications. So I think it's a good thing when a patient's pharmacist is warning them about risks of these drugs, and they're hearing it from me and them. And the good thing is, I think increasingly hospital pharmacists are getting savvy about this issue when older adults are getting hospitalized, like perioperatively or otherwise, which is a really high risk time for both falls and delirium, a time that you really want to minimize these drugs.
Thank you. One of the questions here is, are there any supplements or herbs that you're particularly concerned about and that should be considered for deprescribing?
Well, I think I don't want to paint with too broad a swath here, but most of them are useless, right? So I think you could think of them from that standpoint as in terms of pill burden, and just the complexity of taking all those things makes it more likely that you'll miss a dose of this or that or make a mistake. Aside from that, I think the big concerns about CNS sedative or negative CNS effects of the drugs are those over-the-counter medications that I referred to, and because they're anticholinergics and antihistaminics.
Great, thank you.
I think there's increasing actually concerns about melatonin, I understand, but I still view it as a safer alternative to the PM meds, certainly, as well as nighttime benzo or Z drug use.
So we're getting some great questions here. I'm going to ask one that may be, because I'd like you to respond to the questions in the text when you're done, Eric, but do you ever discuss the potential disinhibiting effects of benzos with your geriatric patients? Is that something that would be meaningful for them and their families as you try to message negative side effects?
It's a great point, and the point here is that sometimes benzos, which we think of as being used to calm people down, will have the opposite effect. And I guess I always try to use language that patients understand really easily, just like grabs them, and there's no doubt that they understand it and walk away with that. And so trying to explain a paradoxical or disinhibiting effect is a little challenging. Yeah. I guess I might say it might make you loopy with I guess all the negative connotation of that term, but I might. But what the questioner was asking is certainly true. Disinhibition or even just outright delirium with agitation can happen with these medications.
Thank you, Eric. So we're going to wrap up your talk. If you can answer any of these questions in the chat, that would be great. And again, I want to thank you for participating.
You're quite welcome.
So we have another talk, and then we will take a break for lunch. And I'm really pleased to introduce Dr. Alyssa Gum, who's a good colleague here. She is the Medical Director of Addiction Services at the Southern Arizona Veterans Affairs Healthcare System in Tucson. And she's also the director of our Addiction Medicine Fellowship Program at the University of Arizona College of Medicine's Department of Psychiatry. Dr. Gum is a force of nature. She developed the Addiction Medicine Fellowship in 2018, and then in 2020, she secured a $1.4 million HRSA grant to expand the fellowship and further enhance the infrastructure of the program. She has over 8 years of experience working in inpatient detoxification with consult liaison services, outpatient addiction clinics, and inpatient residential rehab programs. Dr. Gum has a passion for addiction program implementation, and she's assisting other facilities, not just the VA, but also Banner and other programs in town in developing addiction medicine services to increase access in our region. So again, Dr. Gum, thank you for joining us and looking forward to your talk.
Well, thank you for inviting me in. And I know when you first approached, it was how do we treat multiple substance use disorders and assess? And I said, let's boil it down to just getting patients into the door, because sometimes that's the hardest part. And in modern medicine, it can feel difficult and kind of sometimes overwhelming to try and ask everything that you got to in a 20-minute session. So what we're going to be starting off with is screening for addiction and a 20-minute appointment. And so our objectives for today, just identifying some high-risk behaviors with quick screeners, retain options for charting and coding to capture workload for screening and treatment in primary care, and be able to recall the overall definition of addiction and how to assess those 11 substance use disorder criteria. Now let's start with our why. And why is this important for primary care to tackle in that brief appointment? Well, we know that the statistics around substance use, misuse, and addiction are quite overwhelming, and it's not an uncommon thing. We know, and when we look at the graph here on the left, that over 138 million people are current alcohol users. When we see this orange beige circle, about 66.7 million people binge use alcohol, and about 17.3 million people are heavy alcohol users. Now, this isn't even including just addiction. And we know with binge drinking and heavy alcohol use or misuse or risky levels of drinking, there is a ripple effect throughout the body, meaning patients can have increased risk for depression, insomnia, anxiety, as well as other medical issues such as hypertension, hyperlipidemia, etc. And if we're not asking about alcohol consumption and we're trying to treat all those other diseases, we're pushing a boulder up a mountain, and it, is going to slip and fall back down and crush us from time to time, because there is an underlying culprit kind of preventing those medications from fully working and from the patient from getting into a healthy state. Not only is alcohol a pervasive problem, we also know that the misuse of other substances or illicit substances is on the rise as well. And this is just looking at, on the right here, this graph about the number of people that have used an illicit substance in the past month. And we see that 27.1 million people, or about 10% of people, have used an illicit substance. This includes marijuana, the misuse of prescription medications, cocaine, tranquilizers, stimulants, hallucinogens, methamphetamines, inhalants, other sedatives, and heroin, so a whole spectrum of other substances. And you can see here in this kind of divided out panel that marijuana is one of the most heavily used substances. And so this is becoming even more of a problem, or becoming more of a use for your patients, because it's becoming legalized. And so people that normally wouldn't have used it before, because of that, fear of the consequences, are kind of exploring that. And that can actually go into that previous talk. I encourage everybody to ask your patients about their marijuana use, not just if they use or don't use, but once they say that they use, how much, how frequently, are they getting it from a dispensary, kind of really exploring and treating it like a substance, like an over-the-counter medication. Do you ever have side effects from it, etc.? If we don't explore these substances or alcohol, we're kind of setting ourselves up for failure, or feeling frustrated when our patients aren't getting better. Now, this is just misuse or use of these substances. And when we look at the use substance use disorder statistics, we see that the past substance use disorder statistics for the last year were 20.8 million people had a substance use disorder, so meeting the criteria for an actual diagnosis. And I know the opiate epidemic is still in vogue, and we get a lot of attention for that, and we get a lot of money and funding and grants, and it's wonderful. It really supports our mission. However, that's not the most prevalent substance that we actually deal with when it comes to addiction. And so the most prevalent substance use disorder is alcohol. And that's why addressing that heavy use and that binge drinking use can be really important, because it is more likely to go on to addiction. Now, illicit drugs, marijuana are still our top, after alcohol, our top use disorders as well. Now, there's a significant amount of people that use substance use disorders, and a lot of people know about the mortality, but the economic burden that comes along with untreated substance use disorders is pretty vast, and it hits a multitude of other domains outside of just personal health risk and or mortality. And so when we look at the left side of this, we're looking at the tangible cost of substance use disorders in 2019. And we saw some of the biggest costs coming from productivity loss. And we know that there was about $249 million of costs related to just alcohol use disorder alone. And then illegal drug, about $193 billion. And you can see that it's productivity, health cost, crime, law enforcement, and criminal justice. So we know tons of people are incarcerated because of their substance use or because of obtaining, carrying paraphernalia, et cetera. And also a big cost is traffic collisions. A big percentage of traffic collisions are related to somebody being intoxicated, whether it is alcohol or another substance. We know that this has a very heavy burden on public assistance and social service problems. And then that there's also some other accidents that can come along due to substance use, such as fires. We put a bunch of money into researching prevention techniques and looking at all these statistics to see where we can improve different areas. So there are a couple of different domains that lead to a very expensive total tangible cost of about $501 billion. Now, some of the intangible costs are the things that we predict we potentially lost because of somebody's loss of productivity, loss of quality of life, or even death. And so we can see here, this graph on the right, this is in the trillions. And so we see a significant increase in intangible loss and cost due to the loss of life, the loss of quality of life, crime victims, traffic deaths, etc. So there's a huge cost to not asking about somebody's substance use. And of course, when we look at those intangible costs and that mortality, everybody's been hearing these statistics, and this didn't slow down with COVID. We were kind of hoping in 2018 that overall overdose death was going to decrease. We had some good data. We were really hopeful, but with COVID, it actually swung in the opposite direction. And we've seen an explosion of overall overdose deaths. And actually in April of 2021, we hit that 100,000 overdose deaths in the United States. And so something like 270 plus people die a day of overdose deaths. And so this cost is costing us not only economically, but it is costing us our loved ones, our friends, our family, our patients, et cetera. And so this is why we're really directing all of our attention to it and trying to prevent these deaths. So we have a huge cost, we have a loss of life, we know there's all these factors. But the other hurdle is that primary care physicians on average get 18 minutes per appointment. And that's for an average of 2.5 problems. And the studies look at every problem only increases an appointment by 1 to 2 minutes. So when you're getting to 4, 5, or 6 problems, you're really only getting to about 24 minutes to be able to address all the concerns for the patient. And so we know it's very difficult, and we need to make it easier for these frontline clinicians to be able to ask about substance use. Now, one of the acronyms that we use quite a bit in my world is SPURT, and this is screening, brief intervention, and referral to treatment. Our main focus for this 20-minute to 30-minute talk is screening and how you can do that in that 20-minute appointment. So screening is just using some standardized tool with every patient. not kind of excluding anyone because you've known them for 10 years or they're geriatric, they don't drink anymore, they're drinking, they're retired. This is meant to be with every patient, almost at every appointment or annually, kind of touching on their substance use. Brief interventions can be a wide variety of things. It can be providing brief little bits of education, or it can be providing some feedback on their maybe misuse or risky use. And it can be kind of doing some motivational interviewing. So it can just be little bits, and it can advance to things like offering medication-assisted therapies for alcohol, opiates, or amphetamines. It can be referring to your social worker or another counselor within your team to be able to talk with them further. And then the last bit is referral to treatment. And that's referring them to somebody that is maybe an expert or specializing in treating addiction or more comfortable with it. And in Tucson, we have a whole host of different facilities that provide treatment. At the VA, I have a whole smorgasbord. It's very much a pleasure to work there because I have everything you could possibly ask for. And in the community, there's several hospitals that provide detox. There are several IOPs like Desert Star, and then there's even full-blown residential rehabs like Sierra Tucson and Cottonwood. So referral to treatment could be referring the patient to any one of those higher levels of treatment. And when they looked at SPURT and kind of just doing these brief screenings, and if we ask every patient, how long is that going to prolong these appointment sessions? And they noticed that when we asked just one or two brief screeners, that the majority of patients do screen negative. Because if you remember back to those statistics, it's about 10%. So the majority of people will screen negative. You're good, you move on, you tackle another problem. However, about 20% will need a kind of brief intervention or maybe some discussion points about the risky use and how to maybe reduce that a little bit. And then the last 5 to 10% will need that referral to treatment. So we know that it can help, and it will help you treat those other diseases as well. So what we're going to dive into are those screeners and how you can kind of implement them into those short appointments. Now, the pre-screening options that we have are just 1 or 2 question kind of screeners, and they're very simple, but actually really effective when they looked at them in the research. So the independent pre-screeners, one for alcohol is, how many times in the past year have you used or drank alcohol? And then the one for substance use is, how many times in the past year have you used any illegal drugs or misused a prescription medication? Now that seems simple, and it seems like, how is that studied to be effective? It seems like a common question, but literally just asking these questions, and if a patient says, no, I haven't used any illicit substances, and moving on, was really effective. There's also a 2-item conjoint screening, or called the TICS, and it basically combines the top 2 in a really brief screener. In the last year, have you ever drunk or used drugs more than you meant to? And have you ever felt or wanted the need to cut down on your drinking or drug use in the last year? So that one was also shown to be really effective to kind of suss out if that risky use was kind of advancing onto a more advanced addiction or substance use disorder. Now, a lot of people may be familiar with this. I see a lot of VA names right in this conference. And so the Audit C, that's one of our briefer screeners to kind of lead to maybe we should be looking at a full screener or maybe a full assessment for substance use disorders like alcohol. And the Audit C looks at quantity and frequency. So it's going to be, how often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day? And how often do you have 5 or more drinks on one occasion? And you can see the score is 0 to 4, and you tally that up. Anything that's greater than 4 for men and greater than 3 for women is a positive screen and either needs additional screening or potential brief intervention, or maybe even a referral to a specialist to fully suss out a substance use disorder. Now, moving from the Audit C, which is a brief version of the full-blown audit screener, we have the audit, which is 10 questions. And this reviews a variety of questions looking at not just frequency and intensity, but some of those other consequences and life-impairing situations that come from consuming alcohol. So how often do you contain alcohol or have a drink containing alcohol? How many drinks containing alcohol do you have in a typical day? Or how often do you have 5 drinks or more? That's the first part of the Audit C. So if you've already done that, you can see how you're already skipping to question number 4, which looks at how many times in the last year you have found that you are not able to stop drinking once you've started. And this is a great way to ask one of the substance use disorder criteria that we'll get to in a bit. Number 5 looks at, have you failed to do what you've wanted to do or expected of you because of your drinking? How often during the last year have you needed to have a first drink in the morning? And how often during the last year have you had a feeling of guilt or remorse? So you can see how these questions are starting to look at and assess those consequences and how alcohol is impairing somebody's life. When you go through the screener and you tally it up, you can kind of see here how on the right side, it gives you a variety of options for the scale. So 0 to 3, low risk, 4 to 9, risky, and 10 to 3, harmful, and 14 or more, severe. And what they state is that usually 0 to 3 is just having maybe a positive message about their alcohol use and how they have a healthy use of alcohol. And then 4 to 9 is looking at potentially a brief intervention to reduce alcohol, maybe some harm reduction conversations, something as simple as, instead of having a fifth, what do you think is a more manageable amount of alcohol? Because you're starting to have potential health consequences, or this is a risky amount of alcohol. You can just talk to the patients about reducing the number of drinks that they have. And when we get to that harmful and severe range, we're looking at more intense brief interventions and definitely referrals to treatment. Now that DAST screener is basically the same thing and the same formulation of those questions, but with using substances. There's a lot of great handouts that automatically list the different substances at top, and there's some auto calculators that will also help you kind of calculate the score so you don't have to manually do it. But these 10 questions mimic the audit, where it's looking again at a little bit of intensity and frequency, but also those consequences. And right here on the right, same type of scale, low risk to severe, and the different interventions that you would have with it. Now you're probably thinking, I thought you said this would be easy and I could do this in 18 minutes. This seems like a lot. 10 questions seem like a lot. There are a couple of different avenues. It doesn't always have to be the physician or the provider doing these screeners. It can be sent to the patient before the appointment. It can be given to the patient in the lobby before they start their appointment. It can be provided by anybody on the clinical team. And one of the apps I really like is this Spurt app out of Washington, or out of Oregon. And basically what it does, if I can get it to launch. So when you click on that, it will give you 2 different options for English and Spanish. It also has an opportunity to have an audio assisted guide so the patient can have the questions read aloud to them. And so we'll kind of go through this together just really quickly. So I speak English. It gives me some, interesting information. This should take about 5 minutes. Ask my age, ask my gender. And it's going to tells me that it's going to ask some questions about my substance use. And ask specifically those different types of substances that we seen at the top of that screener on the paper. And it just goes through all 10 of those. In a very easy to read, colorful format. And then it gives you an option to type in any other illicit substances you may have been using in the past month or so, or in the past year, because there are about 850 abusable substances out there. And so it gives them the option to write something in. Now it'll ask me about my actual individual use and the frequency, and it's going to go through those 10 questions from the DAST in this really easy to use app. As you can see here, it's just kind of clicking through. It's going to ask me about my IV drug use, because this could also help you determine whether or not you are going to use any other kind of laboratory tests, such as HIV testing or hepatitis C. Ask me about if I've been in treatment, and then it asks me about alcohol. So it's going to include that DAST, it's going to include that audit C, And for sake of time, let's just say no. It actually includes also the PHQ and the PHQ-9, I believe. And for us health professionals, what it does is it sends us an email with all that information that you can easily just copy and paste and put into your notes. So you've administered these different tools. You can review it really quickly in a well laid out format here. And then it can help you determine what additional questions you need to do, or maybe additional workups, especially if you see certain substances maybe checked in that list, and or if you see something like IV drug use. So there are tools like this, like apps. You can print out a variety of different kind of screeners to hand out in the lobby beforehand. And even nowadays with email portals for patients, you can email those in advance. So you've done all this work. How do you capture it? And we can't ignore that part of medicine in this day and age. We have to talk about coding and charting and how you can capture this hard work, because there's definitely a lot of different ways. And depending on your insurance, whether it's commercial insurance, Medicare, or Medicaid, there's a variety of codes that you can actually add on to doing these screeners. Now, if you have a patient and you're only able to get to the screeners and they say, doc, I got to go, I can't talk about this, or you're running behind, or they don't want to talk about it, just because you gave the screeners, you can still bill for that and capture that workload that you did when screening the patient for these substance use disorders. And so let's look at what something like that would be. So you can easily just say the patient completed the DAS, the audit, whatever your screeners may be, and they completed the screening tool today with a score of, input the score as suggesting no risk, high risk, or severe risk. We did not discuss this further because the patient did not warrant further discussion. So maybe they didn't have risky use, and maybe things are going okay. You still can capture for that productivity. Maybe the patient expressed unwillingness. They might not be willing to at this time, but you at least started planting that seed and hopefully can motivate them for additional interventions in the future. And so what you can use in this situation is this CPT code right here, 96160. And if you're just screening and you didn't get the opportunity to actually diagnose somebody with a substance use disorder, you can use these codes here for diagnosis codes. So Z71.41 is for alcohol screening, and then Z71.51 is for drug or substance screening. And this can even be for screening for those prescription misuses for sedatives, stimulants, or opiates. Let's say you were able to get in a brief intervention and it went well, same kind of setup. So you completed these screeners. This was the risk level, and this is things that you talked about, and the total clinical time. And there are 3 different levels for how much time you spent with the patient. Maybe you dug in really well and the patient was receiving the information well, and you came up with all these plans and you spent more than 30 minutes. There are definitely a bunch of codes that you can use to capture the amount of productivity, or just 15 to 30 or 5 to 14. And hopefully my slides will be shared, and you are more than welcome to just copy and paste this as a little format. I use a Word document at work to kind of copy and save some of the things that I do every day. And so it's helpful to kind of have these like little cheat sheets for modern day medicine. Now, these are all about screeners, and screening does not necessarily mean that somebody has a substance use disorder or addiction. And so the overall diagnosis, or the overall definition of diagnosis, is that it's a complex chronic disease manifest by compulsive use despite harmful consequences. And so we're going to talk about those 11 criteria now. And so we break them up into 4 chunks. The first one is impaired control, and this is when the substance is taken in larger amounts or over a longer period than intended. Or the second one, there's a persistent desire or unsuccessful efforts to cut down or control use. A great deal of time is spent in activities to obtain, use, or recover from the substance. There are cravings, strong desires to use, or triggers to use. Our second category is going to be social impairment. So recurrent substance use resulting in failure of major role obligations, not going to work, not able to take their kids to school, that type of thing. Continued use despite having persistent or recurrent social or interpersonal problems, failed relationships, divorces, but also not talking to adult children anymore. 7 is social or occupational recreational activities are given up or reduced. 7 and 3 look a little bit alike, and sometimes you can meet both with just 1 or 2 sentences. If the patient's telling you, I don't go fishing anymore, that's an activity, because I spend all my time, recovering or feeling better from a hangover from my alcohol use or from using alcohol. I start to drink and then I don't feel motivated to go fishing. And in that one statement, they're already hitting 2 of these criteria. We look at our different blocks here. So risky use is going to be recurrent substance use in situations which is physically hazardous. And continued use is by having persistent or recurrent physical or psychological problems. Somebody continuing to want to hold on to alcohol despite having insomnia, anxiety, depression, that's checking the box there. And then pharmacological. So this is tolerance, so more is needed to get the same desired effect. And then withdrawal. All of our substances have a withdrawal syndrome. And so somebody's starting to experience those types of symptoms when they stop or reduce their use. Now, of course, it's medicine and it's not easy. And that's why you see a little asterisk here. And the pharmacological category doesn't actually count when somebody's prescribed a controlled substance. So this includes opiates, sedatives, Z-drugs, and stimulants, et cetera. So if somebody's been taking an opiate every day for 90 days, we know that they're likely to develop a physiological dependence. And if we would just cold turkey them from the medication, they're going to experience withdrawal. And we also know that if a patient is on an opiate every day for 2 weeks, they're going to build a tolerance and need increased amounts to treat their pain. So because we know that controlled substances all have both usually a physiological dependence that develops with a certain amount of time or tolerance, we don't get to count those if the patient's taking the medications from a primary or from a prescription or from a provider. So we can't work with those 2. And so we have to work with our other 9. And so sometimes that can be really frustrating. You're seeing a patient maybe on opiates for 30 years, if they stop, they have withdrawal symptoms and tolerance, but we got to look at how that opiate is actually impacting their functioning, their social life, every other aspect, not just the withdrawal and the tolerance. So it can be a little tricky. And it's a spectrum now. Back when it was DSM-4, it was either abuse or dependence. And now it's a simpler spectrum. So mild is 2 to 3, moderate is 4 to 5, and severe is 6 or more symptoms. So what we're going to do is a brief little case, and hopefully I can get some participation. And so we see Jill Smith. She's arriving to her 6-month follow-up. She was provided one of those screeners in the lobby. You're handed that from your MA. She's just here to see you for hypertension, but her audit is showing some risky behaviors and potentially some harms, especially with her age, that alcohol may be impairing her life. She looks like she's screening for high risk here, so you want to talk to her a little further. So I'm going to give you guys just 1 to 2 minutes to read this briefly. All right, and if we could maybe have some group participation, what type of symptoms, when we look at those 11 criteria, are we seeing potentially in this patient? You can pop it in the chat. Right, so we definitely see, thank you, Stephanie, causing harm, injury, so use despite medical consequences. So right out the gate, we know that she has hypertension, and continuing to drink excessive amounts or binge drinking levels when you know that you have hypertension is a risk factor and a symptom. Drinking more than intended, great. larger amounts, interpersonal relationships with the kids, right? We're starting to see ultimatums kind of appear within the family. And so when we look at this, we see a couple of things here that might be a little bit more subtle. So sometimes when I'm feeling sad and lonely, so use despite mental health problems, so maybe she's having some depression and continuing to drink as a coping mechanism. So that potentially is a symptom. Drinking more than intended. So this is classic when somebody says, oh, I'm just going to go I'm going to stay in this weekend, but I'm going to go have a drink with a friend. And then next thing you know, they've gone out 10 days in a row, drinking 5 to 6 drinks at a time. So that's an example of more than intended. I fell walking up the front steps and fractured my arm. That's pretty significant. My son is worried, won't let me talk to the grandkids. That's going to be those interpersonal problems. And so when we look at that, we see interpersonal difficulties, increased time using. We'd want to explore that a little bit more. Hazardous use, despite mental health and medical issues, and more than intended. And we might want to explore her tolerance, and we might just say, you know, have you always been drinking this amount, or did you start at a lower amount earlier on? And so we're looking at an alcohol use disorder, moderate to severe. And so the screening tools can kind of maybe pick up some of those, especially when you're using the audit and the DAS, some of those consequences that, yes, do count towards your criteria, but we do want to explore them a little bit more when we're talking with the patient. And this is for a more advanced appointment. You may do your screeners and say, gosh, I need to spend more time with this and I need to do it justice. And so you invite the patient back, or maybe you incorporate your team members. You know, at the VA, we use clinical pharmacists to talk about AUD and AUD medications, but we also have a lot of social workers that can help. So we have a whole team, and really finding which team member feels comfortable with this to be able to assess this further is generally really great. And so I'm wrapping up now. Happy to answer some questions. Some things I included in the links. The screening sprint tool that I walked us through, really helpful. I wasn't able to do a full justice in this brief session, but you can click on this. Should be all hyperlinked. And then these are PDFs of different tools, and also then patient education. So there's a moment where you can, you know, kind of talk to the patient, do harm reduction conversations, you have a really meaningful conversation. And these patient educational tools are something that you can print out and hand to the patient, so they have something that they can take home with them, maybe review later, and then help them retain what you talked about. Okay, questions?
Thank you, Dr. Gum. That was great. Any thoughts about screening for tobacco? Because we didn't touch on that. It's a different, I mean, it's not maybe immediately deadly, but it's something that we really need to be addressing for our patients.
Right. And I will tell you, I get this kind of remark because I spend a lot of time talking about tobacco and caffeine with my med students, and they like, she spends too much time on this. But what we know is caffeine is actually the most used and misused substance in the world. And then tobacco is number 2. And so when we look at alcohol and all these illicit drugs, they get a lot more attention because we feel that tobacco screening and tobacco use is no longer needed because it's been trending down for so many years. But what we do know that vaping has actually turned around that trend. And so kind of asking patients about their tobacco use is really helpful. It is one of the most, it's the substance related to the most cancers and the most preventable health conditions. So, you know, alcohol has some of the most deadly comorbidities along the sense of like alcohol hepatitis and alcohol liver disease, but not picking up smoking is one of the best things that you can do for your health long run. And so kind of screening those patients and asking them about tobacco. Vaping has changed the landscape. And so asking people about vaping, it starts with, well, do you vape? How much do you vape? Do you get a cartridge? How many milligrams is in that cartridge, and how often do you feel like you have to change it? So that's definitely changed and kind of expanded the number of questions, because it's no longer just, is it a pack a day or 2 pack a day question? You got to kind of explore a little bit more, but we still need to tackle nicotine cessation.
Can you use the same coding?
Yeah, you can. Yep. Those same coatings can be used for tobacco conversations as well. And so if you're talking about multiple substances, there are some screeners that allow you to use, I think it's like 4 screeners up to 2 to 4 times a year, depending on what insurance you're billing. So don't leave productivity on the table. You're working hard. You're asking about these things that can definitely really expand a conversation or an appointment sometimes. So there are definitely options.
So great, thank you. There's a question here about thoughts about primary care providers prescribing benzos to help people reduce their drinking. I wonder if this is more for maybe this person is addressing or asking about outpatient detox, but maybe you could respond to this.
Yeah, so benzodiazepines are basically alcohol in a pill, and there's not been evidence to support them being utilized as an MAT. We've been really successful with buprenorphine and methadone, but we've not been able to translate that to other substances and other medications that mimic those receptors. And that's probably something I could geek out on. Mainly, benzodiazepines don't actually attach to the GABA receptor like alcohol does. It attaches to a benzodiazepine receptor on the GABA receptor, and you need GABA present. And so it's not quite the MAT that we would hope for. And so it ends up actually inducing cravings for alcohol itself. And we generally don't recommend prescribing benzodiazepines long-term in a patient. Now, of course, we use them to help detox a patient because it helps prevent the alcohol withdrawal seizures. But that's meant to be short-term. I can be pretty heavy-handed with benzos when somebody's in acute alcohol withdrawal, but that's generally only a 3 to 5 day stent, and we're not discharging patients on those.
Thank you. There's another question here, and I think this has really high relevance for the audience today. How do you screen for addiction in patients who have chronic pain?
Ooh, that's another hour to 2 hours. And that's one of the things, actually, the Arizona anesthesiologist had me come talk on that. And that's a difficult area. And so what I always recommend is looking at things like, there is pain seeking, there is drug seeking, and then there is a combination. And so the first thing when a patient says, my medication is no longer working, not knee jerking into this being drug seeking behavior, but exploring, is the pathology progressed? Is there new pathology? Is there an exacerbation because something underlying? Exploring that first, and not just kind of saying, oh, this is clearly addiction, and kind of giving the patient due justice, bring them into an appointment, do a physical, do lab works up, repeat the imaging. I have the pleasure of sitting on a committee that reviews patients that have been on high dose opiates. And sometimes we see that we kind of sometimes set it and forget it, and we don't reevaluate and reassess, and we miss things. So when somebody asks for more, don't automatically think it's drug seeking. Kind of do some poking around and see where maybe the pathology is at that point in time.
Thank you.
Yeah.
We have time for one more question. Your thoughts on acupuncture for detox or addiction by a licensed acupuncturist?
I'm actually in support of it. One of the things I wrote into the grant was actually getting people trained for NADA, the detox protocol. There's been a lot of evidence to support that. And I think that could bring a value and hopefully reduce that benzodiazepine burden. We rely so much on benzos. And that was what we were taught for the longest time in med school, is benzos and set it, forget it, don't worry about it. But there's a lot of other things that actually go into detoxing somebody. And I think NADA is a great tool to be an accompaniment. Benzos and phenobarbital still are gold standard, and you don't want to move away from that. That's your foundation of treatment, and the other things come in. I'm actually interested in exploring battlefield acupuncture and those patients that are in that little crosshair of like potential OUD and pain, because there's been a lot of evidence that that's been really effective in that population. So I think there's definitely some tools there.
Great. Thank you. Thank you. So we are at our break, and we're going to take from now until 12:30 p.m. Mountain Time for lunch. All right, so just to orient folks for the rest of the afternoon, we have 2 more 30-minute talks and then a 30-minute Ask the Expert session. But right now, I'm really pleased to be able to introduce Dr. Jeff Newcorn, who is professor of psychiatry and pediatrics and director of the Division of ADHD and Learning Disorders at Icahn School of Medicine at Mount Sinai in New York, and director of pediatric psychopharmacology for the Mount Sinai Health System. I just checked the weather, and it is 30 degrees in New York City with a winter weather advisory report, but Dr. Newcorn is in Tucson visiting his daughter. So he gets to be someplace nice and sunny and warm. Dr. Newcorn is also immediate past president of the American Professional Society of ADHD and Related Disorders. He is a highly regarded clinician researcher with special expertise in the areas of ADHD, aggression, and child and adolescent disorders and psychopharmacology. He has published over 350 articles and book chapters on these and related subjects, and his most recent research focuses on the clinical and neurobiological basis of differential response to ADHD treatments, utilizing data from clinical, pharmacogenetic, and fMRI measures, as well as the neurobiological basis of substance abuse risk in those with ADHD. Dr. Newcorn has studied or helped to develop many of the emerging drugs in the ADHD field, and he has received numerous awards for his work, including several directly related to his work studying and improving the lives of those with attention deficit disorder. We are very lucky to have him with us today, and Dr. Newcorn, please take it away.
Thanks very much for that kind introduction. Can everybody hear me well enough?
Yes, you're good.
Jordan, it's good?
Yes, great.
Okay, so we're going to talk about adult ADHD, and here are my disclosures. I have the good fortune to consult to companies who are thinking about developing medications for ADHD, and in some cases, working with companies that have medications for ADHD. Also receive federal funding for my work and some other consultation activities as noted. So look, what is ADHD? First of all, it's a condition that lends itself very well to clip art. And we have the usual pictures of befuddled children or kids that just can't get with the program. But we now also have a picture of a rather worried, but otherwise normal looking young adult with ADHD. And notably, all the child pictures are male, and this one is a female. We have here in this slide, the crunched down versions of criteria for ADHD on the left and the right side of the screen, and we'll talk about those. But what we like to say, and what this picture is supposed to depict, is that ADHD is really the tip of the iceberg, and that there are a lot of other impairments that go along with ADHD, and you see them there, being fired from jobs, teen pregnancy, dropping out of school, rage, criminality, substance use, and even increased suicide risk. Now, Paul Wender, the father of adult ADHD, said that ADHD is probably the most common chronic, undiagnosed psychiatric disorder in adults. It is characterized by inattention and distractibility, restlessness, labile mood, quick temper, overactivity, disorganization, and impulsivity. It is always preceded by a childhood diagnosis, a disorder that is rarely inquired about and usually overlooked. Quite a visionary statement based on his work over several decades. And when I say it's probably, I agree, and I quote him in stating that it's probably the most chronic, undiagnosed psychiatric disorder. Look, the prevalence rate is 4.5%, which means that probably you all treat people who have ADHD. And so it's worth thinking about. Now, these are the DSM-5 criteria for ADHD. They show you the contextual basis in which the behavioral descriptors I showed you before exist. First of all, ADHD is classified as a neurodevelopmental disorder, which means that it has characteristic changes over the lifespan. We won't have time to get into that in great detail today, but we will talk about it some. You have to have a threshold level of symptoms of inattention and or hyperactive impulsive symptoms, but you can see that it's six for children of 16 and younger, but it's 5 in individuals 17 and older, in recognition of the fact that, although the disorder frequently is maintained, the number of symptoms can go down and the impairment still can stay high. You have to have several symptoms prior to the age of 12. They don't have to have been diagnosed before the age of 12. This is in recognition of the fact that many people are diagnosed after the age of 12, and there is retrospective recall, which is not always the easiest thing to do. There has been some current controversy about whether there's adult onset of symptoms. So, if you think you see somebody who is not really having this problem before the age of 12, I wouldn't tell you to categorically say they don't have ADHD, but I will tell you is that if you look long and hard, you'll probably find it. You have to have impairment in multiple settings. You don't have to have that reported by two informants, but ADHD is a condition that follows you where you go. And it's really interesting and important to understand the ways in which it presents across settings. You have to have impairment in social, academic, or occupational function. It's not really hard to elicit from people who have the condition. The symptoms should not be better accounted for by other mental disorders, but they certainly can co-occur with other mental disorders. I'm going to talk to you briefly about the developmental trajectory of symptoms in ADHD. I would make the point that inattention is present across the lifespan, and inattention and executive dysfunction represent the leading reasons for seeking treatment in all age groups, but this is especially true in older individuals. And on the left side of the screen, you see the way, a truncated version of the way the behavioral descriptor is presented in DSM. And then you see some of the common manifestations that you'll find in the text or in other places. And you can see poor time management, difficulty initiating and completing tasks, problems switching or multitasking, procrastination, avoiding tasks that require sustained attention. And of course, sometimes people can work very hard to overcome it. You can have support staff who pick up on some of the things you don't do well, or you may self-select a lifestyle that works out better for you. Now, hyperactivity tends to decrease with age, and we like to say that aimless restlessness often migrates to purposeful restlessness. It's generally less impairing on its own, but it can be impairing in certain contexts. You can see that you can have adaptive behavior, working long hours, doing a lot of activities. People with ADHD who have some sense of restlessness, they just need to be moving all the time. They may or may not fidget, but they have to be busy. They like to be doing one thing and then doing another thing. They tend to avoid situations in which low activity is required. They get easily bored. And you have to ask about the subjective sense of restlessness rather than only looking at the physical sense of hyperactivity. Now, impulsivity is often decreases with age, but when it's present, often carries serious consequences. You can see that the DSM descriptors are rather trivial: blurting out, having trouble waiting or interrupting or intruding. And of course, when you make a diagnostic system, you highlight high frequency behaviors, and in this case, behaviors that are frequent in younger people. But look, acting without thinking, having poor frustration tolerance, often quitting jobs or ending relationships without fully thinking through the potential consequences, losing your temper easily, as Paul Wender indicated, driving too fast, road rage. Not all of it is explained by ADHD, but it is common behavior. Making hasty decisions, note hasty as opposed to decisive. That's interesting. And impulsive aggression, although verbal aggression tends to predominate. Now, persistent symptoms of ADHD are associated with potentially serious consequences. We know about the academic consequences, poor academic outcome, failing grades, suspension, and dropout. But look at this: lower occupational attainment and lower earning across all SES levels, even professionals. Consequences of persistent impulsivity. I alluded to this in the earlier slide, and you can see the data about this here. Some very significant things, particularly with regard to driving, substance use, divorce rates, and employment status. Workplace difficulties are common in adults with ADHD, and they can be in any workplace, including medical settings and university settings, incomplete projects, underachievement, poorly formulated career goals, frequent job changes, poor discipline. All of them are seen and can be impairing to our patients and in some cases our colleagues. Comorbidity is common. It's the rule rather than the exception. And as you can see, all of these conditions on the screen are more common in individuals with ADHD than those without. And you note here the prominence of mood, anxiety, and substance use disorders. Although the rates are not as high, you can see they're 2 to 3 times higher in individuals with ADHD. But you can see the anxiety disorders are very high, and mood disorders and bipolar disorder, when you aggregate them, get quite high as well. So to summarize this section, ADHD is a highly prevalent and impairing condition which persists across the lifespan. Impairment is seen in many functional domains beyond school. It's often difficult to recognize in adults, and I didn't tell you this, but most adults are not diagnosed or treated. So this is a really, really important session, and thank you for inviting me to do it. ADHD is a neurobiologically based disorder. I had to cut those slides, but I have some extra slides I'm putting into the deck that's sent to you so that you'll be able to look them over. It's highly heritable, about 75%. It's as heritable as schizophrenia or bipolar disorder, and multiple neural networks are involved, including executive control, reward, and salience. People with ADHD pay attention very well to things they love and not very well to things they don't love. And while that's true of all of us, people without ADHD are much better able to pay attention to things they don't love. And so that's really interesting and important for you to think about. Now, recent models of ADHD highlight the importance of symptomatic and functional domains not described in DSM. There's an expanded view of executive dysfunction in adults. Mood dysregulation is quite common, and it highlights the important roles of motivation and salience. All right, we're going to shift gears now and talk about evaluation and treatment of ADHD across the lifespan. So why is evaluation of adult ADHD so complex? Well, the core symptoms of ADHD are present in all individuals to some extent. And so here you want to focus on how much and how impairing. Comorbidity is common, and so are the symptoms that we see of attention and performance and productivity. Are they from ADHD, or are they accounted for by the comorbid disorder? Here, the longitudinal history is critical. Impairment in 2 realms of life can be relative and difficult to determine. This is especially true for high-functioning individuals. You want to assess their level of function and their impairment relative to their individual capacities. Somebody with an IQ of 130 who was able to graduate college with B's and C's probably isn't living up to his or her potential. And while grades aren't the be-all and end-all of ADHD, they are in the minds of many people, but they really aren't. They can give you an indicator of how well somebody's performing. Retrospective recall of symptoms is problematic and difficult, and there's no litmus test to verify the diagnosis. Now, why do we treat ADHD? Well, if you're a pharmaceutical company and you're making drugs for ADHD, you have to show that you decrease the level of core symptoms. And we tell people in our guidelines to track symptoms and make them better. But actually, we don't want to decrease the level of symptoms. We want to minimize the impairment from core symptoms. Improvement over time is likely linked to improved functional status that follows the treatment of symptoms, no doubt. And this includes academic or occupational problems related to attention, task completion, time management, et cetera. But it's not necessarily linear. So you've got to get to a pretty good level of symptomatic improvement to start seeing improvement in function. And so, minimal improvements that you get from starting a treatment and not titrating it optimally aren't good. Those are not going to get the job done. And now another interesting thing is to alter the course of other disorders and decrease the risk for emergence of other disorders, including depression and personality disorders, anxiety and substance use disorders. And that is extremely interesting as well, and suggests that earlier treatment is a good thing. Now, professional guidelines of ADHD have been advanced by many societies. Here I highlight the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry. Those are older and are being revised. There also are important guidelines from Europe. The UK has the NICE guidelines. Canada, the CADRA has guidelines as well. Why do I mention those two international guidelines? Because they have guidelines for adult ADHD and the United States does not. And you can see that the importance of using established rating scales for diagnosis and monitoring treatment, about assessing for comorbidity, about the importance of using a combination of both medication and non-medication interventions, about the importance of targeting problems in multiple settings, and addressing adherence to treatment as important impediments to people getting better. Now, environmental modifications can be quite important for individuals with ADHD, identifying and avoiding distracting environments, organizing physical space to advantage, establishing centers for payment of bills or collecting messages, altering communications. You typically want brief instructions. You want work to center around things that are interesting. And you want to structure time, very importantly. Now, there are a lot of external aids that can help people, external calendars with day planners, tape recorders, notepads, checklists, reminder alarms, and various task-specific devices. And certainly some companies have decided that it would be useful and profitable to market these. But I would point out that some of the same instruments like computers or telephones that can be very helpful in organizing people with ADHD can be highly distracting as well. And so that is quite an enigma. Now, psychosocial treatment of ADHD often involves targeting domains, and particularly time management and organizational skills and planning, and then teaching people to break down complex tasks into simpler tasks, teaching them to use executive organization and planning. It typically builds on cognitive behavioral approaches and self-reinforcement. And as you can see, it can be quite effective. And it can be quite effective even in people who get medication, and particularly good for organization, which medication is less good for. Helpful, but not perfectly helpful. And we either have quite a few or not very many medications for ADHD, and I would submit this slide as an example of that. This slide has, as best as I can tell, all known medications for ADHD. And I use brand names, but key them to generic names because it's impossible to distinguish between different formulations of drugs of the same type if you use generic names. So this passes CME every time. And I've highlighted in light blue the emerging or relatively new drugs to market. And you can see we have basically the methylphenidate and the amphetamine classes of stimulants. And we have two classes of approved non-stimulants. We have the alpha-2 agonists, which are Intuniv or Capve, Intuniv being long-acting guanfacine and Capve being long-acting clonidine. And we have Strattera or atomoxetine and Qelbree or viloxazine, ER, which are relatively selective norepinephrine reuptake inhibitors. And basically these different formulations are managing the way drug is administered and how it gets in, and altering the PK characteristics will alter the duration of drug effect. Now, this just shows you, this cartoon shows you how stimulants and both classes of stimulants and atomoxetine block presynaptic transporters for stimulants, dopamine and norepinephrine; for atomoxetine, norepinephrine only. Amphetamine also blocks reuptake into these presynaptic vesicles, and so amphetamine increases release of neurotransmitter, whereas methylphenidate only blocks reuptake. So their mechanisms of action are quite similar, but they're not identical. And that suggests that people may respond better to one or the other type. It also suggests, and the similarities of atomoxetine to stimulants suggest that there may be people who respond to both of them as well, but also separately. Now, the benefits of acute stimulant treatment are substantial, both for core symptoms and associated features. And associated features I would highlight include behavioral noncompliance, impulsive aggression, social interactions, academic efficiency, academic accuracy, family dynamics, and self-esteem. The effect size for core symptoms of 0.8 to 1.1 across studies is quite robust. These drugs are about the most robustly effective drugs we have in psychiatry. And the time action properties, though, complicate response. The drugs don't work all the time. They're there when they're there. And there's, for amphetamine, there's PK/PD dissociation. So even though the half-life is quite long, the behavioral half-life is shorter. And so you have to keep delivering drug if you want it to continue to be effective over the course of the day. I'm not going to speak at length about dosing, titration, and efficacy. I'll just highlight that methylphenidate is less potent and you have to give about twice as much of it, and that there's a potency advantage for amphetamine in the labeled dose range. I'll tell you that it's important to titrate drugs. These drugs, you don't just start them at the dose that you think people should be at. And, although they may report initial improvement after a day or two, when you start them at a low dose, you'll typically need to go up to optimize treatment. And if you want to improve functioning, you're going to have to do that. Testing higher doses than you might think are needed is sometimes important. Think about the optometrist that fits you for glasses. When they think they get on the right refraction, they always test a higher one to make sure that they've really got it right. Again, the effect size, and this I told you. And you'll have to be able to review these in the slides when they're sent to you. I would say regarding older people with ADHD, remember, the treatment targets often differ. Predominance of inattention-related impairments, and treating mood dysregulation is an associated feature. You have to treat people over extended periods of time over the day. All medication classes are now approved in adults, but not all drugs within those classes. And the approved doses are not necessarily the same for children. Counterintuitively, some of the labeled maximum doses for adults are lower than for children. That's not because you need lower doses to treat adults and kids. You actually need higher doses. And the effect sizes are often larger at higher but not approved doses. You're going to treat people adequately and throughout the day. You may need a higher absolute but a lower milligram per kilogram dose in older people who are heavier. And you need to think about safety considerations, particularly cardiovascular risk in older people. Stimulant adverse effects are listed here: decreased appetite, headache, palpitations, mainly appetite and insomnia are the main things, and increased heart rate you can see. Edginess, irritability, rebound when the drug wears off, which can be irritability or drowsiness. Rarely can see tics, but not usually de novo in older people. Risk of sudden cardiac death, you won't see it. There's studies show that there's no increase over baseline, but there were things that you will read or your patients may read on the internet that led to suspension of Adderall XR in Canada about 15 years ago. It did prompt extensive study of cardiovascular risk of stimulants, and I'll show them to you briefly. Psychiatric risk, you can see psychosis. You've heard of amphetamine psychosis. You can see mania. In people who are depressed, you can see suicidal ideation. Importantly, you do see misuse, abuse, and diversion of stimulants, particularly in young adults and often in college students. State registries can be helpful to you. And monitoring, of course. So we have large data studies of cardiac events in kids and adults. They're indicated here. And you can see that there is no increased rate in treated versus untreated individuals. You can't say for sure that there's nothing because the noise floor is not zero, because you see, untoward cardiac events, in the population at random. All right, we're going to talk briefly about non-stimulants before we stop. Stimulants are extremely effective, but you see poor response or tolerability in some patients. Suboptimal response is not uncommon. The stimulants have relative or labeled contraindications for some comorbid conditions. Some people won't take them. Some doctors won't prescribe them. And I mentioned the risk for diversion or abuse. So atomoxetine was the first drug that received an actual approval in adults. Now several do, stimulant and non-stimulant, although this is the only non-stimulant that actually says it's labeled for adults. Viloxazine is labeled for children and adolescents, and the adult data are before the FDA. The long-acting alpha-2 agonists are not approved for adults in the United States, though they are in Japan. You can see a nice level of improvement. This lower level of symptom rating is not as low as you typically see with stimulants. Atomoxetine is particularly good in people with ADHD and anxiety disorders. This is a child study. This is with the pediatric anxiety rating scale. The effect size of about 1 was the largest. For ADHD was the largest in their pre-marketing trials. And the effect size for anxiety actually in this study was 0.5, which is about the same as you see for SSRIs in children. So quite good. Here's the dosing for atomoxetine. 2 important things to tell you. It's weight-based dosing, so you'll see it's milligram per kilogram, and you can refer to this. You do need to go slowly in titration because you can get sedation pretty early on in treatment. And also the drug is metabolized by CYP2D6, and poor metabolizers have much longer half-life and much higher blood levels. You may be able to use a lower dose. It may be more effective because the amount of time on receptor is probably much greater. The half-life in extensive metabolizers is about 4.5 hours, and in poor metabolizers can get up to 19 to 21 hours, which of course is preferable in my mind. Side effects, importantly, nausea. So you have to take this drug with food. Because it's noradrenergic, you get increased heart rates. You see no advantage there over stimulants. The growth rate, the impact on growth is lower than it is for stimulants. Obviously, we're talking about adults, not a big issue. You can see chemically induced hepatitis. It's extremely rare. You can't predict who's going to get it, but it's like a couple of cases out of millions. And if you stop the drug, it goes away. Importantly, in older males, urinary retention and sexual dysfunction can limit the ability to use this drug. Okay, briefly, situations in which stimulants may be used preferentially. which non-stimulants may be used preferentially. When there's poor response or tolerability with stimulants, presence of co-occurring condition, which can be adversely affected by stimulants and or better treated with non-stimulants. So anxiety disorders, sleep disorders, tics, substance use disorders, in some cases growth in younger people. For some patients who participate in competitive athletics, but mainly not. I mean, plenty of people in Major League Baseball and the NFL take stimulants for ADHD. Happy to talk to you about that. This one we can eliminate. And of course, combining treatments is very important. Short and long-acting stimulants to cover the day. There are very few, even of the long-acting stimulants, that cover the entire day. Stimulants and non-stimulants can be used together to augment therapeutic effects, to minimize adverse effects, perhaps because of effects that cancel out, like with the alpha-2s and the stimulants, with the alpha-2s lowering heart rate and blood pressure and stimulants increasing, allowing for lower dosing of both drugs and for treatment of comorbidity. And of course, you're going to have to use stimulants together with medications that are needed to treat other disorders. And you have to be aware of possible drug interactions. And with that, I'm going to summarize and conclude by telling you that ADHD is a complex and multifaceted neurodevelopmental disorder. It begins in childhood, and it often persists over the lifespan. There's a high degree of impairment and societal cost, and there's a strong neurobiological basis. It's often not that well appreciated. So that's my timer. There are numerous medication options that show very good response. Stimulants are generally more effective than non-stimulants, but non-stimulants can have a major role in certain conditions. Remember, the treatment doesn't always normalize ADHD, it improves it. Symptoms often persist over time despite treatment, and combined treatment can offer benefit in selected cases. And with that, I'm going to stop and stop my share. And here we are. Thank you.
Well, thank you, Dr. Newcorn. This is excellent. We, primary care physicians and psychiatrists, do not get enough education about the care of ADHD across the lifespan. So this is really novel and valuable. To be really practical and sort of, I don't know if you can be definitive, but for primary care providers, do you have a recommended algorithm? If an adult presents with likely ADHD and they have anxiety or depression, would you prescribe Strattera because it's an antidepressant molecule first line, and then maybe try a stimulant, or is it really case by case? And so I'll let you respond.
Yeah, it's extremely interesting, and thank you. You're gonna organize the questions.
I'm going to take care of asking you the
and you'll
questions.
go through them, right?
Yep.
So let me first correct one thing you said. Atomoxetine or Strattera was developed as an antidepressant, but is not an antidepressant. It failed in phase 3. It's actually was going to be Lilly's preferred antidepressant. And when it failed, they went to its very close cousin, fluoxetine. Atomoxetine was called tamoxetine at first, and fluoxetine or Prozac, it just has a fluoride side chain. But it made all the difference because atomoxetine targets norepinephrine transporters and fluoxetine targets serotonin transporters. So it's really interesting. So I would say don't worry about it in depression, and you can still precipitate mania. So there's not necessarily an advantage there. You might think about the SNRIs, but there's been a lot less study, and I didn't really include them. Only ones that are going to do well, though, are the ones that have relatively more noradrenergic activity. So here, when you have comorbidity, what you have to do is prioritize treatment. So if both conditions are equal, you can think about a parsimonious option. But if you see, there are people who have, sort of low-grade chronic depression, they don't perform well, they down on themselves, and they have definite ADHD. Those people, you may want to treat their ADHD first. But if someone has a major depression, treat their depression first. Treat it with the best thing you know how to treat, and then circle back and worry about ADHD. But understand that if you don't treat ADHD well enough in people who are depressed, you may end up with more chronic depressions and under treatment. So that's really important. Bupropion, really important because it is an evidence-based treatment for ADHD, although it's not labeled. It is another norepinephrine dopaminergic reuptake inhibitor, but weak. Effect size is probably a little lower than the non-stimulants, but a decent parsimonious option. I use it sometimes to extend the duration of effect or to try to decrease stimulant dose, or to use, or with people with, low-grade depression and parsimonious treatment. Absolutely.
Thank you. I'm going to ask this other question has relevance for not just adults, but especially children. It is a bit culture bound because of how technologically dependent we've become.
Yeah.
Oh, wait, that's not the one. But how do you distinguish ADHD from the decreased attention span and impatience associated with the high technology use of more recent generations?
Well, there is no accurate way to answer that question. And I think the most important thing to say there is, first of all, increased screen use is common in individuals with ADHD. If you look at studies of the environmental etiology of ADHD, almost all of them are pre and perinatal events. Now, the American Academy of Pediatrics certainly has an advisory against screens and too much television viewing. And there are a number of studies, at least a half a dozen, maybe more now, showing an association with screen use and ADHD. But note that they're observational studies, and the direction of the effect in observational studies can't be ascertained cleanly. So, while it may be true, and it's likely that even if screens have an impact, they likely have an interactive effect with genetics and some of the environmental causes in terms of families and parenting are also going to be more common in adults who also have ADHD and who carry the genotype for ADHD that likely got passed on to their child. So we have so I think the message I want to deliver is multiple interactive conditions together.
Thank you. What are the monitoring tools that you use to survey improvement in symptoms and treatment success when you've initiated treatment?
There are a lot of scales. I didn't include them in this slide deck, and I have a chance to modify them before they go out to you. So if I didn't include it, I'll put them all in.
Okay.
So I think it's there, but maybe not. But the ASRS ADHD symptom rating scale, that was one that the World Health Organization helped to develop, and they have a brief screener and a more extensive one. There's the ISRS for investigator that's used in adult clinical trials. There's the Conners Adult Rating Scale, the ADHD Rating Scale. You can use it in adults, but the one thing to tell you about using scales is if you're using a scale that's mainly anchored in items developed for children, you have to think about developmental presentations. So you miss it.
Is the Conners Adult just for diagnosis, or is it sensitive to change?
There's a DSM scale that you can use to monitor treatment. ADHD-RS is typically used to monitor treatment. Any symptom scale, Vanderbilt, but Vanderbilt is kids, but that's the American Academy of Pediatrics scale. You can follow that. But just remember, showing improvement in symptoms is helpful. But the most important thing that you can do is identify the 2 or 3 things that are most impairing to people and the people need to see improve with treatment and track those.
Okay,
Come back to them and track them. In my notes, for example, I highlight target symptoms. And then I go back when I read them forward and say, how is this thing? We said we were going to track this thing. How is this thing? How are you doing at getting to work on time? Are you getting through your workday fast enough? Are you getting home on time? There are no criteria that speak to those things. So you want to highlight the functional impact of symptoms, not just symptoms.
Good. Thank you for that. I extended our question and answer
I
session
saw.
with you because, well, this is a cause of consternation for primary care providers, and I knew there'd be a lot of question activity. So, Dr. Newcorn, if you have a couple of minutes, if you could respond to some of the questions in the chat, our participants would value that. And then we are going to transition to Dr. Kalia. And I want to thank you, Dr. Newcorn, for participating today. This was terrific.
Well, thanks for inviting me and thanks for highlighting this topic. I think you've done a great service and I look forward to continue to interact with you and your department.
Thank you, Jeff.
So long.
Okay. Okay. So let's see. One more person to introduce, and she is last but not least. I want to introduce Dr. Saira Kalia. She is a good colleague and friend of mine in the department. She's a perinatal psychiatrist and educator, and she's one of those faculty without which a department of psychiatry could not function, because she's really the triple threat of clinician and educator, and she's also developing a line of scientific inquiry. She's held various administrative roles at Banner University Medical Center, the College of Medicine, and within our department. These leadership roles include serving as medical director for outpatient psychiatry and as the associate program director for the adult psychiatry residency program. She launched the department's perinatal psychiatry clinical service and training track and is in the process of expanding these services. She is well known and well regarded in the Tucson community and has earned numerous accolades for her role as an educator and for her patient-centered care. So very grateful to have her on the planning committee and speaking today. And I will turn it over to Dr. Kalia.
Thank you, Dr. Karp. That was such a generous introduction. And thank you again for inviting me. This is a topic that's near and dear to my heart that all of you will see in a minute in terms of how passionate I can get. So I apologize for the passion ahead of time. The topic today is psychiatric medication management in pregnancy and in the breastfeeding time period. I have no financial disclosures, and my very lofty goal today is to discuss the burden of perinatal mental illness, review the principles of care, briefly review SSRI use in pregnancy and breastfeeding, and then kind of go into insomnia management in that time period, because that's often what I find our colleagues want to really bring me in for as well. So perinatal mental health is considered a major public health problem by a lot of our governing bodies, such as the CMS, the American Academy of Pediatrics, American Psychiatric Association, AMA, et cetera. It really is. And part of the reason that it gets so much focus and energy is because maternal mental health conditions are the most common complications of pregnancy and childbirth, which is about 1 in 5 women, 20% of childbearing people will have a maternal mental health condition, which is a pretty high rate of complication when you think about it. Additionally, what's not noted here is also paternal depression. So paternal depression is about 8% to 10% in the postpartum period, which is definitely higher than what you would experience for the fathers in any other time period. And a big risk factor for paternal depression is maternal depression. So that's another reason to keep that in mind in terms of the impact that maternal mental health can have on not just the mom, but the child and the family system in general. Suicide and overdose are the leading cause of death for women in that first year following pregnancy. And in that particular subpopulation in that time period, we find that suicide peaks around 6 to 9 months postpartum, and new mothers who die by suicide are most likely to be white and older. Additionally, this population tends to use more violent forms of suicide than we naturally associate with women. So that's another reason to kind of make sure that you're screening for mental health issues as well as screening for suicide in this population. As a quick review of like general principles of what you are doing in terms of managing of a patient in that time period, revisit the diagnosis. Make sure that you're clarifying what the diagnosis is for yourself and not just carrying it forward because the patient said so or it's in their chart. Once you've clarified and confirmed the diagnosis, also classify severity of illness, because based on the severity of illness, the treatment will vary. And once you have that in place, that'll help. Maximize use of any behavioral somatic treatments and interventions, for example, bright light therapy in the setting of depressive mood disorders can be really helpful and is an underutilized tool, and you can use that to benefit alone or in combination. Minimize the use of the number of adverse exposures. And I really want to make sure that we hear this part. It's unfair to the mom to expose to both illness, which is the risk of depression, for example, and then also medication. So if you're treating, treat to remission, because there is clear evidence of impact of untreated depression, both to the mom and to the fetus, and therefore minimize the number of adverse exposure. Make sure that you're monitoring the disease over that time period and clarifying that the person is adequately treated. In the event that you are using medications, use medications with data, and we'll cover some of those in the next as we go forth. And then also assess for other risks. Smoking, marijuana use is a big one in the pregnancy population because, as I said, insomnia, anxiety, those things tend to come up a lot. And it's really just easy to get marijuana prescriptions, at least here in Arizona. And then make sure you're educating everybody that's involved. So not just significant others or spouse, but also family members, OB teams or midwife teams, and they understand what you're doing. Care coordination can be a big challenge, and therefore making sure that you're either communicating back and forth in terms of what's happening or just getting into a routine habit of sending your most latest note automatically to the provider who's sharing care. The other thing to keep in mind is expect pregnancy. And I know we talk about this quite a bit, but by the age of 44, 88% of US women will be mothers. And then unexpected pregnancy makes about 50% of all pregnancies in the US. In Arizona specifically, we're a little higher than the national average. So we're sitting at about 52% with more unexpected pregnancies in sort of the teen adolescent time period. And so the main reason I bring this up is because most of the time the providers are going to be, these patients will be on medication, and reproductive safety or impact will not be discussed. So if it is essential to discuss the pregnancy safety, reproductive considerations for medications for women, especially if they're not pregnant, because it's coming at some point. So I'm hoping that we can illustrate kind of the plan, the considerations for management by using a case. So let's take the case of Daniela. And if you feel comfortable, please pop some things in the chat as I ask you guys questions. So Daniela is a 33-year-old married female. She's being seen in her PCP's office. She's on Prozac 20 milligrams and clonazepam 0.5 milligrams PRN. And these were started for management of generalized anxiety disorder and major depressive disorder. These were first started 9 months after the birth of her first child, and she's been on them for over a year and has residual symptoms of anxiety and insomnia. She's coming in because she wants to have another baby, doesn't want to feel as bad as she did before, and is conflicted and wants to know what you would suggest. Specifically, she's asking you, what's going to happen to my baby if I get depressed? What are the risks of depression to my child? So if you guys have any thoughts, please feel free to pop them in the chat. It's okay, I will keep talking. Also, I'm going to give it like a few seconds if people feel comfortable. Hold on 1 second. Yes. Thank you. So depression is a risk to the fetus. Depression is a fixed, so let's talk about the risk of depression to both the baby in terms of physical risks as well as neuropsychiatric risk. In terms of physical, your depression during pregnancy has been associated with preterm birth, low birth weights, as well as higher rates of preeclampsia and gestational diabetes, decreased infant motor tone and activity, as well as higher infant cortisol levels and poor reflexes, and basically overall worse infant health status. This, of course, is severe depression. Additionally, when you look at neuropsychiatric concerns that baby may have as a result of exposure to depression, the mother's postpartum depression has been shown to have a lower IQ, slower language development, higher rates of ADHD, and behavioral problems, of course, and psychiatric illness. So the reason why I'm making sure that we're talking about this is because there's robust data that has been replicated that maternal and psychiatric illness during pregnancy and postpartum can lead to undesirable and negative outcomes for the child. And this is something that you'll have perinatal psychiatrists harp on again and again, because it is a risk discussion. It's not just risk of medication, it's risk of untreated disease. So you talk to her, you talk to Daniela and say, here is the risk of maternal depression to the baby. And you kind of spend a little bit more time getting to know her psychiatric history. She has one suicide attempt in her 20s, and her most depressive episode, her most recent depressive episode was quite severe. This was the third depressive episode of her life, and she's responded to Prozac really well. Currently in partial remissions with some symptoms of anxiety and insomnia, a bit of fatigue left. She's now wants to talk about the impact of medication use in the pregnancy and what are the risks of continuing to use medication. And in that setting, we'd come back to the idea of this is the risk of the disease, but also this is the risk of treatment. And so you're having both that risk discussion so that she can make an informed decision for her pregnancy and for her child. You have to have a very collaborative, patient-centered approach, and it's a matter of informed consent. So you're discussing the risk on each side. The challenge becomes that there's no one drug. Like we can't say, oh, Prozac is the one, even though like most of the time it feels like people reach for Prozac and Zoloft very quickly because they have a lot of data behind them. But realistically, there's no one drug. Mainly also because you're going to pick the drug that works, right? So you're not going to be like, oh, Lexapro has worked really well, but I'm going to switch it because to sertraline because I think sertraline is safer. So you have to make sure that you're using the medication and you're treating to effectiveness and you're not switching just because there's one med that's a little better. The other piece is there's no one study. Unfortunately, that becomes quite the challenge. And I'll try to highlight that as we discuss a few specific medications because historically, versus what we knew historically versus what we know now really does change over time. And so making sure that you stay up on the data is a big factor in this particular area. And then it is really the patient's decision. So I've had patients with very similar presentations, histories, backgrounds, make very, very dramatically different treatment decisions. And you have to respect that as well as manage them and support them throughout the pregnancy and educate continuously. Let's kind of talk a little bit about SSRIs, because I feel like a lot of people that are attending this talk are likely to be using SSRIs a lot during that pregnancy and postpartum period, or just starting women on SSRIs and having to deal with that unexpected pregnancy, if you will. So here's what we do know. Most of the time when I talk to patients about any medications, reproductive safety, I tend to break it up in these four categories: any congenital issues, neonatal considerations, gestational considerations, and neurobehavioral. I tend to use that framework because it makes me accountable to make sure that I'm not missing anything relevant, and also makes me accountable to remember what's current and what's not. So for congenital issues with SSRIs as a class, there's no increased risk in congenital abnormalities. We'll come in a minute to talk about the cardiac issue defects history and the history of persistent pulmonary hypertension. As most of you are probably familiar with, those used to be a consideration. So we'll talk about that in a minute. Neonatal issues with SSRIs. So there is the risk of neonatal adaptation syndrome. It was first kind of discussed in like 1973, and it used to be called neonatal withdrawal syndrome, which hurts my soul because it implies that you're getting addicted and there's a withdrawal aspect to it. About 30% of patients exposed to SSRIs in pregnancy will have neonates who have neonatal adaptation syndrome, except that syndrome has a very wide expression. So it can be anywhere from a colicky fussy baby to a severe autonomic instability scenario. The severe autonomic instability scenario shows up in about 2 to 3%, and the rest kind of fall in that range of fussy, colicky, won't rest. If it's neonatal adaptation syndrome, it's going to show up within 3 days and it's going to be done within 2 weeks. If it's not in that time frame, it's not neonatal adaptation syndrome. There's been ongoing debate, especially in the 2000s, of we should decrease the dose of SSRIs at the 3rd trimester, and that will help because that will decrease the SSRI exposure, and therefore you'll decrease the risk of neonatal adaptation syndrome. That hypothesis has not borne out, and primarily what it does is it undertreats, increases the risk of relapse, or increases the risk of patient having depressive episode. And so it doesn't bear out, and it's not a recommendation that most perinatal psychiatrists will give you. It's just to decrease the dose. The other thing to consider are gestational outcomes. So in terms of like risk of preterm birth, hypertension, all of those scenarios. So the one thing that does come up in the data with regards to SSRI use in pregnancy is that antidepressant exposed babies on an average tend to weigh about 3.4 ounces less than unexposed babies. Most OBs don't tend to consider that significant, and I will tell that to the mom as well, and I'll allow them to make that decision, because depending on her history or previous pregnancies or outcomes with past births, that can be relevant, which is also why you're probably making sure that you're aware of that, have background, what happened with past pregnancies or past children. Neurobehavioral outcomes, which is another big one. Is my baby going to be addicted to these medications? Are they going to have depressive issues? So antidepressant dose and duration does not tend to predict any cognitive or behavioral outcome in children. We have lots of data, and we have lots of specific data. For example, like Prozac, we have a couple of studies that are following kids up to 18 years and have not demonstrated any issues in terms of neurobehavioral outcome. I'm going to come to the cardiac defects piece. So in 2005, FDA had issued a warning concerning heart defects with paroxetine, and I'm sure all of you remember this. And this was kind of based out of like one study that did not have a huge amount of control for confounding factors. And since then, there have been larger studies and meta-analysis that have found no associations between SSRI use in the first trimester or overall congenital heart defects. And when I say large studies, I'm referring to studies that are approaching or exceeding 1 million women. So definitely like large in that setup. And the other one that we tend to always remember, because it's like drilled into our brains from exams, is persistent pulmonary hypertension. In 2006, the FDA had issued an alert because SSRI use was associated with persistent pulmonary hypertension of the newborn. This was the Chambers study that had led to this. Again, this was a study that didn't really control for confounding factors. There were a lot of subsequent studies, and then only 50% of them confirmed the finding. And then the definitive sort of data point became the Hubert study in 2015. And they found that the association disappeared when you controlled for confounding factors. And it really did help because they had a huge sample size. So that really was reassuring for us. The other common question I'll get is autism. Is my child at higher risk for autism? So this was, again, I think it was about the late 2000s, like 2008, 2009, that there were a couple of studies that came out. They had major confounding factors, and these early epidemiological studies showed an association between SSRI use and during the pregnancy and subsequent autism spectrum disorder in the child. So since then, we've done more controlled data sets, sibling propensity studies showing no association, and kind of comparing overall like case control studies as well. There was a cool study in JAMA 2018, I think, that came out, and it was a case control study. And they defined 34 medication groups, took various neurotransmitter systems prescribed to pregnant women, and compared prenatal exposure versus pregnancy exposure. And they controlled also for confounding factors, which is like birth year, maternal age, maternal history. And they found that of those, including SSRIs and other antidepressants, they didn't find an association between prenatal exposure to medication to risk of autism spectrum. The other thing to keep in mind, though, which I think will come up if you're having this discussion, is that there is an increased risk for autism spectrum for moms who have depression. So that is an independent risk factor for the child and does not seem to be associated with whether that depression was treated or not. So automatically that in itself is a risk factor, not a dramatically significant one, but that is a risk factor. And the use of medication doesn't adjust that risk. So we're going to come back to Daniela. She's had that conversation with her primary care provider about risks of depression, risks of medication, and now she's showing up to her OB's office. And she is pregnant, 10 weeks pregnant with her second child. She's taking her Prozac. She's occasionally using the clonazepam, and her medical history is significant for type 2 diabetes and BMI of 32. Overall, she's doing well. She's unable to sleep. And she tries to manage it by taking naps when she comes home, except she has family and a toddler. It doesn't always work for her. And so what is the risk of sort of insomnia to this pregnant woman? And I don't think I'm clearly kind of clarifying that risk. I'm going to probably couch that a little bit better. I mean, sleep problems are common during pregnancy, and you'll find that about 73% of women will report insomnia during pregnancy. Anywhere from like mild, 50% of them will say it's mild, and then it can be pretty severe. And then additionally, women who are more likely to have perinatal insomnia are like people with comorbid medical conditions, pre-gestational insomnia, high BMI. But the risk particularly to her conferred by the insomnia alone are increased risk of gestational diabetes, a higher rate of prolonged labor and delivery, preterm birth, and near-miss motor vehicle accidents. So perinatal insomnia in its own will confer risks to her, both for the gestations or the diabetes, preterm birth, higher rates of labor and delivery, but also, as we already know, can make her perinatal depression and anxiety worse. And so treatment is generally recommended. You've already all attended this talk, so you did all the right things. You talked to her about the sleep hygiene, you referred her to CBTI, and you suggested using the CBTI coach app, and she agreed, and she said she would engage. She comes back and says, I couldn't really engage. I'm continuing to have insomnia. It's getting worse, and I'm getting more and more fatigued and irritable. And now just like, I don't want to go on at times. If I could just sleep, I think I could handle things better. And so what would you review at this point in the case? And then the more difficult aspect of things being, what medications would you consider for sleep? I'm going to pause for a second just to make people think, and then I'll. Yes, thank you, Tanya. Yes, check her thyroid status, see what else is could be another cause of her insomnia from a medical perspective. Figure out how much clonazepam that she is using. Is she using any marijuana, and what other meds are on board? And I will make a plug for CBTI again here. I know you've heard it before, but CBTI is indicated in sort of perinatal insomnia. And realistically, the cool thing about CBTI and perinatal insomnia is that they have found that the self-reported sleep is a bigger predictor of maternal mental health than like an objective measure of sleep. And CBTI tends to improve that. The mother's perspective of their sleep is better improved by CBTI than medications. However, sometimes we have to think about medication management. And so let's talk about sort of what we know. So we'll run through a few of the common med classes, and then we'll take a break. Benzos, because she's already on the clonazepam. Very commonly prescribed during pregnancy and tend to be about 1 to 4% of prescriptions, with the highest use in the third trimester, partly because of the sleep, partly because of the anxiety. Lorazepam is the most commonly prescribed benzo in pregnancy. They tend to cross the placenta and are present in amniotic fluid, and also tend to cross the fetal blood barrier. So as we talk about reproductive safety, there's been a lengthy debate on congenital malformations, gestational outcomes, as well as neonatal outcomes. Like their earlier 80s data was benzos are going to give you cleft palate. That does not bear out. So like in the 90s and later and 2000 data tends to say that doesn't bear out, that association no longer exists. There is one concurrent use of benzos and antidepressant in pregnancy systematic review that came out that said when you use them both together, you're likely to have an increased risk of malformations about 4 to 4.5%. As a reminder, absolute risk of malformations in pregnancy is about 3%. So it was considered to be higher and hasn't really been replicated, but it is enough for you to consider. The other thing that's a big one is gestational outcomes. So there's been several studies that note an association between benzo use and severe outcomes early in the pregnancy, such as miscarriage. There was a recent cohort study that noted an association between benzo exposure prior to conception, as well as an increased risk of ectopic pregnancy. There was a nested case control study in 2019 that took 400,000 pregnancies, and they also noted an increased association between miscarriage rate and first trimester benzos. The problem with the 2019 study and the 2020 study is that they did not control for confounding factors, which is always the problem when it comes to perinatal data, which means that you are going to discuss this with the patient and say, hey, this is what we know. We know that that data has some flaws in it, except that's kind of what I have to guide you with. And then it becomes a risk-risk discussion and a collaborative decision-making. Breastfeeding-wise, reassuring data, if a little bit sparse. And then the main risk, of course, is sedation as a primary side effect. And it's noted to be kind of rare in that scenario. So generally, the recommendation is Avoid longer active benzos if you can, given their extended presence in milk. So when it comes to benzodiazepine for sleep, you have to discuss the reproductive safety when prescribing, and they're generally not considered to be first line. The Z drugs, we've talked a little bit about them today earlier as well. We don't really know much about them when it comes to the reproductive safety profile. They do cross the placenta, and zolpidem has a few earlier studies like 2007, 1998 studies that showed there was increased risk of congenital malformations and slightly higher risk of obstetrical outcomes. Again, the confounding factors have not been controlled, and zolpidem again is one of those drugs that has an interesting pharmacokinetic, pharmacodynamic process. Therefore, it has different recommended dosages for women versus men. So that's something to keep in mind. When it comes to the other meds, which we're talking about sort of the Z drugs in general, there was Swedish birth registry data in 2011, and they looked at quite a few infants, and they didn't feel like there was a huge increase in congenital malformation. So it was 3.1%, which doesn't beat the absolute risk. So that's the other keeping in mind. So it doesn't beat the absolute risk. We don't think based on that study that there would be a higher risk of congenital malformations. In the Taiwan study, they had about 2,500 infants exposed to zolpidem. They also did not find any risk of malformations in them. They did find an increased risk of low birth weight, preterm labor, gestation, small for gestational age, cesarean births. Again, they did not make any controls. And then realistically, when you look at data sets for sedatives, moms who are on sedatives tend to be older and tend to be smokers. And they found that that was definitely a scenario in that patient population. And those two factors alone can also be confounding factors and be associated with preterm birth and low birth weight. Additionally, there was not a lot of commentary on like frequency of use, daily use versus as needed use. So realistically, we have signals, but not really enough to say we have guidance on risk of malformations. So to conclude, the way I would talk to a patient about this is we have some data that says that there is some reassurance for congenital malformations for babies. However, when it comes to other gestational outcomes, the data is not clear because the confoundings are not clear. And we can't really fully rely on them because of that limitation of the data set. Once you've done that informed consent and the mom chooses to do so, I think that is another piece. I would document that very clearly. We had this discussion. Mom expressed understanding and has elected to use them on an as needed PRN basis. And we're also trying other things. There is sedating antihistamines. They're widespread in terms of like the use of diphenhydramine, hydroxyzine, doxylamine, and they're used in pregnancy for anxiety, sleep, pruritus, nausea, vomiting. And despite the widespread use, we don't have a lot of data. Like I can't quote you meta-analyses or systemic reviews that say, we've studied this and these patients are safe from a congenital outcomes framework or a gestational issues. However, from what we do have, they don't appear to be related to congenital malformations. And I'm kind of partial to doxylamine myself because it'll help with the nausea as well. And it's short-lived. Trazodone, another drug that we've discussed earlier today, it can help with sleep continuity. We don't have any data that studies it as a sole agent in pregnancy. So most of the data sets we have are studying trazodone along with an antidepressant or trazodone along with any other and psychotropic medication. So in those data sets, we didn't find any increase in birth defects with the trazodone exposed babies, knowing that they had an exposure to another medication throughout. And then the limited data sets that we do have that are using trazodone in combination with other antidepressants will state that trazodone is helping reduce postpartum depressive symptoms when you're giving it for insomnia treatment. Breastfeeding, we don't have a lot of adverse reactions reported. We have about, the data sets that I'm saying are very small. So like 58 exposures in 2003 data set that had 2 malformations. So they're not huge data sets. There's not a lot of exposure that you're kind of counting on. And breastfeeding data that we do have, case reports, et cetera, seem to be very reassuring. Another medication that we tend to commonly consider, mirtazapine. Mirtazapine is a beautiful med on its own. And it's an old med, but even then we don't have a lot of systematic reviews. I think the most recent one was in 2016. The reason that I tend to reach for mirtazapine is hyperemesis gravidarum. It's really helpful. So on its own for hyperemesis gravidarum, doses of 30 milligrams have been shown to have efficacy. Treating hyperemesis gravidarum tends to help with mood and anxiety on its own. And because it's available as disintegrating, it can really be helpful in terms of just a reasonable day-to-day perspective of it. From what we do know from the data, there's no incidence of major malformations with mirtazapine, and from a lactation perspective as well, there's no concerns for like sedation or neonatal outcomes in that scenario. And for long-term neurobehavioral outcome, we only have studies up to like 12 months of age, and they don't note any concerns either. I'll go quickly through sort of our alternative treatments, and we're gonna start to pause. Buspirone, which I'm sure most of you are familiar with. Human data is limited, and animal data shows no congenital malformations. In this patient, you would also consider maximizing the use of her SSRI just to make sure that her treatment for anxiety and depression is adequate. People have also used antipsychotics such as sertraline and such as Seroquel for management of insomnia. Seroquel, actually, out of the second generation antipsychotics, has the lowest placental passage and the lowest rate of transfer into breast milk. You would have to counsel with regards to kind of the risks that apply in an antipsychotic class anyways, but those are the considerations. Another big one is melatonin. And melatonin is kind of a dearth of data. We're really hoping over time, because a lot of studies are happening right now that are trying to figure out if melatonin can mitigate placental oxidative stress. And that's really getting studied actively. However, we don't really have a lot of data right now. And we know that it has roles in sort of fetal maturation and onset of labor. And so I tend to stay a little bit away from melatonin because we just don't know what it's doing. Realistically, a melatonin dose of 1 to 3 milligrams is elevating blood melatonin levels up to 20 times the normal. And then, and most of the time, you're not really looking at a circadian rhythm issue with pregnancy as well. So I would keep that in mind. So coming back to Daniela, she's now 36 weeks pregnant, and her spouse comes to the appointment and is very worried about her. He said last pregnancy was really difficult, and she got really worse after delivery, and identification of what's happening, making sure she got care, time for the medication to work, everything, all of those delays made things worse. He's comforted that she's on the Prozac this time, but he wants to know, is there anything quick? Like if she gets that bad, that severe, she was close to suicidal, she'd expressed suicidal ideation at that point, what would you do? What would you suggest? And in that setting, we kind of have a newer medication. Brexanolone was FDA approved in 2019. And it's basically an IV delivered analog of allopregnanolone. And it's very exciting because it's a very different new style of medication. And a lot more follow-up studies are happening in terms of figuring out how to use that molecule. And the reason why it's kind of cool for us is because it's rapid onset of benefit. And within 5 to 6 days, you're finding an onset of benefit and efficacy up to 30 days. So for that patient that you're like, I'm going to start the Prozac, but I know it's going to take a few weeks, Brexanolone is something to consider. The problem is it's IV. You need 5 days of continuous IV, so about 60 hours. So you need to be hospitalized. It's expensive. It's hard to get insurance approval. But for those of you that are in Tucson, Arizona, we have the Tucson ER will provide Brexanolone, and CR Tucson here in Tucson will also provide Brexanolone. So I'm going to pause here and kind of talk about resources for both patients and providers, and then see if there's any questions. So in terms of resources for both patients and providers, Postpartum Support International is a great resource. For patients, they have a lot of groups online, as well as consultation, as well as comfort options. And when I say lots of groups, they have like 35 groups, anywhere from like, Desi moms, because I am a Desi mom, or fathers, and groups for fathers, groups for for parents with NICU babies, groups for perinatal loss, pretty much any subset of a population that you feel like you identify with. PSI has an online group for your patients. For providers, they have a psychiatric consult line. They also have a provider directory. So if you're not comfortable with managing it, you can go look up who in your area is close and who has sort of the the prenatal mental health certification as well. And they have an annual conference that kind of goes through both therapeutic considerations, management, and evaluation. And for those of you that are like, I want to learn more, this was not enough, and you talk really fast, all of that is true. And so for further education, I would suggest the MGH Center for Women's Mental Health. There is the National Curriculum for Reproductive Psychiatry, which is a free online curriculum that is geared. There's a 5-hour version, and there's a couple of subsets of deeper discussion topics and modules that you can either use to educate yourself or educate your colleagues or your trainees. And then you can always consult depending on the state you're in. There's a couple of perinatal access programs across different states that will offer consultation. There's bioethic committees that you can refer to, or risk management as well. For looking up, I would suggest having LACTMed as an app on your website, on your phone. LACTMed is NIH grant run, and so it's very up to date and current. And so you can always figure out the breastfeeding considerations here. And then reprotox is also, so mother to baby, mother risk, those are all considerations here. I'm going to pause here. The rest of my slide deck has resources that are local to Arizona, and those will get sent out to you. So it has kind of resources including like, diaper banks, breastfeeding, in-home family supports. So I won't belabor everybody with that discussion here, and pause to see if there's any questions. I know I talk fast.
No, Dr. Kaya, that was amazing. That was a real tour de force. I have a question for you. So now many of the primary care providers who participated today should feel more confident in taking care of psychiatric conditions in their pregnant or breastfeeding patients. But what do you recommend? When should they refer to a specialist like you?
I think if they're not comfortable with the management, they should refer. And I think we can kind of manage referral in multiple ways. Because there's very few perinatal psychiatrists, most of the time what I'll do is I'll clarify if they want me to take over the case or they want me to consult. And consult turns out to be a lot more efficient, if you will. So if you have diagnostic uncertainty, or if you have a patient that's failed 2 or more medications, I would refer out, and you can either do consultations and take over the patient again, or you can refer for management. The problem, of course, becomes getting patients into care. And so that, I think, is probably the biggest challenge. Within the Banner system, we try to make sure that we can get patients in within 3 to 4 weeks, because that's important, because most of the time you're waiting 3 to 4 months, and that's a long time in pregnancy world.
Yeah, well, 3 to 4 weeks is still 1/9 of the pregnancy, so that's still a long time.
It's still a long time. And so I think if you have local local colleagues that you're comfortable with, having a good somebody you can call really does help. And so I have a lot of colleagues, NPs, midwives in the Tucson world that will just call and say, hey, what do I do while this person is waiting to get in?
Well, people are posting that they want copies of these resources, and so that will be available when we send out
it's like 10 slides worth of resources, so I didn't want to torture everybody, but once you get the rest of the slides in terms of other considerations for in-home support, all of those factors will make a huge difference to the parent. I will also say, as the primary providers to the patient, keep in mind that social factors help. So if you're supporting time off, or you're allowing them to take FMLA, that really does make a difference.
There's another question here. Can you speak to virtual behavioral health programs like Curio being FDA approved, if you're aware of these?
I'm not familiar with Curio. I will say that there's a couple of behavioral health programs that are very CBT focused that I think are really valuable. The other, because they do a good job in terms of delivering sort of cognitive behavioral methods, they do really well for those conversations. I also think it's always important to kind of encourage patients to engage. So what we found in COVID was higher rates of maternal depression and maternal anxiety disorders, and isolation was a big factor. So engagement, recommending whatever your local OB practices and midwife practices will just tend to have patient support groups. So I think that piece, I will look into Curio, but I will have to admit, I don't really know much about that one.
Okay. So we are thank you so much, Dr. Kaya, that was great. We're a couple minutes over, and we're going to enter our last session, which is an Ask the Expert with Dr. Kaya and myself. I'm going to suggest that we take a 60-second break in case people need to just take a quick break, and we'll see you back here in a minute. We are back. We're so grateful that people have stuck around all day. We've tried to keep things on track and as engaging as possible. Please start sending more questions in through chat, and we will address them as best we can. And I'll start now. So, and this will be directed for Dr. Kalia. What do you do as a provider when your mom is showing signs of postpartum depression and declines therapy?
I know this is such a difficult one because it's multi-layered from the patient perspective. For me, it becomes an aspect of education about the risks and to both the patient and their supports, making sure that that you're bringing that up, because depending on the visit, they may not be open to it. That's not the time for them to hear it. So making sure that they're exposed to that. And at the very least, considering if they will not consider therapy formally, will they consider a patient support group? Because I think from sometimes hearing it from a cohort that is their own will be a lot easier for themselves.
I think that's a great approach, and it's consistent with what Dr. Len said in his talk. It's about how you deliver the message and what matters most and is most acceptable to the patient. So I posted a comment earlier when you were talking about the negative effects on the fetus of a depressed mother. And do you have ideas about how a depressed mom can lead to low birth weight or premature delivery? Is it because of high levels of stress hormones, not taking care of other medical problems, epigenetic changes?
I think that's such a great question. And that's been studied because for initially, when you look at sort of the perinatal psychiatric data, the answer is hormones. And that doesn't always bear out. So initially it was like estrogen is causing, the lack of estrogen postpartum is causing this. And so there were very cool nuanced studies looking at that in terms of, is it estrogen sensitive, and what's going on? So we don't know in terms of either is it hormonal or is it any other sort of particular conversation here. What we do know is that the stress pathway does become a significant issue. And part of the reason that is pregnancy in itself is a dramatic change in, physiological considerations. Like your cortisol levels during pregnancy, by the time you're hitting the third trimester, are kind of close to the level of, disease. And so realistically, you can't eliminate the fact that pregnancy is a high stress condition on the patient as well. And so we don't know clearly why things tend to get worse in both the pregnancy and the postpartum scenario. There's definitely epigenetic considerations for the child as well. The other aspect is the postpartum period is rife with stress because, again, huge disruption physically, as well as from a sleep perspective and a rest perspective. And we don't have a lot of mechanisms for support, especially, parents they're more nuclear families, having that sleep supportive. So there's so many psychological, biological, and social factors that play into it that become quite challenging.
Thank you. Yeah, that's great. Here's a question. How do you assess for underlying bipolar disorder before initiating an SSRI or other antidepressant for depression? I always struggle with finding the right language for screening for mania. When I'm in clinic, the language I use before starting an antidepressant is just to ask, have you ever been the opposite of depressed? Euphoric for days at a time, not needing to sleep. People thought that you were talking too fast or engaging in unsafe behaviors. Really, the cardinal symptom of mania is euphoria or prolonged mixed state with excessive irritability that's not just depression. So becoming familiar or comfortable with this sort of language should be routine before prescribing all first index antidepressants. I don't know, Dr. Kalia, if you had anything to add.
No, I completely agree. I think it has to be a matter of focusing on the opposite, elation, not just happiness, and also irritability. So some patients will have that elevated mood, but some will say, I've never been happy. What are you talking about? And so irritability is another factor that I will ask about. And if other people have remarked about it to them as well. And most of the time I'll get the answer of, yeah, college. And so at that point, I'll say, was it sustained over a couple of days? And, how long did that last? We've all had college days where for a day or two, maybe we met the criteria, but it has to be sustained and you have to meet it over time.
Thank you. Yeah. I'm going to request that you respond to this this question first. This is such an important question, maybe particularly for primary care providers because they're seeing these patients the most. I had a patient whose partner was controlling and perhaps abusive. What is the first step in helping the person who's being victimized or abused?
I think that's such an important question, especially during, and I'll say this from the perinatal perspective, interpartner violence tends to increase in pregnancy. And so that's definitely, even if it wasn't something you were screening for before, you're going to screen for in that time period. Women are in various stages of acceptance of the fact that something is happening to them or willingness to change. So the main piece becomes providing psychological safety, that you are a safe space for them to be able to say, this is what I want to do, or these are the resources, have available resources for them, and open the conversation on various levels, depending on personal safety can be less important to a woman, but child safety can be another. And abuse and violence in that time period isn't always limited to just physical. Financial is a big one. And so screening for that piece as well, because that can be a limiting factor. And so, and I mean, this is a talk on its own, but I think having a nuanced conversation in terms of what this looks for you, sometimes having a very gentle conversation also enlightens the person themselves that something is going on. And then making sure that you're a safe space and having a discussion on these, there's resources available whenever you want to talk to me about them. I will talk to you, or I can give them to you if you're open to it.
Thank you. So there's a question here. Should patients on medication for ADHD, I assume they mean stimulants, be required to submit urine drug screens and or be required to attend therapy as a condition of treatment? In my practice, if I'm concerned that somebody is going to be abusing, misusing, or diverting stimulants, then I won't be prescribing them. I do not routinely get urine toxicology on patients that I prescribe stimulants for. I would be more concerned and more likely to use urine toxicology in adolescents or kids who I'm concerned may not be taking the stimulant as prescribed, and I want to know that. They may not be telling the truth. And if I'm concerned about substance misuse, I would prescribe a non-scheduled drug such as bupropion or atomoxetine. Dr. Colley, what do you think?
I completely agree. I had the joy of being a college psychiatrist for a year, and it was hilarious the amount of people that would try to use stimulants as their source of funding, like their life. And so coming in. And so I don't have a very punitive approach to ADHD management, because it is a real disease with real serious outcomes. And so figuring out why it is that you're worried about this patient, and then there would be indications to consider urine drug screens. I'm wondering if this is about somebody with a history of substance use disorder and on ADHD and considering urine drug screens and that. And so I think you would have a nuanced approach to both managing the substance and then figuring out what medication you would use in that patient with ADHD. So it wouldn't necessarily always be a stimulant.
Thank you. So there's a question here that really intersects both of the last two talks. Any advice on treatment of women with ADHD in pregnancy?
Yes. Treat it if it's indicated. ADHD can vary from like mild to severe, and severe ADHD is a problem. Like people have trouble functioning. And so I've definitely had patients who I've treated with their ADHD throughout pregnancy. The problem again becomes data sets. So Ritalin versus the amphetamines are very different data in pregnancy versus very different during breastfeeding. For example, and this is a very small snapshot, and please realize that I can't cover all the nuance in like a 1 minute answer. Ritalin tends to be a little bit more signals with congenital outcomes and risks of miscarriages in our first trimester, except Ritalin postpartum in breastfeeding is like barely there in breast milk. And so Adderall, limited to no concerns from a congenital issue, from a preterm birth issue, from a low birth weight issue, except Adderall formulations about 10 to 12% present in breast milk. And the American Association of Pediatrics tend to say anything less than 10% we like better. So that probably is a quick answer.
That's a great answer. And that's actionable because stimulants can interfere with appetite. And I imagine that it could make the baby less hungry and less likely to latch and feed.
Yeah. And seizures. Moms tend to worry about seizures. The biggest question I get is if I take ADHD meds, during pregnancy, will my baby have ADHD? And my answer is your baby has high risk of ADHD because you have ADHD. The exposure to the stimulants is not going to make a difference in that association. And that's we've studied over time, that those babies that are exposed to stimulants have the same outcome risk of ADHD as moms with ADHD without any stimulant exposure.
So here's a question from my brother, writing in from Western Pennsylvania. If you do urine drug screening for patients with ADHD, how do you handle specimens positive for cannabis? I'll let you go first, Dr. Kaya, and then I'll speak.
So the cannabis data with ADHD is, in the ADHD world, is kind of cool, right? So there's increasing data saying that people who have cannabis use disorder should be screened for ADHD because patients with undiagnosed ADHD have a higher use of cannabis, and that if you treat the ADHD, the cannabis use will decline. It's coming out in the last few years. So what I tend to do is just say that we know this is people who have undiagnosed ADHD tend to have cannabis use. Cannabis doesn't really help in controlling for ADHD. So I would want to make sure that we're managing your disease without taking away from the management in itself. So you'll need higher doses. I'm not sure that that's a good idea. And kind of normalize it, that it does happen so that it's not like a shame and blame kind of a scenario for those patients, and focus on the idea that the cannabis isn't necessarily helping their ADHD symptoms.
I would agree. And so I would quantify how much cannabis they're using, because heavy users will come in at times and say, I really have trouble concentrating. I think I have ADHD. And my response is, well, I think that you're smoking too much pot, and that's probably why you're having trouble focusing. So that would be my first approach to either a harm reduction or an abstinence approach to see if that improves their concentration. So here is a question from Dr. Harrison Monroe. For patients with schizophrenia, how would you manage conversations about changing or discontinuing antipsychotics because they have concerns that this may represent a danger to the fetus?
I think it's a matter of discussing the risk of medication discontinuation. So for example, the risk of medication discontinuation in pregnancy is associated with high rates of recurrence, right? And we know this in antidepressant discontinuation, you're looking at about a 30% rate of recurrence. In by mood stabilizer antipsychotic discontinuation, you're looking at about 60% risk of recurrence. And so at that point, you're talking about medication discontinuation, the risk of recurrence, risk of a psychotic episode, and I'm also going to add in manic episode, even though I know Dr. Harrison Monroe, that wasn't part of your question, because at that point, those patients are well aware of the amount of medication exposure they get if they're in an uncontrolled episode. And again, the point is to understand what the patient's fear is. If it is, I don't want to take this much medication, it's too much, you're already going to try to make sure that they're on a lowest but effective dose. So you're effectively treating and discussing the risk of the medication class. This is second generation antipsychotics as a class have a lot of data that say that they're reproductively safe in terms of congenital outcomes for the baby. The gestational outcomes in that class are present, right? Like increasing maternal weight, gestational diabetes. So those are class risks, but not to the baby. And so that's also another matter of what is the fear, and kind of clarifying what that patient's worry is. Is it about myself? Is it about the baby? I'm okay if I decompensate. I don't want to have anything happen to my baby. Then bringing it back to it's still going to be a risk to the baby, because an antipsychotic episode or a manic episode is a huge stressor to the maternal system. And we already know so much data with regards to stress and its impact on the fetus. So I think having that clarification of what the fear is, reassurance that you would be available and you're not going to do anything to harm the child, and kind of review what we do have. And then depends on the med. So Seroquel, as I said, has the lowest placental passage. Olanzapine has a pretty high placental passage, and go from there. The only thing I will add as a caveat is don't breastfeed on Clozaril. But that's like, if you take nothing away, don't breastfeed on Clozaril.
Thank you. There's a question here. Is there a screen for bipolar? And I can't think of the name of one off the top of my head, but it brings up an important question of what is important to screen for in primary care settings. Depression is common and anxiety is common. Bipolar is a real problem. It's not as common. So we shouldn't be doing universal screening as much as we do for depression. But asking some targeted questions, like I mentioned earlier, have you ever been the opposite of depressed, sustained euphoria or irritability? When you're concerned or when you're going to be prescribing an antidepressant, or if somebody's depression is not getting better despite repeated trials of different treatments, they may have a bipolar depression and they require a different approach to get well. Dr. Kalia, do you have anything to add?
I think I would also say anxiety disorders. Technically, they're the most prevalent mental health conditions and can really be debilitating in terms of just the day-to-day life and living with an anxiety disorder. And treatment does work with those. So I would consider, if you're going to say do a PHQ-2 in your office, I would throw in a GAD-7.
Mm-hmm. I think that's great. So I don't think that people are as aware of the PHQ-4, which is a blend of the PHQ-9 or the PHQ-2 and the two items from the GAD-7. And that can be a pretty efficient approach to implement in primary care settings because it's evidence-based. It's replicated and it assesses both depression and anxiety and, as an initial screener that you could follow up on. And yes, the screen for bipolar is the MDQ. Thank you for whoever posted that. Yeah. I'm just looking at the time. We're doing good. Any suggestions on approaching deprescribing in geriatric patients who have been on multiple controlled substances like zolpidem, benzos, and opioids concurrently, who are new to your practice and who are hesitant to this suggestion? So if they're new to my practice, if I don't know them well and things are stable, I don't think that they are a fall risk right away, they're cognitively intact enough, I will get to know them better before I start to deprescribe. I want to develop a relationship and a rapport with the patient, have them trust me and know that I have their best interest at heart. And then it's an ongoing conversation over the next year or so about systematic deprescribing. Dr. Kalia, any thoughts?
No, I think that's such an important thing because I think most of the time patients are so afraid. Half the time they'll come in and be like, don't take away my meds. They are what work. And there's a reason they're so attached because they do work and they will trust you over time. So the rapport building, that investment in relationship is really going to pay dividends over time.
Dr. Henry wrote, how often should we be screening for anxiety? Every visit, every physical? No, I mean, I think that depression and anxiety screening probably should be done every 6 months, or if there is a major life event or a new or scary medical diagnosis. So if somebody has a loss of a loved one, of a partner, they've lost their job, they've retired, they've moved, they're diagnosed with cancer or diabetes, these are times to ask about these common psychiatric problems, or just make it a biannual assessment. Dr. Kalia, what are your thoughts?
I think you're completely, I have nothing to add.
Okay. Well, then you take this one first. Any thoughts or opinions on prescribing antidepressants, anxiety meds, or other CNS depressant meds while a patient is on Suboxone? I have a large patient population on Suboxone in my primary care practice who are also on these types of meds. What do you think?
I think with Suboxone, the one sort of meds that I would worry, the class of meds that I would worry about is benzos. But primarily not anything other than benzos in terms of like antidepressants or gabapentin. But only benzos are coming to mind for me, Dr. Karp.
No, I would agree. I mean, I'm sure that in your practice where you're taking care of a lot of patients with Suboxone, and thank you for doing that because more of us need to be doing this. You have a solid protocol in place of not prescribing benzos, and when you get your urine toxins, if they have a benzo in it, that you have a discussion about whether Suboxone is the right and the safe medicine for them. Dr. Kaya, you take this one first. What's a good option to change to when trying to wean a patient from alprazolam? As a new family nurse practitioner, I am trying to absorb a lot of this information. That's a great question.
That is a fantastic question. And I'm going to assume you mean the alprazolam short-acting med. I tend to go for sort of, I'm going to assume you've done the harm reduction conversation. The patient is ready and agreeable to transition off of the short acting onto something longer acting. There's a few great benzodiazepine converter calculators online. And so if I'm going to switch from alprazolam, I'd probably try to take whatever the current alprazolam dosage is per day and switch it into an alprazolam ER or clonazepam if I can. So really, harm reduction, the first step would be to kind of change the formulation from a short acting to a longer acting, because that is easier to get off of. And I would try to keep the dose the same, the first step wise. And then once I've kind of slipped on to switch that frame work, then kind of slipping down on the alprazolam ER doses. And I use alprazolam ER, not because it's better or any different than clonazepam. It just is comforting to patients when it goes from alprazolam to alprazolam. Literally, that's the reason. It just provides them more comfort. And I do have a couple of like benzodiazepine converters bookmarked because I tend to forget. And so I tend to always make sure my calculation, my math is right before I do this, and kind of say, we're going to keep the dose same. We're just changing the formulation. We're going to go from there.
Thank you. So in caps, somebody wrote on the Suboxone note, how should marijuana plus tox screens be handled? These are great questions that all of us are challenged by in the clinic every day. So personally, I mean, many patients are already have your positive marijuana tox screen when we start Suboxone. That is not a hard stop for me in my practice, as long as there's always Suboxone in their urine and there's nothing else. Some of these patients say that it really keeps them from or helps them to manage their chronic pain or any other craving they're having. And I'm not so worried that there's going to be some synergy between the marijuana and the Suboxone that's going to slow somebody's breathing down. So it's okay with me, but everybody has a different comfort level. And Dr. Colley, I'd like to hear yours.
I think harm reduction is kind of the goal here. And so it matters what if there's presentation wise that there are concerns that you're worried about the marijuana. So say, you're finding that this person's using excessive amounts of marijuana and that is tripping, that is worrying you. And from that perspective, I would ask, why do you feel the need to use this? Like, what is it doing for you? What is it helping you with? And how can I help to make sure that we are supporting you in this journey as well over time? Because marijuana is such a complex topic for all of us. And there's emerging data from like its effects on psychosis or effects on brainwaves and like long-term data that's kind of mixed and confusing. So I would go with, I don't have a reflex like no marijuana, or I'm getting rid of your Suboxone. Why are you using it? What is it doing for you? And go back to like, is there untreated symptoms that the patient is managing with that you might want to consider treating?
Okay, thank you. All right, we have, this will be the last question that we're going to take. And I think it's a great question. I often have patients who are prescribed Seroquel for insomnia after leaving a treatment center. And I will say that it's not just added at treatment centers, it's also added in primary care and in psychiatric clinics. Can you comment on its appropriateness for long-term use and maybe some language about discontinuation of the medication? Seroquel or quetiapine is not a hypnotic. I think that when it is prescribed off-label like this, we are setting patients up for metabolic problems and tardive dyskinesia, and I do not use it as a hypnotic. I do use it as an antipsychotic, and I use it as an antidepressant augmentation agent. So if somebody has a depression and they're treated with an SSRI or an SNRI and they have bad insomnia and you want to augment their antidepressant, you could add Seroquel, but usually you have to get to about 200 milligrams for it to have an antidepressant effect. But really, I would encourage listeners to try to avoid or minimize the use of Seroquel as a hypnotic. Dr. Colley, anything else?
Absolutely. And even if you're using 50 milligrams of Seroquel, there's nothing to say you don't have to do any of the screenings. And I think that also becomes a challenge. People are using small doses of the Seroquel as a sedative, and they're not monitoring HbA1cs and lipid panels, but there is nothing to defend you in court if you're not monitoring it. So you really have to. And I think having that discussion with the patient saying, you're on this med, we're going to make sure that all of those things are monitored and checking your blood levels for all of these risk factors, or we can consider another medication that maybe does not come with all of these risks, tends to be easier.
Thank you. I agree. I'm not going to open up the last question to discussion. I just want to say, if you have a patient who comes to you on 3 or more CNS meds, have a discussion with them that this may not be the best approach for them long-term, and see if you can talk over the phone with their psychiatrist or prescriber, or recommend that they find somebody else to take care of them. So I'm going to end the Ask the Expert today. I want to thank all of the participants. I mean, we still have almost the full group on here. It is a Saturday. This was 6 hours, and I'm just so impressed and grateful to all of you for hanging in there. I want to thank Dr. Kalia, who's been on since the beginning. She served on the planning committee. She gave a talk. She did the Ask the Expert. So thank you to her. I again want to thank the planning committee and Banner University Health Plans for their very, very generous support. And finally, I need to thank Jamie Manser, without whom today's meeting would not have happened. She is a detail-oriented and flawless executor of events like this. So many thanks to her. Jamie put up I think she put up the link.
Yes, she did.
She did. Okay. So please click on this link, provide some feedback, and fill out the evaluation, and then that will take you to the link to request your CME, and we will get the CME certificates to you hopefully by the end of the month, or certainly within the next 4 weeks. You can also take a picture of the QR code there, and that will take you to the evaluation as well.
Dr. Karp, thank you so much for spearheading this idea and getting it executed. This was great. I loved it, and I learned so much as a psychiatrist. So
I learned a ton too. Yeah, no, and we have it recorded so we can continue to share and disseminate this, because it's important stuff we learned today.